Okay, can you hear me, guys? Not like this. I mean, on your audio. Audible? Perfect. Thank you.
Hi Pablo. Hi Domenico. Great to have you guys. Who else is there? Dr. Muthukumar has joined.
Good morning, good afternoon to everyone.
Good morning, good afternoon. Yes.
Yeah, for us it is like mid morning.
Yes, yes. Hi Pablo, good to see you.
He replied on chat.
They may not be able to respond to you.
No, it's okay.
Hello, Ashish.
Hi, Ita, how are you?
Fine, thanks.
So nice.
Hi, Geeta. Hi,
Hello.
Ashish.
Dr. Depujari, you are becoming like Modi. Just lift your head. Lift your head.
Yes, it is.
Oh my God, you should come to Delhi. You will be, the farmers are looking for you.
That's why I'm not coming there.
You are looking like Modi. Just take off your specs. You are looking so cute.
Yeah. I think I should be contesting the next general elections.
Bilkul, bilkul. You are looking so cute.
Nice to see you, Roman and Imad.
Hi, good
Most
afternoon.
welcome.
Now I recognize you after this talk. So, a little
Voice
bit.
hasn't changed very much.
I think this is the effect of Corona pandemic. On all
Just
of,
made everybody lazy.
yeah, that's true. Great.
Hi, Imad.
Hi, Surya. Good to see you.
Good to see you. Dr. Shekhar is only, he's not shaving this. I have to shave both.
You are not cost effective, perhaps.
Yeah.
Hello, everybody. Do you hear me?
Yes, Roman.
Yes,
Oh,
hi, Roman.
Nice to see you.
I'm glad. Hello.
Hi,
Hello.
Roman. How's Ljubljana doing?
Oh,
Hi
it's
guys.
good. No snow.
Oh, good. Is it cold?
Yeah,
And how's COVID in Ljubljana?
it's no snow, 4 degrees. It's winter.
We'll go live in about 13 minutes. But nice to see a lot of friends, and I mean, there has been a very good response. I hope people join us for actually the sessions to hear all of you. But there has been an overwhelming response, I must say. Your anatomy committee's program starts on Tuesday, right?
Oh, yeah, after your meeting.
Yeah. Thank you for that. But it's
Yeah,
a very large
I
and
took
extensive
this in
program.
consideration.
Yeah.
Yeah, because almost some of your speakers, they will be speaking to my meeting as well.
Well, I have missed on Vlad, though, I must say. Dr. Lokendra Singh, very nice to see you.
Hi, hello,
Thank
how
you
are
for
you?
joining us. And you will be one of the chairpersons for the first session. So introduce any one speaker. I think Geeta is introducing the first speaker, and then you will take turns.
Thank you.
And the idea is that the moderators will tag one speaker so that they will take questions for one speaker each.
Fair enough.
Yeah.
I will tag the one I'm.
You will have problem, Geeta, in pronouncing your topic of your first speaker.
I'm not going to say it.
Anil has this peculiar habit of finding some words which you have to really look it in Wikipedia or a dictionary.
No, I'm just going to say he's going to talk on the historical aspect of neuroendocrine.
I have to send him a message. He's the first speaker, so he should be here.
No, but you can speak just a you can decipher it in your sentence. That's it. Don't speak.
No, so I will handle the questions for him if there are any.
Great.
I'm
Actually,
introducing him. Are we doing questions after every talk?
No, we'll do it at the end. You just keep a track, and we are encouraging all the speakers to answer question in the chat box, so that we are not left with too many questions at the end.
All right.
Dr. Chaco, I saw the meaning of this word in the net. It is actually longingness for the lost, which is lost in the past. It's an aboriginal word.
Oh, I see. I won't attempt it. It's okay.
I must say that I did not realize the time change, and I thought I have given enough time for our American friends, but many of them are going to wake up early morning for this.
I don't think they mind, Chandra, but for the weekend, perhaps they mind.
That's right.
I know the American for the regular working day, they usually start early, and they want to finish early.
They usually start by 6 o'clock, 5:30. Yeah.
Hi guys, this is Ari here.
Hi, Ari.
Hello.
Dr. Chaco.
Hello everybody.
Hi, Ari.
Actually Geeta and I are going to be using the same laptop because we are in the same center.
Should not be a problem.
So between the two, because we are one after the other, while somebody is introducing me, is it okay if I just get my talk up straight, or
Yes,
you want to
yes.
have a mugshot of my face?
We'll just show one slide, if you don't mind, of your name and then you carry on.
Okay, so I don't need to have my face up here and smile at everybody.
Not necessary if
Great.
you do not want to.
So then I can just switch from her talk to mine straight away.
Okay.
All right then. See you shortly.
Yeah.
Close the video.
Vikram. Lokendra, when the computers are being changed, during that time, a slide will come for introduction of the speaker, and you can introduce the speaker. For you, Geeta.
Yeah,
and,
I think we'll go one by one. That
yeah.
will be better.
And I think, has Dr. Falbush joined yet?
He was supposed to join at, he joined by 4.
Okay.
7 minutes more.
And Dr. Nosp is also there, right? These are the four these are the four moderators for the first session. Yeah. तू भेज दिया ना डॉक्टर सर्वेडी का मेल भेज दिया?
I'm just testing my earphones. Do you hear me?
Dr. Roman, you're talking.
I'm just testing earphones.
Yeah,
Yeah,
you can be heard well, Roman.
It's a message from Franco Servade. I think he was sending a message. Did you see it?
Yeah, we're just upgrading him to a panelist, so he should be able to speak.
Okay. Can you hear me now?
Franco, yes. Good morning.
Good morning to everyone. Morning, afternoon, whatever it is.
Good morning.
For everyone. Nice to see you all.
Same here.
Good to see you. Same. Franco, are you on travel ban or you are managing in Italy?
No, I'm managing in Italy. I cannot move. Where can I go?
Just in the area of Milano, yes?
No, we can move within Italy. Now I am at home. It's about 3 hours from Milano. But We cannot go anywhere. Hello, hello.
Chandra, do you hear me or see me?
Professor Nosp, yes, we can hear you.
Yes.
This is
Yeah,
Vikram Karmarkar here.
I joined you. That's
Yes,
great.
thank you.
That's
Thank you.
the
Good to have you.
first step. Great.
Yes.
Great. Well, greetings from Austria. Presently, I'm in Salzburg. We have some snow here, and it's great to see here, and we can discuss for our problems. Okay.
Nice seeing you, Engelbert.
Iman, great.
Nice to see you, Professor Nosp and Professor
Yeah.
Sarvedi.
Yeah, great. Thank you.
Yes, Franco, we can hear you.
Private chat.
Okay. किती वेळ आहे रे? 3 minutes. Great to see you, Professor Sarvedi.
Hello. Hi.
Nice to see you too. Nice to see you with this microphone up and down, up and down. It's difficult.
Hi. Hi, Franco.
Hi, everyone. Again, my best wishes to everyone.
Thank you very much, Franco. Thank you.
Sandra, I can be with you for 1 hour because after that I have a ENS duty.
I understand. So, you just say a few words, give your talk, and then after that, whenever you wish, you can retreat.
Yeah. Okay, but an hour, I will be very happy to be with you until the other meeting will start. Now, I can tell you 1 minute, everything is free. Nobody pays anything. So on Saturday, we have meetings from all over the world.
Absolutely.
So, but this is good. This I appreciate. This is something that we have to do to our community. I'm telling you another thing. You may receive emails faked from the World Federation. When you receive any email asking money in any way or anything, the World Federation, double check the sender, because the fake emails are now coming. The sender is President WFNS. My email is francoservadei@gmail.com, not President WFNS. So double check the sender. We are full of people who wants to make money. I don't know from where.
That is really
The last one from
unfortunate
yesterday.
part of the digital world.
Oh.
Morning, Franco.
Nice to see you, Imad.
Good to see you, Moody.
Well, Moody, hello.
You were skiing, or this is
I was skiing in the OR.
On the Saturday, you were in
very
the OR?
busy.
No, this is just came an emergency. So.
Oh, I would say so. No,
So I just wanted you to come in a little early. Sorry to drag you out, but
No. I'm in theater now, so we're good. The other rest of the team is carrying on. That's Amir operating there.
Great.
Hi, Andrea.
You have.
Morning, Mark. Good to see you.
Hi, Andre.
Hello.
Good morning, Franco.
Good morning to everyone. Moody,
Yeah.
Andre, the new arrival.
Hi there.
Hi.
Oh.
Thank you for joining. So nice to have everybody coming in. And Chandrasekhar, you really have to congratulate Krishna. He really has done a great job.
Yes,
Amazing.
yes. He's been really working hard. Apart from helping us in theater work and other work, he's also working.
No, he's done a wonderful job.
Through
He's
the
been
night.
reminding everybody. It's super. It's really nice.
And
And
answering all the
congratulations.
questions.
I mean, your team
I
has
must
really
say
put on
that
Thank you so much.
everybody has pitched in, and it's very nice. We have a very good attendance. Hopefully, most people should join us who have registered for the event. And I'm sure people will join maybe different sessions. So that is another thing which we have no control over. But there were so many other requests coming that we thought we'll also stream it on YouTube.
Yeah. No, it's great. It's great. And really, we've had a lot of support from the WFNS IT team as well. So
Yes.
really, we're very fortunate.
Oh, I think the webinars have been very well done by Teresa and this
Metin.
young man
Yeah.
who's been assigned Metin.
Yes. No, they've done a great job. They've really done they've done us proud, really. We're getting the credit, but they're the ones who have done all the work. Yeah. But thank you, Franco, and it's really you've really encouraged a lot of people across the globe, man. Thank you so much.
I'm very happy. I'm very happy that you're still working in these difficult times, and you
I know.
keep all of you. And I mean, as I will show in Latin, ex malo bonum means there is something good in this story of COVID.
Yeah, there is literally a silver lining to this dark cloud.
Yeah, and we start to see the end of the tunnel. Just only a small light, but it will become bigger.
Yeah. Have you had your vaccination, Franco?
Yes, we had also the second vaccination, which was tough. We got almost all of us, we got fever, and we didn't feel well for a couple of days, almost all of us.
Great.
Now
Anil has joined. Welcome, Anil.
Good morning. Good morning, Moody. Good morning, Franco. Good morning, Shaker.
Very good morning, Anil. I'm really sorry that all our American friends have to get up very early, even on the weekend.
Must be very early for you, indeed. My
It's we got up at 4:30. It's about 5:15. It's very cold here today.
Oh.
So it's freezing and there's going to be snow, so it's all good.
Yeah. Okay.
So we all searched your title in the dictionary and the Wikipedia.
How to speak it? How to pronounce it?
Erarit-jarit-jaraka.
It's a tongue twister.
Well, I got my second dose of the vaccine too, so we must have got it. And I tolerated it well, but I hope all of you can get it. And the numbers are really dropping pretty dramatically now in New Jersey. It's really dropped. Franco, how is it in Italy?
Well, we touch iron, as we say. I mean, things are going better, much better, and since a couple of weeks, we are fully open. We work 100% in neurosurgery, and we don't have as many as COVID patients as before. So situation is improving. We don't understand how long. Look at the UK. I mean, we don't know, basically. At the moment, it's okay. We are dealing with the COVID patients and with normal activity at the same time.
It's slowing down in UK, Franco. It is slowing down.
It's
getting better.
Ale, how are you?
Nice to see you, Henry and Andre. So nice to see you guys.
I am very happy.
Good morning.
for you.
Good morning.
Morning.
We have
We
seen
had
this.
our first vaccine last week. I think the second will come a month later, probably.
Okay.
Nice. We've read about the vaccine in Kenya for the second time. So
Oh.
we
In
just
Germany,
keep
we
reading
have
about
also
it.
problems. In Germany, we have also problems to get the vaccine. There's really a fight for the vaccination now.
Wow.
It's a real fight.
Now in our country, the strategy is changing on a daily basis. So now they have inoculated the 90+ senior citizens that live independently at home. And I didn't know that these are 60,000. So 60,000, 90+ age group were 60,000 and still living at home independently. And they have now been vaccinated. But the doctors are not happy with it. They say those people will never come to the ICU. If they get ill, they will not enter the ICU. Typically, the ICU is now with people between 50 and 70. They say that's the highest risk group, and especially those who are obese or have lung disease or anything else. And they are planned to have the vaccine in the last quarter of this year, so between September and December. And that's ridiculous. But it is changing constantly because AstraZeneca vaccine is not so good for them, for the elderly. So they are waiting for the others. But now AstraZeneca is not delivering the vaccine in a sufficient number. So every single day we hear a new kind of strategy. And actually we have only vaccinated, well, a little over 100,000 people of the 70 million here. So, and that is in 4 weeks' time. It's incredible. It's just
That's not
almost. I mean, all doctors and nurses and personnel, plus people, elderly people in residence and small hospitals, they all have been vaccinated. 1.7 million already got the vaccine in Italy. So it's working. The question is how to proceed now. And as you said, every day is changing.
Yeah.
The problem of the unions. The unions of teachers say we are first. Why? Nobody knows. But they're strong, so they want vaccine first. So,
but they wanted to order the vaccine as the EU for 27 countries together. And therefore, they were very late. Because to get 27 countries to decide on one thing, that is, and make one decision is more difficult when just one country has to do that, like the US or UK. They just say, we do it now, we buy it, and that's on. And now in the EU, it's good that it is not every country have to fight by its own, and that it is across the European Union. But you see, this is not always an advantage.
No, you're right. Right.
Yes, that's why they were very late with the ordering.
Exactly.
Yeah.
So it means we still will have webinars. We're still sitting at home, looking on screens and talk to each other for some more time.
I don't think a safe meeting will be in place until, we don't know basically, but at least after summer. I don't know, Anil, what do you think in the States? How is it going? Because we got invitation for CNS and WNS in person, but I don't know how it will work.
Well, we're unleashing the meetings from July onwards. So I think it's optimistic. Most of the neurosurgeons have been vaccinated. A lot of them have. So they feel, you know, immortal as always. We can go anywhere. But I think it's still going to be hard to do it. The CNS is going full blast. The WNS will probably move from Vancouver, maybe to Orlando, we're not sure. The academy will be in California. But, you know, the problem is institutions are not allowing us to leave. So my employee, Rutgers University, if I went to Florida for a personal thing, I have to self-quarantine for 10 days. That means you can't work. So, you know, basically we've been landlocked, which isn't a bad thing. I think academic productivity has gone up. So everybody's writing books and, you know, articles. So it's all good.
Well, I moved to Germany to my son. Moving to Germany the cost is one swab test on departure, one swab test on arrival, 1 week in Germany close at home, another swab test on departure, another on arrival, plus 10 days in Italy at home. So it's a question of 1 month to see my son and stay with him. A few days, I almost spend a month.
Oh my goodness.
And my throat was full of push, because any time the throat and up in your nose, and it was terrible.
How about Bogota? Is there any, do you think Bogota is a go for sure, or what is the feeling on that?
Go for sure. The other way around. We will discuss the 13th of March. This it was the Colombian people asked us to delay the decision, the final decision. At the moment, I don't see any way to go there, but at the moment, at least not a big meeting, maybe a local, an hybrid meeting, a local meeting plus the rest of the meeting in the web. We don't know, but it's difficult. It's difficult now to say that we go there in person, all of us.
Hello, all of you. I'm here. Udo Freibusch, greeting to everybody.
Hello,
Yes.
Udo. Hello.
Morning. Morning.
But the meetings are not so important. What is about the skiing areas in Italy?
Well,
you're touching the real
more important things.
Do they open in the mid of February or not?
Yeah, it will be open 12th of February if it's like this. But you have, as you do in the States, you have to book in advance hotel and ski passes and everything like this. We don't know. I have a house in the mountain, and it's the best year since years about snow, as you know, and everything is beautiful, but I can only see the webcam. The webcam showing me how beautiful it is.
So I accept a lot of the nasal swabs if I can go. Okay, gentlemen, I have to leave for some minutes and then I will be back soon. Good to see you.
Good to see
So
you.
we'll start in about 50 minutes, I think, officially.
So we go live in 3 minutes.
3 minutes.
In 3 minutes.
2 minutes. Yeah. Oh, yeah. 1:45. Yeah. Excellent. I will mute myself.
3 minutes. 看些图资料，我说妈，那个，大头发。
I think everyone should mute themselves, except Moody and Chandra.
Good afternoon, good morning, everybody. It's 4:15 and we are ready to start the WFNS NEUROENDOCRINE online symposium. I would call upon Professor Dr. Devpujari, Head of Department of Neurosurgery at the Bombay Hospital, to start the proceedings.
Dear colleagues, it is indeed a great honor to host this symposium on behalf of the WFNS committee. My co-host, Dr. Moody Qureshi, and myself, we would like to welcome all of you. We have got overwhelming response to this symposium with over 70 speakers and moderators joining us from 17 countries. And we have actually crossed 500 registrations and have therefore started simultaneous YouTube transmission. and we have attendance from 46 countries. So I am really very happy that many people can take benefit of this kind of an event. I would like Moody to introduce Professor Sarvadi, who has kindly agreed to inaugurate this session. Moody, please.
Thank you very much, Chandra and your team. It's an honor and a privilege and overwhelmingly pleased to be the co-host of this meeting. And really, your team has done a fantastic job. It is my pleasure to welcome all the panelists from across the globe who have joined. And I take this opportunity to thank once again Professor Franco Savadei, the very active and very busy president of the World Federation of Neurosurgical Societies. His support and his encouragement to all the societies across the world has been indeed superb. And really, for him to be able to take time and join almost every meeting that he's been requested to attend is really beyond my understanding, but well done, Franco. And with that, I'd like to introduce the president of the World Federation of Neurosurgical Societies to give the opening remarks and his talk at this superbly organized symposium. Thank you very much, Chandra, once again.
We would be honored to have Professor Sarvadi give his inaugural talk, please.
Yeah. Hello to everyone. Can you hear me? I think it's okay. It's okay. Can you hear me? Okay. So, and I have shared the screen, and I just have to thank Moody and Chandra for this opportunity and for continuous effort in education. The World Federation is really now working from remote with the same intensity and efforts that we spent before in personal meeting. And this is something that I have to thank all the committees of the World Federation who are now exposing themselves in this difficult situation. We know this is the world as today. The pandemic is still there. I would say a year ago, I had the first webinar. I checked this morning, the first webinar on pandemic and remote teaching on 8th of March last year. So it's almost a year that we are working in the same way. And in Italy, we were the first exposed in the Western world. So we started with the pandemic 21 of February last year. So it's almost a year that we are in the middle of this nightmare. And in March, I have seen my presentation. I told in 6 months, we will be happy and talking each other. That's not the way. We have to wait a bit more. So this is the situation around the world today. It's a real pandemic. I mean, it is all over the world. The reactions of neurosurgeons is seen from publication that we made. You see that there was an interesting editorial written by Douglas Kondiloska, Caldwell, and James Rutka in the Journal of Neurosurgery, showing how much we have written this year. You see, it's doubled. The number of papers sent to Journal of Neurosurgery group doubled this year, and is even more in the autumn. Until 31 December 2020, as you see, we have published more than 1,000 papers in the topic of COVID and neurosurgery, with these are the countries more involved in the publication. So almost all the neurosurgical community felt that the COVID pandemic is concerning ourselves. And how do we keep neurosurgery working in this condition? There are about 5 surveys, very important, from Europe, from US, from Egypt, from Africa in general, discussing the impact of COVID on education and on our activities. This is one of the survey, and you see that if you look at this left part, in most of the units during the high wave of pandemic, the activities were even closed, and in most of them, less than 30% of surgical activity was left during the pandemic times. So we have different solutions, but now I will talk about education. So I'm just touching briefly that there are different solutions. In the left, you see a paper from ourselves. How did we work? And we kept surgery alive in the difficult waves of pandemic by working all together in a system of hub and spoke. On the right, you see a very nice paper from India, which was recently published, suggesting again another system of centralization to keep the neurosurgery alive. But the question of the brief talk of 2 days will be around education. You see that this is the survey done in many countries by Professor El Gandour, and as you see here, many residents had activity canceled, activity significantly decreased both for teaching and for scientific activities. In all over the world, we had a change in teaching and in education of neurosurgeons. This is US and Canada, very high reduced access to hospital, reduced access to surgical activity, about 50%, and change in education using electronic platform instead of in-personal meeting. This is my country, Italy, where we joined together all the residency neurosurgical program into only one program, which was dealt every week by remote with different topics. So we join all the residents together. You see more than 330 residents working on a same program of education, obviously joined to a single university. And you see that this was very successful. We got more and more and more participants, and now we are up to 485 over a total of 600. So almost everyone is involved in remote education. The same happened in India. This is the paper on academic activities in India. The same again in East Asia, India, Indonesia, Malaysia, Singapore, Thailand. There was a deep impact on neurosurgical training and a deep impact on personal experience, especially surgical experience. Then this is a paper from Africa, which is the first paper I read with a positive message. The paper is saying we had difficulties in teaching and we moved to webinars. But in webinars, we had the possibility to hear the presentation and the lectures from well-renewed neurosurgeons from all over the world. And before, we didn't have this opportunity. So I found in this paper the first message of hope in this difficult educational way. And this is the Young Neurosurgeon and the Global Forum Committee working together, asking a group of neurosurgeons, you see, mainly from Africa and Southeast Asia, which are the most important targets for educations in countries with limited resources. And this survey was done in this country, And they have asked them, what do you want in education of neurosurgeon when the pandemic will be finished? What do you want to stay there for the future? And you see that virtual labs and collaborations are on the top, together with the curriculum an online curriculum. So there is a big demand of keeping the remote education for everyone. The World Federation was the first one. This is a letter that I have written in March. And I was criticized personally because this is the May letter, but we have done another one in March. They have criticized us because we stopped in-person meeting at the middle of March. And many countries felt that they were out of pandemic. They didn't need it, but it was unfortunately true. So we have started supporting something that we were already doing before the pandemic. This is 28 May 2018, and this is a webinar on YouTube and on the web, organized by the World Federation already, or the Spine Committee was already working before, and now it's hundreds of meetings organized by the committees of the World Federation, as we were saying before. Just to finish, what do we miss with the web education? Obviously, we miss cadaver labs, who are difficult to do in the web, where it's possible. There are some examples of cadaver lab in the web, but it's, let's say, difficult usually. We have a decrease in manual skills. Obviously, we are neurosurgeons. We have to go to operating theater. We have to work. And we have an increased use of simulation. We have many possibilities of simulation. You see that we have already written a paper in 2018 telling people that we can use the digital teaching for countries with limited facilities for education already. And as you see it here, there is the possibility of three-dimensional virtual intraoperative reconstruction. This is only one example of how you can work with this. So there are possibilities to work together. And this is a project of the European Commission, the Upsurgeon project, which is a collaboration between Italy and UK, working on this field, the remote education on the web by simulation. So in conclusion, I will use two Latin sentences to express myself. What we have learned, first of all, we have learned that we are doctors. We are not neurosurgeons first. We are doctors. We are physicians first, and then neurosurgeons. And in the case of pandemia, we are deeply involved in the cure of patients that we have to care, the neurosurgical patient, but also for the other patients. So necessity is the mother of invention. So we found a way to keep alive neurosurgery, and to work against the pandemic. And the second is ex malo bonum, means something very bad can be transformed in an opportunity, in a positive opportunity. The thing we're telling you before from our African friends, web-based education is free and can reach any neurosurgeon in the world. You see, this is one of the last seminars where I was teaching. Uganda, Libya, Yemen, Congo, Mongolia, these countries, the neurosurgeons living in these countries, for instance, Libya and Yemen, cannot go anywhere in any time. Neurosurgeons from Uganda, Congo, or Mongolia have difficulty to travel in any way, in any time, and to pay for traveling, congress, fees. So the webinars have joined this community, and in my opinion, even when pandemic will be finished, are here to stay. We will not stop. And our residents have learned how to prioritize surgery and keep emergency surgery live in difficult situations. So this is the issue that together with Moody, who is here, we have just published in our surgical focus. There are opinions about COVID and neurosurgery from all over. The world is free. You can download from the web, it's free for everyone. So I thank you for your attention. Think positive. Pandemic will finish, and meantime, we will learn in our young neurosurgeon inside themselves, we will have a bigger earth for for all the patients, wherever they come from. So thank you for your attention.
Thank you very much, Franco, for giving us an overview about what the World Federation has been contributing to the neurosurgical education during COVID times and how it had changed our perception for the future training. And we would really like to appreciate your presence for the inauguration and for the talk. Thank you very much. I would now like to take the opportunity to honor one of the senior neurosurgeons in our country who has been probably the pioneer of transphenodal pituitary surgery for microadenomas at the Premier Institute of All India Institute in New Delhi. And I think he has been like a father figure in recent times for all the neurosurgeons. I think apart from this, his one big credit goes to the successful organization of the 1989 World Congress, where he was instrumental in not only making the Congress successful, but also later on, you know, this exposed the Indian neurosurgeons to the world stage. And the foundation created has really helped training of the neurosurgeons by various workshops, CMEs, etc., which have been done through the foundation. So I would take this opportunity to honor Dr. Banerjee for his guidance all through this time. And is Dr. Banerjee there? Would you like to say a few words, sir? Hello.
Hello.
Huh, sir. Would you like to say something?
Well, it's a great honor to be asked by you to. Hello, can you see me?
Yes, yes, sir.
You can. Marvelous. Then I think it's a great honor for you to have thought of calling me to the stage today. And, you know, this 6.5 decades of neurosurgery, it's a long, long time. And one has seen so much of it, you know, starting from the beginnings of craniotomy with poor lighting, no magnification, to microsurgery, and to right now, what you have been able to do a lot and leave a big imprint was the popularization of the endoscopic evacuation of the pituitary tumors. So I think all in all, it was a great journey. And if I think that it was in 1956, when I was a medical student, that I first saw a craniotomy being done for a pituitary tumor in India. That's in my medical school in Lucknow by a neurosurgeon, A.C. Ray from the army. So from there to the wonderful procedures that you have shown us, you have popularized and taught me. I mean, I'm sure that I must say that you have been able to persuade me to take it up. Of course, now it's years, about 10 years that I have left neurosurgery, but then the longings and cravings are always there. Well, thank you, and wish everyone a wonderful program, which I'm sure Shekhar has organized. Thank you.
Thank you very much, sir, for your presence and graciousness. I would now get to the business end, that is the scientific program for today, and would like to introduce our 4 chairpersons. I think Professor Palbush is a legendary figure already in neuroendocrine surgery, not only in Europe, but well known all through the world, and currently practicing in Hanover at the Institute. And this is also accompanied by Dr. Geeta Chako. She is a pathologist with special interest in pituitary pathology at CMC Vellore. Also, our other well-known surgeon from Austria, Dr. Engelbert Noss, and our Indian colleague, Professor Lokendra Singh, who is currently the president of the Neurological Society of India. So I would take this opportunity to thank them, and I would like them to call upon the various speakers, starting with Dr. Nanda, whom I think Geeta Chako is going to introduce. Geeta, are you there?
Thank you, Dr. Depujari. We start today's sessions with the first keynote lecture by Dr. Anil Nanda. Professor Nanda is the chairperson of the Department of Neurosurgery at Rutgers, New Jersey Medical School and Robert Wood Johnson Medical School. He started his medical career in JIPMER in India, but moved very soon after his undergraduate to the US. He's been recognized as a global leader in neurosurgery. I've had the good fortune of attending Professor Nanda's talks, and I know that he has a great interest in the history of neurosurgery. And today, his talk will be on the historical aspects of neuroendocrine surgery. Professor Nanda.
Thank you. Can you hear me all right?
Yes.
Okay, let me just get my screen opened here. And let me just get this. Do you see my slides?
Yes.
Good. Well, thank you so much for that generous introduction. It's a real pleasure to be with all of you. It's it's freezing temperature. It's going to snow here. So I wish you a very good morning from the Garden State of New Jersey. And it's great to be on with friends. It's sort of a virtual world, but it's wonderful to be with all of you. Thank you, Shekhar and Moody, for setting up a great meeting. And I want to, again, I recognize Professor Banerjee in 1989 when they had the meeting. My late father was alive and actually knew him. And it was a great meeting we had in New Delhi. And thank you, Franco, for your leadership and the great lineup that you have. So, you know, the history of neurosurgery has wonderfully inspiring ideas. And I think in the Egyptian mythology, the story of Isis, Osiris, and Thoth, when they go about finding his parts of his dead body all over Egypt to bring her beloved back, they really revere the spine. It's not the brain that they revere. And the Egyptians really, when they do the mummification process, they quickly suction out the brain. The brain was never important. It was always the heart. And they have, these are the first sort of transphenol instruments that you see. And you can see here, there's a beautiful sagittal CT scan of a mummy. And you can see they're not going transphenolally, they're really going subfrontally through the nose. In fact, one of the pharaohs, Akhenaten, was supposed to have had acromegaly just from his look. So the long history of pituitary disorders there. The title that I use for this talk is Eritjerika, which is an Aboriginal word from Australia. And Elias Canetti, when he got the Nobel Prize, talked about is filled with desire for something that is lost. And so it's another word for nostalgia and to appreciate the past. So I think history always reminds us of what we have lost and what we treasure. So I thought it'd be good to sort of trace our tracks there. So when you look at the origins, Hippocrates first talks about the 4 things, you know, the 4 choleric bilious, and he talks about phlegm, which is pituita, which comes from the nose. And Galen talks about anatomy underneath the basin of the nose. And then Vesalius changes everything. And it's really Annus Mirabilis in 1537. When Cushing remarks about 1537, it was one of the most profound experts. He says it was 1543 is memorable for the appearance in Nuremberg and Basel of human thought about the macrocosm and the microcosm. Because with publication of De Corpora Humana Fabrica Vesalius was perhaps the big breakthrough study on anatomy, and Copernicus shook the Aristotelian theory that the world was the center, and we realized obviously the sun was the center. And Annus Mirabilis, of course, comes back in 1905, and Einstein comes up with his new theories. But I think it's an important time for all of us to appreciate. If you look at skull base and pituitary tumors, this is Durante's first paper in Lancet from Sapienza University. And so I always tell Franco, we owe so much to the Italians. And you can see this, the first removals reported in Lancet with very good long-term survival. Tomasello always reminds me that he was from the island of, from his island. So he was like, this is the way it works. Now, again, the Italians help us a lot here. Giordano did extensive work on cadavers and proposed the first extra sort of cranial approach, transfacial to the pituitary gland. And Schoeffer publishes this paper in 1907, described the first successful operation of pituitary tumor by a superior nasal transsphenoidal approach. You have to appreciate his collar. It's very much like Harvey Cushing's collar. So all the fashionista needs to know that. And this is Coker, who gets the Nobel Prize for his great work on thyroid. And here you can see it was very disfiguring at that time because they would make a big dent like that. And obviously we've come a long way since then. If you look at all the other sort of important players, Minkowski, Hutchison, Horsley describes the transcranial approach, and then Cushing describes the, and starts sort of the art of neuroendocrinology. And, you know, then you look at endonasal approaches here, which really are a paradigm shift that, you know, make it much easier to use the endoscope. So it's interesting when you look at this that, that Cushing and Hirsch independently followed the submucosal resection. Actually happened on the same day. So sometimes greatness in history happens on the same day. So June 4th, 1910, both of them do a pituitary tumor. And Cushing really does a good job. It's a beautiful illustration of Cushing doing that. But you can see his mortality rate was 5.6% when he went transsphenoidally. But when he did it subfrontally, it was lower. And what Cushing did, all of America did. So when he goes intracranially, really it all stops. It doesn't, we don't have any transsphenoidals. So the names that, you know, it's interesting when you look at one of the sort of glaring abnormalities of history, just like some of the great writers of our time didn't get the Nobel Prize. Cushing not getting the Nobel Prize is kind of a tragedy because he created a whole specialty. Coker gets the Nobel Prize for thyroid. Alexis Carrel gets it for cardiac surgery. Joseph Murray gets it. And of course, Igor Moniz, the Spanish gets it for the wrong reason. He gets it for lobotomy when he should have really got it for angiography. But be that as it may, Cushing sprouts many other people to operate on this. Guillot is taken by Godot. And I think the real credit for popularizing pituitary surgery transplant should go to Jules Hardy from Montreal. And he sort of makes it very easy to do this and uses the microscope. And then, of course, the legendary Ed Laws and Charlie Wilson. Ed Laws, I think, has done a couple of thousand of these. So it becomes much more popular. But if you sort of track this down, you can see Harvey Cushing starts 1920, it goes intracranially, and Schaeffler, Hirsch, Norman Dott, Guillot, and Hardy. So a lot of these pioneers decide this. Now, I think the sort of disruptive innovation in this procedure comes with the endoscope. And you can You see Bozzini first describes the endoscope. Hopkins and Nitze described the design. Carl Storz, as the name is legendary, helps us design these things. And Desormeaux, really a urologist from Paris, first coins the word endoscopy. And actually Dandy, which should be given credit for being sort of the father of endoscopy. This is the first contemporary case of endoscopic pituitary surgery being by Jankowski, reported in 1992, when some of us still scoffed at it. And I think medicine is full of disruptive innovations. When new things come, and we're like, okay, this works, this doesn't work. And this is Clayton Christensen's theory on how new things like the gamma knife. And I think medicine is full of people that have come up, Ambrose Paré. When we have to put hot burning oil on wounds, Ambrose Paré says just put rose water. Lister comes with carbolic acid. Nightingale comes with hygiene in the Crimean War. Marie Curie introduces radiation. Harvey Cushing makes a whole new specialty of brain surgery. And Barry Marshall inoculates himself with heliobacterium to give himself a peptic ulcer. So, when I was a med student, they were still doing vagotomies. I must add that Dr. Chacko was at Bellore, I was at Pondicherry, which was just a short distance from there. We did a lot of vagotomies. I think then the history evolves more to three-dimensional with the frame and stereotactic assisted system, makes it much easier. Intraoperative MRI helps a lot. And the robot comes in too. Now, I don't use the robot for this, but I know there's many people that have used this and felt that this is something that works, yeah. This is called Scott's Parabola. It was published in British Medical Journal. It said the rise and fall of a surgical technique. So it comes in as a promising idea, encouraging reports, media pressure, and then doubts creep in, damaging report, condemned by authorities, fall into use, and then old surgeons talk about it. Fortunately, this didn't happen with transsphenoidal surgery. I think transsphenoidal surgery followed this thing, like it was an innovation, peak of inflated experience, and trough of disillusion, slope of enlightenment, and now it's sort of the plateau of productivity. And I think that's made real good things. And I think sometimes there's a difference of opinion. Some people say skull-based surgeons are from Mars and endoscopic surgeons are from Venus. Maybe they're all both the same. And I think if you look at the meta-analysis, this is the meta-analysis, but the only fallout with this is really by ENT surgeons. And so they really push that the endoscopic approach is superior. In all my time in Louisiana, I rarely used the endoscope, but since I've come here the last 3 years, I've been using the endoscope, and it's funny. I would say that even at my age, you can treat an old dog new tricks. So just to look at the data, gross total resection, actually about the same. Visual outcomes the same. I find the biggest difference in endoscopic and open is I can really do an endoscopic procedure. If it's a simple tumor in about 30 minutes, if you go endoscopic, it's going to take you an hour and a half, 2 hours. It's much longer. So this just shows you the meta-analysis of this, where we stand with this, and the complications are significant. You can see that here on both open and quality of scale. So this is some of the papers that have come out. I think the CSF leak is the main thing. This is a large tumor that I actually did endoscopically, and everybody knows these videos. They're beautiful resection. Everything comes out real well. It's funny. My fellow actually came from, Joey Quillon came from Emory, and he actually taught me how Nelson does it, where he goes completely subcapsular. So the whole, you don't get into the tumor and take the whole thing out. And I never did that open. So it's kind of interesting how you can learn to improve your technique. And here you can see most of the tumors come out well. And here the post-op is pretty sure. But it's something like this, the craniopharyngioma with visual loss, and you could say you could do this endoscopically. And I still sometimes will prefer going, the classic way. Here we are between the carotid and the in the triangle, and all the calcium there. So I still prefer some of these cases to go intracranially. But this is the kind of case that I would say if it's purely in the cellar, I go traditional. So I think you don't want to be very rigid that this is the only way to do it. Another case here that if it's purely the cellar, I just knock this out very quickly without going through the endoscope. But again, with larger tumors, the craniopharyngioma going into the brain stem, I will go traditionally open cases. And this is a younger child that did fairly well. And, you know, with tumors like this, I think the jury's out. You can, I mean, sometimes I prefer intracranial or a combination. And then there are cases like this turned out to be a chordoma. So where the perfect approach is, you know, I think you just need to tailor it. This is the Fighting Temeraires, Britain's most popular thing. This was the boat that won the Battle of Trafalgar, but you can see a little steamboat is pulling it. So the cheese has moved on our approaches. And I think this is from medicine, they say, you know, half of the dean of a medical school says half of what we teach you here is wrong, but we don't know which half. So sometimes being rigid on saying that this is the only way to do it is not sort of the way to go. I want to tell you our global neurosurgery meeting was very well attended, and we are now starting a global neurosurgery lyceum series. You'll be hearing about this. We have stroke, and we're having an educational summit. So we invite everybody for it. And I think during pandemic, I think Franco always gives us great Latin phrases. And I would talk about stoicism, that the only way you prepare for pandemic is practicing premeditatio malorum, the premeditation of adversity. And I think when we talk about history, I want to bring back Arajarika, this nostalgia for the past with some of our, you know, we want to make sure our younger colleagues and students learn that the history is so important. This was Harvey Cushing when he came for the International Congress in Bern, and he talked about Coker. And he says the torch goes from one generation to another and fades into oblivion. So for those of you, his spiritual grandchildren who have gathered here, whom Coker is more than a name of the street, I would like to give you an impression of what he was in life. A slight, sparse man of personal neatness, of quick step and alert hearing, of unfailing courtesy and dignity, precise and scrupulous in all his dealings, a man to trust. This is why Harvey Cushing gets the Pulitzer Prize. He's just a brilliant writer. And I would end with a wonderful poem by Amanda Gorman, So the New Light in the United States. She says, "For there is always light, if only we are brave enough to see it, if only we are brave enough to be it." Thank you so much. It's an honor and privilege to be with all of you, and I appreciate your time. Thanks so much. Yeah.
Thank you, Dr. Nanda. I think we will be having the questions at the very end of the session.
So that brings Geeta for you to start your talk. Dr. Geeta Chacko, as you can see, is especially interested in pathology of pituitary, and she is currently the professor and head of Department of Pathology at Christian Medical College, Vellore. Geeta, please.
Just need to share my screen. Thank you, Dr. Dev Pujari, for inviting me to participate in this symposium on a set of tumors that I find intriguing and whose bland histological features can be very deceptive. Pituitary pathologists have constantly looked for clues that help predict clinical behavior. And the evolution in the classification of pituitary adenomas over the years stands testament to this enigma. From a classification that was based on tinctorial properties of tumor cells, the classification evolved to one in the 80s and 90s, which was based on immunohistochemical staining for the various pituitary hormones. In 2004, the principles of the classification remained focused on immunoprofile and ultrastructural features, but added granulation patterns of tumor cells into the subtyping of individual tumors. Null cell adenomas at that time were defined as tumors that showed variable weak to focal immunoreactivity for hormones. Pituitary-specific transcription factors were known to be responsible for cytogenesis of pituitary adenomas, and they feature in the AFIP fascicle in 1998, which was authored by Dr. Sylvia Assa. The three main pathways involved in cytodifferentiation in the adenohypophysis are as follows. The PIT1, or the pituitary transcription factor, which has a role in the differentiation of somatotrophs, thyrotrophs, lactotrophs, and mammosomatotrophs and their respective tumors. The steroidogenic factor, which is responsible for the differentiation of gonadotroph cells and therefore expressed by gonadotroph tumors. The TPIT, or the T-box pituitary transcription factor, which is responsible for transcription of pro-opiomelanocortin, which is a precursor of ACTH and is expressed by corticotroph tumors. In 2017, the role of transcription factors in tumorigenesis of pituitary adenomas was taken into account in the classification. And you can see in this, the PIT1 being the somatotroph, lactotroph, thyrotroph tumors, TPIT for the corticotrophs, like I said earlier, and steroidogenic factor SF1 for the gonadotroph tumors. Now, in addition to this, the new classification changed from the term hormone producing to troph to underscore the role of transcription factors in cell differentiation. Apart from this, immunohistochemistry for estrogen receptor alpha and low molecular weight cytokeratins were also brought in for their role in subtyping. For instance, low molecular weight cytokeratins identify the dot-like fibrous bodies that are seen paranuclearly in sparsely granulated somatotroph adenomas, acidophil stem cell adenomas, and in a subset of plurihormonal tumors. GATA2 is another transcription factor that is expressed by gonadotroph tumors and thyrotroph adenomas. Null cell adenomas in the new classification are non-functional tumors that are immunonegative for all hormones and for all transcription factors. A word of caution here: when one finds a cellular tumor that is negative for both hormones and transcription factors, it's important to exclude other entities like paragangliomas and metastatic carcinomas before diagnosing a null cell adenoma. So in this example is a tumor which is immunonegative for all the hormones, and on transcription factors, steroidogenic factor was positive in nearly all the cells. Actually, more than 10% of nuclear positivity is enough to consider it positive for a particular transcription factor. And so this tumor was called a gonadotroph adenoma. In 2017, the plurihormonal tumors were classified as plurihormonal PIT1 positive adenomas and adenomas with unusual immunohistochemical combinations of hormones and transcription factors. Sylvia Assa, however, sought to clarify that amongst the PIT1 plurihormonal tumors were two sets of tumors. One, the functioning tumors, which were hormonally active, and she said should be classified under their functional counterparts, and the other, which were non-functional tumors, clinically silent, which had a distinct morphology similar to what was called the silent subtype 3, showing multiple expressions like growth hormone, TSH, alpha subunit, and prolactin, characteristically having these CAM5.2 positive low molecular weight cytokeratin fibrous bodies. And she suggested that these be called poorly differentiated PIT1 lineage tumors or silent plurihormonal tumors. This term has now been endorsed by the European Pathology Group. The other kind of plurihormonal tumor is the one where more than one transcription factor and hormone is expressed. And the suggestion is that they be called polymorphous plurihormonal tumors. So for an example, here's a case which shows expression of various hormones. CAM5.2 shows paranuclear dot-like positivity. PIT1 is diffusely positive. And while in 2017, it would have been called a plurihormonal PIT1 positive adenoma, the current recommendation is that they be called poorly differentiated PIT1 lineage tumors or silent plurihormonal tumors. The most controversial aspect of the 2004 classification was the inclusion of the term atypical adenomas for invasive tumors that had an elevated mitotic activity, MIB1 index, and extensive p53 immunoreactivity. There were several studies that found this to be unreliable, both in terms of reproducibility and in prediction of aggressive behavior in these tumors. And so atypical adenomas were removed in the 2017 classification, and this entity is now obsolete. Instead, WHO recommends that aggressive tumor is a clinical term, and in addition to subtyping by immunohistochemistry, one must assess markers of tumor proliferation being mitotic activity of more than 2 per 10 hyperfields and a proliferation index of more than equal to 3%, and also look for features of clinical aggression such as tumor invasion. Now, invasion is defined in WHO by using the NORS criteria for grading. There is also a 5-tiered grading which has been proposed by Truyer, which in more recent years has been tested by some groups and found to be predictive of behavior. In this, grade 1 are the non-invasive tumors, grade 2 invasive tumors, and grade 3 metastatic tumors. And they're further subdivided into A and B based on whether they're non-proliferative being A and proliferative being B. We have not applied this system, but have in our previous work found that MIB1 labeling index is indeed higher in invasive tumors, particularly in those that invade the cavernous sinus. But more importantly, when one looks at outcome, we have observed that high MIB1 is of value in non-functional tumors, where a MIB of greater than or equal to 3% is significantly associated with postoperative recurrence and disease progression. As regards P53, the WHO had defined it as tumors that showed diffuse positivity for P53. This was largely based on evidence of studies such as this, where cases showed disease progression had a high prevalence of P53 positivity. However, this was not statistically significant. There was another study which showed that nearly a third of recurrent tumors express P53. In our experience, P53 immunostaining yields only occasional weak positive cells within a tumor, and the tumors that show diffuse positivity such as this are very rare. Other authors also expressed skepticism regarding clinical significance of P53, and as its role in routine practice was questionable, there was a unanimous decision to discontinue the use of P53. There are some people who still use it, though, in cases with a high proliferation. WHO 2017 termed certain adenomas as high-risk tumors, and these were tumors that were reputed to show an aggressive course. There were 3 functional tumors amongst these: the sparsely granulated somatotroph adenoma, the lactotroph adenoma in men, crook cell adenoma, and 3 non-functional tumors: the silent corticotroph adenoma, the poorly differentiated PIT1 lineage, which I now said is called also was earlier the silent subtype 3, and the null cell adenomas. I'll come back to this again a little later in my talk. Now, alongside the publication of the 2017 was another proposal. The International Pituitary Pathology Club met in France in 2016 and acknowledged that while pituitary adenomas were benign, they could be aggressive with local invasion, repeated recurrences, significant morbidity, and persistent symptoms requiring long-term medication and on occasion radiation therapy. The term adenoma meant that they were denied health insurance coverage, not reported in cancer registries, and there was significant morbidity even when they were not metastatic. And to address this conundrum, the International Pituitary Pathology Club proposed that pituitary adenomas be termed pituitary neuroendocrine tumors with the acronym PITNET. So a sparsely granulated somatotroph adenoma would be a sparsely granulated somatotroph tumor. The common classification framework of neuroendocrine neoplasms, which suggested by the IARC, included familiar names in pituitary pathology, Dr. Sylvia Asa and Dr. Truyer, and they endorsed the proposal of Pituitary Pathology Club that pituitary tumors should be considered neuroendocrine tumors and be called pituitary neuroendocrine tumors, or PITNET. For the rest of my talk, I will address the pituitary adenomas as pituitary tumors. How did this change in classification affect the prevalence of subtypes in our series? One of my proposed graduates, Dr. Akhilesh Ravichandran, reviewed the pituitary adenomas seen in our center over the last 12 years, and additionally carried out immunohistochemistry on cases that were immunonegative. And he used the 3 transcription factors, SF1, PIT1, and TPIT. A tumor which showed more than 10% cells being positive was considered positive for that transcription factor, though in fact, actually we found that when it's positive, it's quite diffusely positive within a tumor, except for the plurihormonal unusual tumors. Now, out of the 1,031 cases, 994 were included in the study, and of this, 92 were immunonegative and required further immunohistochemistry with transcription factors. This cohort included over 60% of which were non-functional tumors and 92 being immunonegative. When we did the transcription factors, what we found was that more than 50% of these tumors were SF1 positive and therefore gonadotropes. A tenth were positive for TPIT and were classified as silent corticotroph adenomas. There were 3 silent PIT1 positive tumors, and 34% of this cohort were true null cell tumors. So comparing the distribution, both pre-transcription factor and post-transcription factor, what has changed is that the prevalence of gonadotrophs has increased. The plurihormonals are split between the unusual expression and those that are part of the functional group. And prevalence of null cell adenomas has dropped to 3%. Now, when one looks at indicators of aggression, there was a significantly high prevalence of invasion amongst the non-functional tumors, which stands to reason as they tend to grow unnoticed and cause symptoms much later due to pressure effects on adjacent structures. When one looks at the high-risk tumors, the prevalence of invasion is much higher in these subtypes than their counterparts, and in most situations, it was statistically significant. Looking at each of the high-risk tumors individually, in a study of 101 somatotroph tumors with the sparsely granulated tumors had a higher MIB than their densely granulated counterparts. We also observed that the rate of remission in these cases was lower than in the densely granulated. However, this did not achieve statistical significance. In this more recent study by Akhilesh, we had 135 somatotrophs. We found that a MIB of greater than or equal to 3% was a significantly larger proportion of cases in the sparsely granulated group. Although both the prevalence of invasion and recurrence was higher in the sparsely granulated group, it did not achieve statistical significance in our study. We'd also found in an earlier study on corticotroph adenomas that silent corticotroph tumors had a higher MIB labeling index, and more importantly, required repeat surgery at a higher rate. I'm not elaborating on this as Dr. Ari Chako will be dealing with this group of tumors in detail in a subsequent talk. Coming to null cell adenomas, there are tumors that are immunonegative for both pituitary hormones and transcription factors. While our earlier prevalence of this was at 9%, with application of transcription factors, the prevalence shrunk to 3%. When you look at the markers of aggression in these tumors, as expected, the prevalence of a high MIB is more in functional tumors compared to null cell adenomas. And when you look at non-functional tumors, the prevalence of a high MIB is similar between the non-functional tumors and the null cell tumors. Looking at invasion as a marker of aggressiveness, 84% of null cell tumors were invasive, and this was significantly more than functional tumors. On the other hand, when we compared this to our other non-functional tumors, the prevalence of invasion was about the same between both groups. The most interesting finding was that nearly 54% of null cell tumors recurred, and this was significantly more than all other subtypes. So the use of transcription factors has certainly helped in identifying potentially aggressive tumors. A multidisciplinary approach has always been advocated for management of pituitary adenomas, and I think is the only way to identify these high-risk tumors. Aggressive therapy with close follow-up is required for invasive tumors with significant postoperative residue, tumors with a high proliferation rate, either by the mitotic rate or the proliferation index with Ki67, and identifying the aggressive histological subtypes. It's important for us to maintain a robust database on these tumors to compare our experiences across various centers. And the European Pituitary Pathology Group has provided a proposal for a standardized reporting format, which I find is quite useful and would help with meaningful comparison of outcomes across different clinical groups. So to conclude, the evolution in our understanding of pituitary adenomas has been fascinating. There is no doubt that the 2017 classification will evolve further. And while techniques of immunohistochemistry for classification can be done by almost any laboratory, the financial implications of an expanding panel of markers will need to be balanced with its utility in guiding management and prognosis. Thank you.
Thank you, Dr. Geeta Chacko, for this very informative lecture of yours. And next speaker is also from the same institute. It is Professor Ari Chacko. And he will discuss about the impacts this new classification, which was discussed just now by Professor Geeta, what impact it has left on the neurosurgical practice. Ari, the stage is yours, please. Professor Ari Chacko.
Yeah, can you hear me?
Yeah.
Yes, Ari.
Share the screen.
Can you unshare screen, Swapnil?
So can you hear me?
Yes.
And are my slides moving and things like that?
Yeah, yeah.
Okay. Well, thank you very much for that introduction. And thank you, Dr. Deo Pujari, for getting me involved in this symposium. Let me first summarize what Geeta just said about the WHO 2017 classification. Tumors were earlier categorized on hormonal status and immunochemistry into the various subtypes shown over here. And the silent corticotrophs are ACTH positive on immuno, but fail to produce ACTH and do not have hypercortisolemia. And of course, if immunochemistry was negative for all hormones, that pointed to a null cell adenoma. With the use of transcription factors and cofactors, tumors would be classified accordingly with their various subtypes, shown here in the appropriate colors. And it's only when all transcription factors are negative is it a null cell adenoma. Geeta showed that these numbers have reduced as they were reclassified into one of the other categories, depending on which transcription factor was positive. There was also an increase in the silent corticotrophs. So if we closely analyze the outcomes of the null cell tumors and the silent corticotrophs with this new classification, we should get closer to the truth with regard to aggressiveness. Geeta dealt with the null cell adenomas, so I will focus on the silent corticotrophs and will not be talking about the management of any of the functional tumors. She also said that the WHO 2017 recognizes these subtypes of tumors as high risk for recurrence and need close follow-up or early institution of radiation therapy. They have, however, removed the term atypical, but still recommend Ki67 testing with the MIB1 labeling index. Although they've removed P53, that is still controversial. Now, it's obvious that neurosurgeons are not privy to this pathological information preoperatively. Therefore, the goal of surgery in pituitary macroadenomas remains the same, namely, improve vision, preserve pituitary function, and achieve remission in functional tumors. A maximal safe resection realizes these goals with a low complication rate. The question then arises, what do we do with residual tumors? And that is where the pathology comes in. For instance, we operated on this patient 2 weeks ago, a fairly large pituitary tumor, clinically non-functional, causing visual dysfunction and invasion into the left cavernous sinus. That's the T2 weighted image showing no cystic changes. Now the video begins with us having removed the tumor in the cellar, and we are now extending the dural opening up to the edge of the left cavernous sinus. With curved suctions, we are able to take off the suprasellar portion fairly easily, with the arachnoid coming to view and the normal adenophysis here on the right side. We're looking into the cavernous sinus with we reach the end of our vision with a 0-degree scope. So with a 45-degree scope under direct vision, we're able to take out the tumor inside the cavernous sinus behind the anterior genu of the carotid artery. So I was quite happy with the excision over here. And with the post-operative image, which shows that there is possibly some residual tumor here in the roof of the cavernous sinus. And over here, that little nubbin of tumor seen on the preoperative image is something that we have missed. But the rest of the tumor is out. Here's the actual biopsy report that says there are small foci of positivity for LH, strong nuclear staining for SF1. So this is a gonadotroph tumor with a high MIB1 index. I will get an MRI in 3 months' time and will discuss with the patient the options of early stereotactic radiotherapy if there is residual tumor seen in the cavernous sinus. The rest of my talk will justify this strategy based on our experience and a review of literature. Over this 12-year period, we operated on 622 pituitary tumors in my unit, half of which were clinically non-functional. Abhijit, my resident, analyzed this data. 62 were silent corticotrophs, 57 being detected on immuno, ACTH positivity, while an additional 5 were TPET positive. So that's about 8%. The remaining were other non-functional tumors, the majority being gonadotroph tumors, and the true null cell tumors, negative for all transcription factors, constituted about 6% of the non-functioning tumors. Now it's evident that the silent corticotrophs were significantly larger and more likely to be invasive than the other non-functioning tumors. We also noted a greater prevalence of microcystic changes in the silent corticotrophs that has been reported by others too. Here are some examples of microcystic changes in tumors of various shapes and sizes in the silent corticotrophs. Now, several issues apart from pathology might influence the treatment decision tree. For instance, if vision is still a problem from residual chiasmal compression, a resurgery either endonasally or transcranially might be necessary. This will be discussed in other talks during this symposium. Our strategy is as follows. If the residue is small but accessible in the cellar or suprasellar area, resurgery is a good option. Whereas if it's in the cavernous sinus with a high MIB, or if the patient's not willing for surgery or not willing to come for regular follow-up, radiation is preferable. We managed some patients expectantly if the tumor was small with a low MIB and they were willing for regular follow-up. This is an example of a young man who we saw in 2005 with blurred vision due to a large pituitary tumor. The sagittal lebar shows a very small cellar, and we were unsuccessful in removing it completely transsphenoidally. So we operated transcranially that same week for the suprasellar residue and removed it completely, as seen on this 6-month follow-up MRI. The biopsy was a silent corticotroph adenoma with a MIB of 3%, so we advised regular follow-up. 7 years later, he had blurred vision again and had a recurrence that we operated transsphenoidally in 2012 and transcranially in 2013, after which we gave him stereotactic radiation. This time, the tumor has remained stable at his last follow-up in 2016. Another example of a 55-year-old school teacher of Indian origin from Kenya who underwent surgery for this tumor in 2011. It was a gonadotroph tumor with a very low MIB index. There was a small residue, so we decided to follow him up. Subsequent MRIs show a small but definite growth, and this is his last MRI 8 years after surgery. I offered a second surgery, but since his vision was normal, he promised to return every year. So this case highlights the importance of long-term follow-up, even in these so-called indolent tumors. On the other hand, this young man with a giant adenoma showing cystic changes came to us in 2013 with poor vision. After an endoscopic surgery, the immediate post-operative MRI shows a good excision, but there are small bits of tumor over here, not really enough for a re-exploration, and his vision had improved. The biopsy was a gonadotroph tumor, MIB of 3%. We followed him up with an MR 9 months later, and this is the MR. Now, if I were to ask you what you would do for him, an audience poll would probably be evenly distributed amongst these options. Now, I would love to choose option 5, but you can't do that in real life, so I chose to follow him up. Now, that was a mistake because he disappeared, returning 6 years later with this massive recurrence. Both these tiny bits of residue seem to have exploded. We did a combined transcranial and endonasal approach, and this time the MIB was 6%. We don't really need an opinion poll to figure out that this patient needs adjuvant RT, which we did, and things seem to be relatively stable on this MR he sent me last week. So with regard to extent of resection, of the 62 silent corticotrophs, we were able to gross totally excise only 20% of tumors. These were followed up, and the subtotally excised tumors were either given adjuvant RT or followed up without radiation. Only one recurrence was seen after a gross total resection and one progression after adjuvant RT, while progression was noted in 60% of patients who are managed expectantly. Here are the outcomes for the other non-functioning tumors, followed up for the same duration. No recurrence of tumor after a gross total resection or adjuvant RT, and only a 16% progression in the patients managed expectantly. And this is depicted in the following Kaplan-Meier graphs for silent corticotrophs. Progression and recurrence was similar in the gross total resections and those subtotal resections that received adjuvant RT. On the other hand, expectant management was associated with a higher chance of recurrence. This is also true for the other non-functioning tumors that had a higher chance of recurrence when residues were not radiated. But on comparing the silent corticotrophs, that's a red curve, with the other non-functioning adenomas, the blue curve, we found that both had similar outcomes if given adjuvant radiotherapy after subtotal resection. On the other hand, this graph beautifully shows a significantly higher rate of progression in the silent corticotrophs as compared to the other non-functioning tumors if they were not radiated. Now, the Emory group analyzed their data in 2012 with Dr. Nelson Oisiku as the single surgeon. They had 33 silent corticotrophs and found that these patients were younger and the tumors were more invasive than other non-functioning tumors. Their excision rates were similar, but adjuvant RT was used more often for residual disease in the silent corticotrophs, although this was not significantly different. Their Kaplan-Meier curves do show a higher recurrence rates in the silent corticotrophs, but because of the small numbers, it did not reach statistical significance. Their conclusion, therefore, was that while some silent corticotrophs tend to recur and require close follow-up, the overall treatment strategy need not be different from other non-functioning adenomas. Even this very recent meta-analysis in 2019 on data from 297 patients found no evidence supporting a higher recurrence of silent corticotrophs over other non-functioning tumors. But the story isn't over, because in October 2019, the Emory group looked at a large cohort of 501 pituitary tumors, amongst which were 14 silent corticotrophs. This time around, they show a significantly higher chance of recurrence in the silent corticotrophs as compared to the other non-functioning tumors, more in keeping with our findings. They go on to test various models for all pituitary tumors and found that the best prediction of long-term course was achieved by their model that included these three parameters. The first two obviously have a bearing on the extent of resection, and a MIB greater than or equal to 3%, as we have shown, has been for many years used to predict early recurrence and is also recommended in the WHO 2017 classification. So as pituitary surgeons, our goal of surgery remains the same. However, we need to recognize high-risk tumors categorized by pathology, and silent corticotrophs are one such tumor amongst others. A high MIB can provide guidance. And if these high-risk tumors have inaccessible residues, consider upfront adjuvant radiotherapy. And finally, it is quite clear that all patients, I repeat, all patients need long-term follow-up. Thank you.
Thank you, Hari. Thanks for a very nice talk. And it's my pleasure now to introduce Dr. Nalini Shah, one of the senior neuroendocrinologists in the city. Her interest in pituitary tumors is well known. She has been till recently the professor and head of the Department of Endocrinology at the KEM Hospital and also at the Tata Memorial Hospital. And I would request her to speak on her update on Cushing's disease. Nalini, please.
Good evening, ladies and gentlemen. May I please understand if my slides are visible?
Yes.
Thank you. So good evening, ladies and gentlemen. It's indeed a pleasure to connect with neurosurgeons. And I think this is a fascinating symposium. Dr. Dev Pujari, thank you so very much for this opportunity to connect across the globe with more than 20 countries participating with different neurosurgeons on one of my favorite topics. So much of what I'm going to present today stems from this very long journey of having managed about 600 plus patients with Cushing's syndrome. And I think as you trail through your journey and when you reflect back, what emerges is what I'm going to put together as some learning points coupled with what has been the recent advances based on the literature. So let me just begin, please. Why is it so difficult to make a diagnosis of Cushing's syndrome? And that question, if we just ask ourselves, it comes through very easily by just relating to this quantum of delay which is ensuing between the symptom complex which begins and the diagnosis that is achieved. And that's because the hardcore signs of Cushing, which encompass the skin change or the muscle change or the bone change, are very, very late in origin, and they kind of represent a very florid cases of Cushing, certainly not something which is going to be useful for a diagnosis. So if you look at the spectrum of Cushing, which is very essential to relate to, because the performance of all the tests is going to depend upon whom are you really applying it to? Cushing sort of just gets lumped together as one single basket, and it is truly far from it, as can be exemplified from this one single slide. This is a very florid case of Cushing, and nobody can really go wrong in making a diagnosis, and so will be the test. No test will go wrong in making diagnosis of Cushing in this particular lady. But this Cushing, which is very early, and this which is very, very mild, and she was referred to us only as a possibility of PCOS, actually is where the test performance could change and could lead to some concerns in their performances. This lady who actually comes as a possibility of PCOS, but you kind of get worried with her faces and you want to pull out a possibility of excluding Cushing's syndrome, which is so common in patients who present with metabolic syndrome. And this patient who's a pseudo Cushing actually because of depression. These are the group of entities which could lead to misdiagnosis of Cushing. So A, we want to achieve right diagnosis early on, even in a milder individual. And B, we definitely don't want to mislabel somebody with Cushing, because the whole management protocol significantly tends to be very different in these individuals. So when we talk about the test, we want the test to be accurate. We want it to be reproducible. We want it to be sort of accurate or good in its performance vis-a-vis sensitivity and specificity. And we don't want challenges with logistics in these group of patients, really. So from the old standards, which are like urinary free cortisol and midnight cortisol, we have moved over to late night salivary cortisol and dexamethasone suppression tests, which perform much better in all the domains of wish list, which we want to achieve in a given test protocols. And even the current reference, which puts together the meta-analysis of all the test performances published to date, clearly suggests that overnight dexamethasone suppression test has a good sensitivity, good specificity compared to the other tests, and very importantly, it's a very easy to perform test on an outpatient basis itself, which is extremely important when you start talking about a huge number of patients who could be mimicking Cushing's syndrome, and we want to investigate them on OPD basis itself. So when you're talking about diagnostic algorithm, these are the number of tests which are available to you. How do you really apply them in A, mild patients or early patients, and B, these patients who are mimics of Cushing, but actually are definitely not Cushing, because this lady will never give us a problem with any test which is applied in its distinction. So this is something which we learned very, very effectively when we started following up our so-called patients who were cured with Cushing's disease post-operatively, and we started monitoring them very, very closely. And I can just point out here that this is a lady whose dexamethasone suppression test is negative, but her late night salivary cortisol has started becoming positive. And that is the earliest marker of sensitive test which picks up Cushing's disease. Come together a little longer follow-up, and now your DEXA just starts surfacing to become abnormal. And that is another aspect of sensitivity that you learn. But come about a year from the time of surgery, urinary free cortisol starts rising, and all the tests are now abnormal, clearly telling us that urinary free cortisol is very poor in picking up early Cushing's disease, which is what our goalpost ought to be. Also, what we need to understand that when we talk about overnight dexamethasone suppression test and we sort of call it a sensitive test, we cannot be burdened with a false positivity emerging, and we want it to be specific as well. And we realize that it is fairly specific, at least in our population, on a huge database of 1,000 patients where we studied it, which is a published data. And if there are problems in the rest of the 4% of patients, we applied the 2-day dexamethasone suppression test, and everybody sort of performs in terms of specificity to the tune of 100%. So dexamethasone suppression test in our cohort, which is a representative cohort of Indian subcontinent, has a good performance both in terms of sensitivity and specificity. So if I start applying now to our patients who are early or mild patients with Cushing's, I'm very happy to work with overnight dexamethasone suppression test or a salivary cortisol test. If I'm applying it to so-called metabolic syndrome or a polycystic ovarian syndrome, I might need that 4% of false positive to be eliminated, and I may go on low-dose dexamethasone suppression test, which is a little more cumbersome on an OPD basis because it is 2 days test. But of course, when I'm applying it in these group of patients who are pseudo-Cushing's stemming from depression, I would need a little more extensive workup, which is LDDS, 2 days test followed by CRH stimulation. And in this lady, any test, anytime is going to give super performance, and she'll never pose a problem in terms of test performances. Also, we need to understand that late night salivary cortisol is now going through huge changes, and now we have, as published in 2019, even the overnight dexamethasone test, instead of taking a serum sample, performs equally well to salivary sample, which is far more convenient because it can be collected at home and one doesn't need to visit a laboratory. Also, we are looking at the differences in serum steroid profiles of different strata of Cushing's syndrome, be it adrenal origin or ACTH dependent Cushing, and we realize there is a different signatures of steroids which emerge in these group of patients. Also, in patients who are ACTH dependent, by which we mean Cushing's disease and ectopic, there are signature steroids which can differentiate the two groups fairly effectively, as can be seen over here. Very distinctive signature for the pituitary disease versus the ectopic ACTH dependent disease, and that could be one of the arena where the work is in progress and could be something useful as a parameter to work with. Also, we realize that once we have sealed and delivered the fact that the patient does have endogenous hypercortisolism, which is a completely non-negotiable fact, because every single test that follows this test wrongdoing is going to go wrong in terms of localization. So after having conclusively said that it is a state of endogenous hypercortisolism, we need to then figure out the localization, and we need to understand the performance of different parameters which are available to us. ACTH is a good test. It definitely allows us to differentiate between ACTH dependent disorders versus these disorders like adrenal disorders, which are clearly ACTH independent. But we ought to respect the fact that there are a group of these patients who will either sit in this gray zone or clearly influence their presence in patients where the cutoff of 20 is used for ACTH dependent pathology. Clearly, we need to respect this, and they cannot be labeled as pituitary in origin or ectopic unless further clinical cues and workup is available in these group of patients. That having said, in ACTH dependent disorders, clearly we get into quandary related to patients with Cushing's disease, which is pituitary in origin, and ectopic, which is very largely coming from lungs and a small carcinoid sitting in the lung. Clearly the mode of treatment is going to be so very different, and no center which works with Cushing's disease can work without presence of bilateral IPSS as an established method which is available, established way back in 1981, as this published data suggests by James Friedling. But here, the refinement came about a decade later with the work of group from Lynette Neiman and her group, where it was very clearly shown that if CRH stimulation is used, the distinction between pituitary and ectopic disorders becomes so well demarcated, because this is such an invasive test, one cannot be really left with a questionable outcome after doing IPSS. In our own published data on IPSS, which was established in 1991, in our center, the patients who had equivocal outcome in terms of being ACTA dependent, but the MRI, which was not conclusive, we clearly showed that with CRH stimulation, the distinction of pituitary origin versus ectopic was very clear, except for this one individual, but there was a cannulation defect because of the non-formed petrosal sinus, which didn't allow the sample collection, and hence this patient could not be really differentiated on the basis of IPSS. So IPSS is a good test, but an extremely invasive test, and also the expertise may not be available across the centers. We have systematically worked with our radiologists to perform or increase the performance of our MRI over a period of time. And what we have realized is that working with a good pituitary dedicated sequence and wipe sequence in our case outperform the performance of MRI from just a dynamic contrast study where 67% of patients could be picked up with a pituitary MRI based finding of pituitary microadenoma. It remained close to 88% in wipe sequence where the MRI obviated the need of IPSS, which is truly a great deal for us, because going for an invasive test in a scenario where CRH is not easily available in our country could be definitely challenging. And in this respect, we are truly grateful for this extraordinarily pioneering work which has come from our country, from Chandigarh, by Rama Walia and Dr. Anil Bansali's group, who have put together the use of molecular imaging, which targets ACTH secreting tumors, which are corticotropinomas, and they worked with CRH stimulated DOTA scan, picking up all of pituitary microadenomas ranging from 2 to 3 millimeters upwards, which is such a big boon in terms of translating and hoping that this is available more often to all of us. And this took away the need of every single invasive parameter, because they proved their outcome on surgery and on pathology as well, which is truly a remarkable study to be proud of. Having said this, in terms of diagnostic challenges, let me shift gears and put together the management challenge in few of the slides. It has to be respected that there are patients out there at the end of the best surgical outcomes who might require, either because of the persistence of the disease or the recurrence of the disease, second line of therapeutic management. And these management principles are same across the pituitary tumors, very well put together by Dr. Ari Chacko in the previous talk as well. And do we really have the predictors of that? Well, actually, no. Only if it is MRI positive tumor, which is proven on histopathology, these are the individuals who have a lower risk of recurrences compared to the other patients, especially the MRI negative and of course, pathology negative patients who are most likely to recur. And when the recurrence happens, time and again, it has been shown by our center and across the globe, the recurrence happens at the same location. And that stands together to reason because of the sheer pathology of these tumors, who tend to have degree of invasion, which is either abutting the medial wall of cavernous sinus or the dura, and where the recurrence starts forming all over again after going through even the cure, which is proven in these group of individuals, necessitating long-term follow-up in these patients. So what are the performance outcome of different modalities of treatment? Well, radiotherapy, in terms of fractionated radiotherapy, has definitely performed well. The responses across the other aspects of radiotherapy are practically the same. There's a very good and high number of relapse rate, which is described with gamma knife surgery, which is very worrisome to my mind. The pituitary dysfunction does happen even with gamma knife, and that is one thing that we ought to respect as endocrinologists, really. And acute effects of radiation, which are seen in terms of cranial nerve palsies, are totally kind of avoidable to my mind as an endocrinologist. Comparing the response of fractionated stereotactic radiotherapy across different groups which are published, and our own data has suggested that stereotactic fractionated radiotherapy has good response. Though it is slow, it is a steady response, and it does not have associated complications in terms of cranial nerve palsies. But there is a caveat, and there is a caveat which has emerged in our mind, which I would like to bring to attention of our learned minds. And this is our recently published data, which clearly showed that if there is a therapeutic medical management which is used in interim period peri-radiotherapy, patients where either ketoconazole or cabergoline is used tend to show recurrence, and that is absolutely an unhappy news for us. So probably these medical drugs in some way act as radioprotective agent, and we need to be very conscious of it, is a message that I'd like to leave behind for these group of learned scholars who look after patients with neuroendocrine tumors. So if I put together our learning experience and the need of medical therapy, which is going to be addressed later on by Dr. Mary, so I'm not going to talk about it at all, but we are in an exciting time frames right now with newer compounds which are emerging, and I'm sure Dr. Mary is going to refer to that. It is an exercise of learning which continues to evolve, and your own group of postgraduates, through their extraordinarily inquisitive mind, keep teaching you. And I have learned all of it from my postgraduates. And it is always good to be on the same page with all the caregivers of this extraordinarily fascinating tumor, so that the patient care can be streamlined effectively. Ladies and gentlemen, thank you very much for your patient listening. And Dr. Dev Pujari, thank you so very much for this opportunity.
Thanks, Nalini. Many important messages for the neurosurgeons as well. And I'm sure you will stay for the discussion forum. We still don't have any questions, but I'm sure they will be coming soon. So I would request Dr. I would request Dr. Falbush now to share his screen, and to introduce him, I have requested Dr. Lokendra Singh. Sorry, Dr. Ari Chako. Ari, are you there?
Yeah, it's my honor to invite Dr. Falbush to give the next talk on principles of surgery in functioning microadenomas. Dr. Falbush is a highly respected neurosurgeon, pioneering a lot of work in transsphenoidal surgeries in Europe. I met him once in Erlangen, and then later when he moved to Hanover. Dr. Falbush.
Thank you very much, especially for inviting me.
Yeah.
Absolutely great job. Everybody can hear me? Yes. Absolutely great job for preparation of this wonderful meeting. And I'm glad to hear, to see, and to listen to many of the neurosurgeons who accompanied me in pituitary surgery over the years. When I present the principles of surgery in function microadenomas, I should present also some data about history, and starting with Harvey Cushing and his basophilism. He called these microadenomas minute adenomas. Later on, they were defined to be less than 10 millimeters, as you can see here. Successful management of these microadenomas can only occur when there exists a local cooperation of neurosurgeons and endocrinologists, at that time in Munich with Klaus von Werder, and later on Faglia and Giovanelli. There are a lot of famous couples who are also present here, but I just learned that you have in Mumbai also excellent experience in this field. So in 80, they were focusing only on microadenomas. And these were the results in the different types of functioning tumors, taking consideration at that time, we had no MRI, no navigation, etc., no effective medical treatment, and the gaining experience of the surgeon presenting their data there, having no larger series of micros than less than 170, that was Hardy, resulted in normalization remission between 70, 80 in ACTH-OMAs, GH-OMAs 83, a little lower in prolactinomas with 60. This was a cooperative study with Milan and Martheim and Erlangen, and the rare TSH-OMAs, which is a special topic and not possible to deal with this exactly. Today, we improved, of course, up to 20%, here 30%, in GH-OMAs not so much, because in GH-OMAs, meanwhile, there are stricter criteria for normalization. If we see this, microadenomas should be the domain of the neurosurgeon. However, we have just heard also by the endocrinologist that medical treatment is coming, although not very potential in ACTH-OMAs. At that time in 80, there was nothing. Very effective with carbaguline in prolactinomas. However, the same successful with surgery, very strong, effective with octreotide up to 76%, 67%. And I take this data also for surgery from Biller's publication with an endocrinologist. The goal of surgery is selective adenomectomy, firstly defined by Hardy in 1969. Of course, not possible in Cushing's autopsy cases at that time, based on morphological data, that is tumor removal and preservation of gland. It needed some years with introduction of radioimmunoassays that this confirmed also on a functional basis, elimination of hormonal excess with preservation of pituitary functions. And of course, we had to avoid complications, which in microadenomas is about 1%. I don't go into the details here. There's only one neurosurgical disease at all in which surgery is exclusively indicated on endocrine parameters, and that is Cushing's disease. And pituitary and glandular hormones are tumor markers, parameters for quality of the procedure. Assays and normal ranges are different in laboratories, not always comparable, and its sensitivity increased. So I report about my series published in 2008, over 15 years experience, starting with my first patients with hypercortisolism. At that time, with the normal cellular Toxica, who is here in clinical remission. He, like all the other patients in Cushing's disease, have microadenomas in 90%. This is a typical microadenoma. However, MRI is negative in 50%, also including dynamic sequences. I was very glad seeing that Dr. Shah just introduced new methods. Maybe the sensitivity of that can be increased in the future. What we want as neurosurgeons, as we have heard, we want, among the sophisticated tests, that we have confirmed a pituitary origin, that is 60% in general, and exclude an adrenal origin. Especially in cases with highly increased ACTH levels, central venous catheterization is indicated, especially to exclude ectopic sources. Petrosal sinus sampling is possible if no adenoma in MRI is seen to determine ACTH levels, to get a localization site of the adenoma, which is no longer so popular as it was maybe 20, 30 years before, but it is still a potential for hemihypophysectomy. I present a typical course of a patient with a 3 millimeter microadenomas. This was resected. Increased cortisol levels dropped immediately within days and weeks into the subnormal range, suppressed by 2 milligram dexamethasone into the normal range below 2 milligram, then increased over the time, and clinical recurrence occurred nearly after 9 years. But before, we could detect also already that dexamethasone had no longer a normal response. After reoperation of the adenoma, 2 to 3 millimeters, we had normalization in a subnormal range over 20 years. Recurrences occur in about 15%, and overall remission rate in microadenomas is 85%. Early subnormal cortisol levels, from my point of view, are the best prognostic factor. And what is very important for the early postoperative phase, that hypercortisolism must be replaced paradoxically with hydrocortisone. Coming to some surgical remarks for microadenomas, the entrance to the sphenoid sinus, the small sphenodectomy over the vomer area with incision of the mucosa here at the end of the surgery, small, no big mucosa resection is necessary, offers an excellent view into the sphenoid sinus with protuberance of carotid artery on both sides and the sellar floor, here normal, which has to be opened in microadenomas in up to 10 to 12 to 6 to 8 millimeters. Drilling is the best way to do so. If we have opened the dura to both sides to cavernous sinus, there can be some venous bleedings, also by intercavernous sinuses. Then the microadenoma becomes visible, in this case at contact to the sellar floor, and can be removed by microforceps, by microcurettes. This is a larger microadenoma. And if it is very small, the microcurettes have to be about 2 millimeters to get it. Sometimes hooks, in this case, are also very helpful. In negative MRI, that means adenomas below 4 millimeter in diameter, we have to perform a special cellular exploration with meticulous sectioning of the anterior pituitary gland, as you can see here and there, including periglandular inspection, because the tumor can be also developed extragranular towards or into the cavernous sinus. We have to respect also the periadenoma area towards enlarged adenomectomy. Hardy proposed to resect some pieces in the border to avoid recurrences or to get failures. It is Oldfield who propagated the pseudocapsule resection, but not all these tumors have pseudocapsules, mainly the more firmer ones, and not all are firm. And we prefer a 1 millimeter rim resection to achieve the best outcome. Why? Because in the capsule, we can find clusters of ACTH producing cells. Others are trusting ethanol injection into the cavity. I don't know who is still doing that. Navigation today can be helpful, especially in encased carotid arteries. like here. This can be injected into the eyepiece of the microscope, and you know always exactly where you are in the area of the cellar floor. Endocrinological long-term outcome should be explained by this slide. We can have basal elevated hormone levels, which are decreasing within hours into the normal range. Then we have the long-term normalization. They can remain unchanged or improved. Then we have a persisting hormonal excess. And in this case, we have to ask ourselves if we can do an early reoperation within some days or a little later. However, if we have a normalization of the hormone levels over days and many months, and still an elevation, then this is a clear recurrence. And in these cases, in ACTH-OMAs, we highly recommend a reoperation. As you can see, the tumors were nearly in all cases identical in location as at first surgery. We could normalize these tumors after reoperation in 56%. And if we take all the treatment together, including X-knife and adrenals, we could normalize 15 out of 16 patients. Our special locations of microadenomas related to preferred concentrations of hormones in the normal pituitary gland, as we can see here. And that means that ACTH-OMAs should be also located here. Is it helpful to find microadenomas smaller than 4 to 5 millimeters? I personally didn't have the impression. Summarizing our experience with ACTH-OMAs, we didn't find adenomas in 15% of the cases, 13% of the cases. We performed selective adenomectomies in 86%, had early remission in 75%, long-term remission 85%, and long-term control, including reoperations in 89% of the cases. Important to say that we have the same results in MRI negative adenomas than in adenoma positive. Coming to microprolactinomas, of course, here selective adenomectomy is highly indicated. We have a remission rate of 80% in the literature, in special series up to 92% even, and the best results if the prolactin levels are no higher than 8-fold elevated. No deficits has to be expected, and especially improvement of hypogonadism in 90%. Why? Because especially females have the wish of pregnancy, which can be fulfilled with additional help by the neurosurgeon. And this is supported, meanwhile, also in Casanueva's consensus paper, that in microprolactinomas, surgery in experienced hands, and if it's the patient's wish, is prior to dopamine agonists. Why I do mention Cyprus, this was my first patient in 1972, because an endocrinologist in Cyprus offered me a patient to be operated with microprolactinomas. I was so successful that he married these patients later on, and they had 2 children, like here, twins and 1 child later. There's one specialty in the course of prolactin levels in microadenomas postoperatively. This is a historical slide, that's why a little. The elevated levels decrease within days into the normal range and then increase up to 4-fold over the days, and the years remain stable. These are no recurrences. These are so-called relapses caused by functional hyperprolactinemia, may be irritation of the pituitary stalk. No adenoma were found in these cases. No reoperation is indicated. Observation and maybe medical treatment if the patients are symptomatic. In true recurrences, that is the opposite. Indication for surgery can be given, especially in this patient who had no respondence on carbagoline over 4 years finally, and finally no tolerance. It was an incidental finding after a mild trauma originally. Preoperative situation, prolactin was elevated about 11-fold to 168 nanogram per ml. You see the microadenoma just after surgery decreased to a nearly normal range. After 3 months, the MRI. After 6 months, re-increase of prolactin levels, and before surgery, after 33 months, to 216, even higher than before. And you see again the adenoma here in the area of the cellar floor developed to both sides. It is of special interest that these are risky tumors, as we have just heard before in the pathological lecture. And this patient had MRB1 of 7%, and also after second operation, 4 to 5%. After reoperation, the prolactin levels were 2-fold elevated to 3-fold elevated, and under additional dopamine agonist therapy, they are now in the normal range. It is important to say about microadenomas that long-term treatment results are not depending on long-term dopamine agonists. People have said in the past, they always develop fibrosis, which makes it difficult to remove the tumors. That may be true, but in microadenomas, I personally couldn't find a difference. Coming to acromegaly, there are special diagnostic and remission criteria, but based not only on one, but on two, in special situation on 3 hormones. We can have 3 situations, as shown here. IGF-1 is always elevated, here together with GH, in 30%, also with prolactin. And especially in this case, we have only IGF-1 elevation without GH hypersecretion, which is under OGT normal. This is an indication for surgery. Preoperatively, treatment with octreotide can be very helpful, especially to improve comorbidities. Maybe remission rates can be better if we have this pre-medication, but that is not confirmed by everybody. Postoperatively, there's an early remission of comorbidities such as hypertension, diabetes mellitus, which we have to take care of as neurosurgeon. Don't continue to treat these patients with antihypertensives and anti-diabetic medication. Surgical specialties, as we have thickened bone structures in the sphenoid and the cellar floor maybe, and can require long-term drilling, and mucosa can be swelling. Acromegaly has this specialty for neurosurgeons that there are regular consensus conferences of pituitary societies since 2000 in Monte Carlo, guided by Justina and Mermet. You know the publication and the consensus papers. And there are also national acromegaly registers in Germany, and especially in the United Kingdom. And despite these excellent results in the best hands I've offered you, in the whole population of acromegalic patients, only 39% of these patients have normalized IGF-1s. And if we overlook surgery versus medical treatment, then the costs are much lower. Reimbursement in Germany is about 8,000 euros. The yearly treatment with octreotide is 33,000 euros, and with pegvisomant against IGF-1 elevation, more than 100,000. That means surgery should be the domain in microadenomas, in acromegaly, also in larger adenomas. And to say this in front of the neuroendocrinology committee, training in neurosurgery is essential to get this position. And this is expressed also by our learning curve in my former department. We have a publication here, myself, who did the majority of the cases, but also my juniors at the time, Buffet and Nomikos. We could improve in time since 82 till 2003 from 75 to 89. That means in 50% of the cases. So even we could improve, and we have to train all the interested neurosurgeons to come to similar results. The remission overall rate in microadenomas is 81%, is overlooked from literature, and it differs between 63 and 100%. And take in consideration that the actual criteria are these for normalization: IGF-1 normal, OGT, GH below 4, or random below 1. If we take these hard criteria, no recurrence is observed. However, it can occur, of course, rarely, in 3 among 290 patients with remission. That means 1%, and you see here the data below 1 nanogram. Coming to the question, microsurgical removal using the endoscope, using the microscope, there are a lot of publications. And I don't think there is a difference, taking death, complications, extent of tumor resection, and especially not in acromegaly, coming from Oldfield. Jane's publication, same results in microadenomas and in macroadenomas. That has nothing to do that endoscopy has a nicer view, is more modern, more people are using this. But on the other hand, endoscopy, from my point of view, was not able until now, after 20, 30 years of using it, to offer better results. Summarizing the reoperation in functional active microadenomas, in ACTH-OMAs, independent from negative or positive MRI, if we have hormonal persistence, we should do early reoperation. Some do it below 4 days, some a little later, after a week. Why? Because alternative medical treatment is weak, although it exists, but is weak and not comparable. In true recurrences, of course, reoperation and remission rate is 60 to 70%. Different to prolactinomas, where we have no real hormonal persistence. In these cases, we have a reoccurrence of relapses, no operation. But if we have a real hormonal persistence, then we have a strong medical treatment with carbagoline and should do it. In true recurrences, we should do reoperation only if dopamine agonists are not helpful and the remission rate is very low. In acromegaly, if there is hormonal persistence, of course, and MRI is positive, reoperation. Please take in consideration that we have a delayed IGF-1 decrease up to 3 months belonging to the long half-time. And we have, on the other hand, also a strong medical treatment, but we should always think about reoperations. In persistent acromegaly, we can obtain remission in 40%, in recurrence in 60 to 7%. All this would not be necessary if we could avoid failures. For example, by optical imaging, having a luminous adenoma in fluorescent color, different from normal pituitary tissue. I hope this will come in the future, similar to ALA fluorescence, which works in a special percentage of adenomas, but only in non-functioning adenomas. Coming to the end, I would emphasize the importance of close cooperation between endocrinologists as neurosurgeons. And I think this is also the duty of this committee, the Neuroendocrine Committee, to continue this close cooperation to the benefit for our patients. Thank you very much.
Thank you, Professor, for this wonderful talk and sharing your huge experience about functioning microadenomas. It was really very interesting. Now, may I invite Professor Nelson Oyesikwu, and he will talk about surgery for large functioning tumors. Professor Oyesikwu is Professor of Neurosurgery and Endocrinology. He is a co-director of Embroid Pituitary Center, Program Director, Neurosurgical Residency, Department of Neurosurgery, Emory University School of Medicine, Atlanta, USA. Professor, stage is yours now. Thank you.
Hello? Can you hear me?
Yeah.
Can you see my slides?
Yes.
Yes.
Wonderful. Well, good morning, good afternoon, good evening, everyone. It's a great pleasure to be here. Congratulate the organizers for a wonderful assembly of great luminaries and attendees. So I'm going to talk on the surgical management of large functioning adenomas. I'd like to first start out by acknowledging my chief resident, Dr. Rindler, who put this talk together for me. She's a budding pituitary surgeon. So thank you, Rima, for doing that. So essentially, before we delve into this, the question is, how aggressive should one be in this particular series of tumors that are functional? First question you have to ask, are there any surgical, non-surgical alternatives? And if not, then what can surgery achieve? And that is really predicated on the size, the configuration, and the invasiveness of the tumor. And of course, a critical decision point is the impact of vision. So in the case of Cushing's, obviously, we know that there are options available, as seen in this graph. There are drugs that target cortisol production, target the receptor, and so forth. In the case of acromegaly, we know we've got somatostatin receptor ligands, octreotide, lanreotide. We've got dopamine for the co-secretors of prolactin and growth hormone. And then we got the receptor antagonist. And in prolactinomas, we have cabergoline and bromocriptine. The goals of surgery are obviously to, one, decompress the anterior visual pathways for vision, and of course, to allow a maximal safe resection to achieve the goal of biochemical remission, or at least significant cytoreduction and reduction in biochemical activity. So the areas where these tumors can grow to or grow into from the cella include the suprasellar region, the clivus and the sphenoid, and of course the cavernous sinuses bilaterally. Suprasellar extension requires the extended approaches in the sagittal plane, and we also use the lumbar drain because we believe it's helpful in terms of delivering the tumor and also managing intracranial pressure. So in the case of the suprasellar extension, obviously this is the cella, cavernous sinuses, so that requires drilling of the tuberculum and planum to get access to the suprasellar region. One has to transgress the intercavernous sinus and achieve control of bleeding air, and that takes you into the cisterns and so on. And then this is an extended view of that, showing the under surface of the chiasm, the pituitary stalk. For tumors that require further extension or that have further extension into the suprasellar region, the diaphragma cella has to be sectioned. And of course, that goes all the way around the gland. And tumors can extend into this recess here into the oculomotor, the third nerve, and that can be seen nicely on MRI scans. So you'll know to do that. In terms of the sphenoid, sinus, and clival erosion, these require approaches in that recess to explore the recess. Drilling may be required to expose that fully, and then dural resection if the tumor extends intradurally. So this is the target for the clival region that one would have to expose. And if you had to remove the dura, of course, that would take us into the ventral brainstem. Functional tumors can and do invade the cavernous sinus, typically the medial cavernous sinus, and that medial cavernous sinus wall may need to be resected to achieve gross total resection. And these extended approaches sometimes may involve the transpterygoid approach lateral to the carotid to achieve significant debulking around the cavernous sinus region. So this is looking at that from, this is the the gland here, obviously carotid, and this is the cavernous sinus extension region that you often will see, and this is on the contralateral side. So let's look at some cases now. So let me start with a case that of an acromegalic that has complete tumor is limited on both sides, not extending significantly into the cavernous sinus. It does efface the anterior visual pathways. Patient presents with classical acromegaly. So here's the case. We're approaching the cella here. And in this particular case, we're going to do this classically with the dissection of the pseudocapsule and what we'll do is open the dura gently, as you see here, to preserve that plane of dissection. And that dural opening will extend on both sides of that vertical incision, as you see there. And as we do that, we'll continue the dural resection or incisions to reduce the intratumoral and intercellular pressure. And that allows the tumor to prolapse gently into the sphenoid as we encircle the tumor on both sides, taking it away from the medial wall. You see here, we're using that instrument very carefully. And then lifting the tumor up from below and away from the medial wall of the patient's left cavernous sinus. And we're doing the same thing on the opposite side here. And you can see that the tumor continues to gently deliver forward. Here we're going on the other side again removing the tumor from the wall of the medial wall of the sinus. Again, the dissection continues, respecting that plane of dissection. And then you can barely begin to see the arachnoidal membrane up here as the tumor delivers from the suprasellar compartment. And we're gently dissecting away from the arachnoidal membrane there. And you'll see the arachnoid layer there and the tumor wall here. And we continue along the side on both sides. And there's the arachnoidal membrane, there's the tumor. And then gently, with blunt, careful dissection, separate the tumor pseudocapsule from the arachnoid. You can see the arachnoid is semi-permeable membrane, just a little weeping there, and just gently delivering the tumor using that plane of dissection. You'll see here towards the final stages of the delivery of the tumor. This is the back wall of the cella. This is the tumor membrane. And then the final steps with delivering of the tumor, you can see right here. So that's the classical situation. How about the non-classical? Here's a case, another case of macroprolactinoma. This 25-year-old male with 3 months of declining vision, low energy, and low libido. Here's the tumor here. You can see that the anterior circle of Willis is plastered to the superior surface of the mass. There's some cystic hemorrhagic change, optic nerve compression. There's an OPS2 on the patient's left. Prolactin was 4,600. Surgery was recommended to achieve significant optic pathway decompression. So here's the case. We're exposing the suprasellar region by drilling the area of the tuberculum. And here's the kerosene to further that exposure. You can see that the tumor is has already invaded the dura at the bottom of the cella. And here we're taking away the dura from the tuberculum. We're going to cauterize that area to gain access into the suprasellar recess, opening the dura there. And you can see that there's a fibrotic element to this tumor. It's not as soft as the other one we just saw. This one's a little bit more fibrotic and tenacious and does have invasion into the dura. And as you can see that on the MRI scan, it had transgressed the arachnoidal membrane as well. And so the plane of dissection is not as clean here as you saw a minute ago because of the invasive nature of the tumor. And so we're carefully peeling it away off of the edge of the dura here. Again, trying to find that plane of dissection around the tumor and then delivering it. This in particular case, it has invaded part of the left cavernous sinus. There was a NOPS2 there. You can see the arachnoidal membrane here, and that's the plane of the tumor. And this is the diaphragma cella here, right up there. So we're looking below the diaphragma cella and above the diaphragma cella. We can see the top part of the tumor there. and we'll continue the resection. This cautery is to cauterize the dura of the diaphragm and then cut it. And then that allows us to see the back of the tumor below. There's still some tumor fragments here that we'll clean up at the end. And this is gains interest and entrance to the suprasellar system, and that's the dorsum cella. So that's that case. This is the post-operative course of that patient. Prolactin went down, didn't go to normal, 390, but we have alternatives. Put the patient on cabergoline, and we're able to get euprolactinemia and restoration of vision. Here's that case I showed you. That's the post-surgical changes and involution of the tumor. Here's another case. This is another acromegalic, a giant growth hormone secreting tumor, came with new onset, presented with new onset seizures, but classical phenotypic features of acromegaly. You can see here, this is a nasty looking tumor, goes all the way into the ventricle, all the way down. Here's into the infratemporal fossa. It's just a miserable looking tumor. There's obstruction of the third ventricle, it's multi-compartmental and so forth, invades the clivus and so on and so forth. We first put a shunt in this case and did an endonasal biopsy. It showed a growth hormone secreting tumor with an IGF-1 in the 600s, growth hormone of 4. So we did a stage operative resection here, an orbitopsychomatic approach from the right region, and then an expanded endoscopic approach to complete the resection. Here's the, show you the final view of that case. Because of there's time, we don't have time to see it all, but here's the, on both sides, this is the exposure and the resection cavity after we finished. And then place some fat graft in the area, and then put a flap up there. I'll show you the flap in a minute. Flap comes over to cover it because we've got a big hole, and gently put that in place. And some Surgicel and so on. And this is how that case looked like at the end of the resection. You can see the ventricles on both sides. There's some residual disease here. This is your fat graft, and this was the big tumor cavity in the sagittal plane. Pathologically, it was a stain positive for both growth hormone and prolactin. Growth hormone came down, but there was the need for continued biochemical treatment for some residual tumor with octreotide. Here's another case of an acromegalic with a 38-year-old male, growth hormone 600s, IGF-1, sorry, 622, growth hormone 74, that is high. This is how that tumor looks, NOPS3A and 3B, very nasty looking tumor here, invasion on both sides. And there's the tumor with some clival invasion as well as into the sphenoid. This is the case here. I'll briefly show this case, and you can see this is the exposure. This is the tumor descended all the way into the sphenoid. It's invaded the dura, invaded the sellar bone, and part of the sphenoid sinus mucosa. So very difficult to get around the typical plane of dissection. So we're working here on the patient's left side where the majority of the cavernous sinus invasion is. And there's an opening right there into the wall that we'll work through in a minute once we can decompress some of that tumor so we can see that opening on the patient's left side. And those tumor fragments that are reachable, we're going to reach those using the curettes and then deliver them with the pituitary forceps. And we're gently working around that, as you can see here. This is the wall, the medial wall back here. There's tumor right in there that we're going to carefully, through the hole that the tumor, using the hole that the tumor used to invade the cavernous sinus. And we're going to use that to assist the delivery of the tumor using this approach with a curved endoscope. And see in a minute as it comes through the tumor fragments that have invaded that left cavernous sinus. There's another one, another tumor fragment. You can see that hole. And there's the end of the case. You can see that there's still some residual tumor, but there's been some significant debulking, and the optic mass effect has been alleviated. Path was, of course, stained both for PIT1 as well as growth hormone, densely granular, persistent elevation of IGF-1 and growth hormone, but down. Patient was started on lanreotide depot. Here's another case, a recurrent invasive ACTH adenoma that had vision changes, had TSA and craniotomy ×2 and FSR, presented with progressive disease. You can see here NOPS4 on the right, tumor invading the sphenoid and clivus area, horrible looking tumor. Anterior circle of Willis is involved with the tumor. Here's the operative field. Tumor within the sphenoid sinus. We had to get through that with the microdebrider. And you can see that the old scar tissue from previous surgery here and there. And so we're gently working through this, opening the sphenoid sinus, mucosa, the scarring. You can see there's tumor into there and into the back of the clivus. So in order to get to the cell, we have to get through this wall of tumor. This is the clival recess that we're drilling to improve the exposure. This is tumor here, obviously. And then we get into the tumor. You can see there's a fair amount of fibrosis. This is the tumor wall. And we just gently have to work at it, because these invasive tumors, very difficult to get around to establish planes. So it's a lot of work to go back and forth through the plane and the bone and the mucosa to continue to follow that trajectory. Here we're drilling the superior portion, the tuberculum, and so that we can gain access into the anterior superior area of the tumor. This is all scar tissue and tumor within the cavity, and we're working around that to deliver it piecemeal, as you can see here, debulking the tumor progressively to gain further access. This was a very aggressive tumor, as you could see on the MRI, and at surgery that certainly proved to be the case. We're just delivering the tumor here. So these large functional tumors can really be a difficult challenge, as you can see here. So we're now into the cavity. You can see better inside of the cavity. This is the superior portion of the lesion. You'll see on the MRI scan that there's residual disease. This is the post-op MRI coronal and sagittal. This portion of the tumor above the scar plane was difficult to reach because of the scarring. So we came back at it. We're going to come back at it with a different therapeutic option, probably either temozolomide or pasireotide. This is a giant prolactin adenoma, came with vision changes, confusion, presented to the ED. Here is what it looked like: a NOPS4 invasion on the left, extension into the third ventricle, obstruction, hydrocephalus, sphenoid sinus and clival invasion, and so on. And you can see, I'll show you how this looks. This is the exposure. You can see the bone is chewed up completely. We're going to decompress the bone, and this is the tumor here. And there's a lot of tension in this tumor. Open the dura. This is tuberculum that's been drilled off and part of the planum. Some invasion of the dura, you can see here. Opening the dura. And you can see there's your tumor right there. It's invaded the dura down into the sphenoid sinus. And here's where the NOPS4 invasion on the left cavernous sinus is. So first we're going to address this portion of the tumor. Again, trying to find as best as we can the plane of dissection. We have to debulk the tumor in order to see behind it because it's such a large mass. The elevated seen below it. ICA is back here, medial wall of the cavernous sinus. This is where the tumor invades the cavernous sinus. On the patient's left. Here's your optic chiasm up here, arachnoid below the third ventricle. You can see CSF beginning to emanate as we decompress the tumor from the third ventricle floor, and that allows CSF to deliver through there. That's a good thing because we know we've got the floor of the third ventricle open. And then now we're in the suprasellar region, and we're delivering tumor from underneath the chiasm in front of the brainstem. We'll see the brainstem behind in a minute. It's a very large tumor, as you can see. Using a curved suction to get access behind and above our line of sight. You see gently delivering tumor again. Now we can see into the third ventricle bilaterally and into the lateral ventricles there on both sides, and then coming out with the endoscope. And this is what it looked like after all of that effort. So you can see that there's still encirclement of the carotid here, and there's tumor behind the carotid on the sagittal. Path-wise, it stained positive for both prolactin and growth hormone. Patient was started on cabergoline, vision has improved, and the hydrocephalus is resolved. Last case is a 44-year-old lady with visual loss in the left eye with a suprasellar mass, adenomas. You can see that this is the gland back here in the inferior portion compressed by the tumor. Most of the tumor grew above the gland and retrocellar into the area of the ventral pons. So here's this case, and what we've done is, pretty, as you've seen before, an expanded approach. This is the transtuberculum, transplanum. This is the cella opened. Clivus is also being drilled here as well. Clival recess, excuse me. Cella is opening right as we speak with the, and then we're going to go across the intercellular cavernous sinus up there ventrally. And then, as you'll see in a minute, we'll open that area in a minute. We'll see arachnoid will come into view. There's the tumor just coming into view. Looks a little red, hemorrhagic, angry looking tumor right there. It's a little fibrous band. And then after the plane has been established, the tumor is kind of loose, so we can deliver it with its inside core is soft and the fibrous bands around it. Your chiasm is up here, suprasellar cistern is here, and there's your anterior circle of Willis and the undersurface, and there's your ventricle. And so there we go. So that's that case. So, and this is the post-op MRI scan and near total resection here, and this is the repair and so on. Pathologically stained for TBX19 and ACTH. So these tumors, these large functional tumors can be challenging in terms of their size and their multi-compartmental nature and the tendency that they have for invasiveness of the adjacent neurovascular structures. And so sometimes gross total is not accomplishable and you have to settle for significant tumor debulking. But mindful of the fact that there are other options for treatment in these tumors to achieve biochemical remission and tumor control. And your approach and the strategy, again, of course, depends on anatomy. And you have to adjust your surgical approach sometimes. And the key at all times is obviously to minimize morbidity as much as possible. So Sheikh, thank you very much for having me, and it's a pleasure to be here this Saturday morning.
Thanks, Nelson. Ari, would you please introduce
Yes,
Dr. Kundwell? And
yeah, I will. It's my pleasure to introduce to you Dr. William Caldwell, who is professor and chair of the Department of Neurosurgery at the University of Utah. Dr. Caldwell is a past president of the WFNS. He's come to India on many occasions as an invited speaker, and his vast experience in skull-based surgery comes across very clearly in the precise way he speaks on these very difficult surgeries. Dr. Caldwell, welcome.
Thank you so much, Ari. It's an honor to be here, and it's great to see so many friends and colleagues from India and around the world. Let me share my screen. So I was asked by Chandrasekhar to speak on functional tumors and transcranial approaches to functional tumors. And I thought, well, this is a fairly narrow topic, but I thought I would use this to sort of complement what Nelson has done. He's done a beautiful job talking about surgery for functional tumors, mostly endonasal. And I'll talk about the tricks that I've used, the mistakes that I've made on addressing some of the larger and more invasive functional tumors. So we're now over 110 years of transfenoidal surgery. This is Schlaffer's original diagram. I think it was sort of ironic that Cushing initially was interested in the transnasal approach, but then was trying to promulgate his transcranial approaches and really focused on transcranial approaches to the suprasellar region because he felt he could see it better. And of course, there wasn't a good light source like there is now, either with a microscope or an endoscope. So this has been going on a long time, and I really want to credit Jules Hardy because he's the one that repopularized the transnasal approach in North America. And when I was a medical student at McGill in Montreal, Jules was one of my mentors, and he was in the heyday of his career at that time. And we recently had the opportunity to look back and look at some of the contributions of he and Guillaume. And it's interesting because the use of the operating microscope as introduced by Guillaume and Hardy really allowed us then to do a adenomectomy of the tumor and preserve the pituitary function, and hence was really the birth of functional pituitary surgery. And Jules is still living in Montreal and is very sharp. And he and I wrote this paper on Guillaume, brilliant man, and all the contributions that he's made. But Hardy had published this paper back in the late 60s and early 70s, where they looked at the indications for transcranial approaches. And I think it's as relevant today as it was back then. And if you look here, transcranial surgery was really with large suprasellar extension. And I'm talking about those extensions that go beyond the diaphragm celli. If the diaphragm celli is elevated, it's not usually a problem getting the whole tumor to come down, irrespective of the size. But if you have suprasellar mass, the snowman tumor, the multilobulated tumor, these are the ones that are hard to get to descend. And we often look towards transcranial surgery approaches. So this is just to remind us of the brilliance of medical therapy. This was a gentleman who came in comatose with this giant prolactinoma. And he was NLP in his left eye. And what would you do? So he's had apoplexy, we felt. And so I did just an emergent decompression transnasally, and we got his labs back after surgery, and he had a prolactin level of close to 1 million, which is the highest I've ever seen personally, and some low testosterone, and very dense prolactin staining. And you can see my transcranial approach. I only removed part of the tumor, but I did decompress the hypothalamus and his optic chiasm. And in 6 months, the tumor is literally gone. So that is a very lucky and a perfect outcome. And you can see this with these giant prolactinomas. But what are the goals of treatment of functional tumors? We want to eliminate the mass effect, reduce hypersecretion, obviously, preserve normal pituitary function, and then minimize the chance of recurrence. So in most functional pituitary surgery, we want to really remove the tumor as best as we can. And I really want to just call out, I mean, Ed Laws, who I saw on the call earlier today, Marty Weiss, who are real pioneers in really extending the suprasellar exposure, the lateral cavernous sinus exposure, and the transfer for other tumors besides pituitary tumors. But these techniques have enhanced our ability to approach invasive pituitary tumors as well. And initially using the microscope and then of course with the endoscope, it made it so much easier to come laterally and address the tumor adjacent and around the carotid artery and do it safely with an endoscope. And no matter what approach you use, the endoscope gives you a much better view because it puts your eye at the cellar. Now, Engelbert Nosp provided this terrific grading scale, which really gives us a prediction of the cavernous sinus invasion based on the laterality of the tumor and the carotid artery. And it's been our experience that if you look at many of these tumors, you've got to really take a look at surgery and see if you can preserve and you can remove this tumor, even if it goes lateral to the carotid. So this is not encasing the carotid. But if you take a look at this with an endoscope, a side angle endoscope, you can see that in many cases, the medial cavernous wall pantaloons around the artery, and you can do a more effective removal than you think you may by looking at the scan. And in this case, we were able to actually get her growth hormone down and controlled just by skeletonizing all the tumor from the medial cavernous wall that was pantalooned around the carotid artery. In obvious cases, obviously, if the cavernous carotid is surrounded, there's no question that that's invaded, and as would have been predicted by Engelbert's classification. So when do we use craniotomy? So it's only a minority of patients in our experience. It's used about 1 to 4% of pituitary adenomas. And as I mentioned, this constriction of the diaphragm cilia is one. Paracellular extension or inaccessible suprasellar extension off the midline. Fibrous tumors that are difficult to bring down and we don't want to pull from down below. Active sinus infection is a lesser contraindication in my mind. Aneurysm may be a contraindication. Ectatic intracellular carotids, and I'm going to talk about that with acromegalic patients. Brain invasions, and obviously cranial neuropathy from cavernous sinus invasion, and I'll talk about that with a case. So this is just an important heads up. This is something that Anna Osborne taught me, that when these tumors grow, they grow into the cavernous sinus, and Nelson talked about this, but you can predict the cavernous sinus growth and the supracavernous component based on the growth patterns of the tumor. And the oculomotor cistern is the cistern around the third nerve as it enters the cavernous sinus before it gets into the cavernous sinus proper. You can see this on a T2 image. And you can see obliteration of this in tumors that invade the cavernous sinus and then engulf the third nerve. So here's a cartoon that shows it. But basically what you're going to see is you're going to see a separate head of tumor come out the roof of the cavernous sinus. And here's such an example. And you'll never see this component if you do a standard transnasal and don't open up the diaphragm. And so you'll have to use a separate approach. And I use a separate approach to address this tumor because it's coming out of the roof of the cavernous sinus. And you can see we've left it here. We've left postoperative residual, which in this case actually ended up undergoing apoplexy. But you can look at the scan very carefully and predict if you've got suprasellar extension through the cavernous sinus instead of the diaphragm, and which may be inaccessible through a standard transnasal approach. So here you look and you can see there's this lateral component on the roof of the cavernous sinus. And then you get into the main part of the tumor. And this is posterior usually. It's extending out the back of the cavernous sinus, following along where the third nerve enters. And this you would predict would be a cavernous component that's gone through the roof of the third ventricle or of the cavernous sinus. And in a standard axial view, you'll see this. It looks like there's cavernous sinus invasion, obviously, on the right side. and then you've got this separate bud of tumor coming out posteriorly. So an important tip, and I always look at the scans very carefully. Now in a case like this is cavernous sinus invasion, but it's still held within the cavernous sinus. And you can use a couple of different tricks to try and remove that. Obviously you can come in transcranial and lift the cavernous wall and remove that. But we'll try at the time of surgery transnasally to try and reduce that. And I'll show you how that's done. So if you have a soft tumor, you can actually extrude some of this tumor using some of the tricks like jugular venous compression, Valsalva, etc. during surgery. And I'll show you, if you see the extent of cavernous involvement here, it's all within the dura of the cavernous sinus. And you can come through both these corridors. You can come through in the anterior loop of the carotid here, and then below and lateral to the carotid, transnasally, and perform a Valsalva, or the big gun, as Ed Laws taught me, is bilateral jugular venous compression. And this gives you a Valsalva that's a super Valsalva. And then you can actually sometimes extrude the tumor from the lateral wall of the cavernous sinus in through the transnasal approach and reduce some of the tumor. So you might try that on some cases, and I've used that. It's worked actually fairly well in several cases I've done. So what are your options? Well, you can perform a single transsphenoidal approach, you can do a transcranial approach, or you can combine them. I have combined them. I'm not a big fan of combining a contaminated approach with a clean approach, but it's actually very effective. You usually have two surgeons come from below and one from above. But let me show you the technique that I would use. And usually we're using a frontotemporal approach for a tumor that's involving the suprasellar area and has multiple compartments. And I think this case exemplifies it. This is an acromegalic. And if you look at the tumor on this case, she's had a transnasal approach and was fibrous, and we couldn't get it to drop at all. And there's multiple components to this tumor. So what we'll do is we'll come in, this is the classic case of the multi-head monster, and we're going to have to find components and compartments that we empty transcranially. So I'll use a frontotemporal approach in these cases merely for the reason that it gives you so many more options when you come in frontotemporally to work through different corridors. And so we'll open up a frontotemporal approach, and you can see here's the left optic nerve, and we'll go ahead and then enter each of these little compartments and then remove the tumor from them. And this is why it's very, very difficult to remove them from below, because you just can't, when there's multiple compartments like this, you just won't be able to get the tumor to drop from a practical standpoint. So open up the fissure widely and find these different compartments. Search, try to match up what you're seeing at surgery with the MRI scan, and making sure that we don't leave a compartment that's been unaddressed, and open up the arachnoid and then remove the tumor. And we'll spend a lot of time going through all the different compartments, the chiasm and the around the third nerve, under the PCOM artery, through the I think I've come through the lamina terminalis in this as well. You'll see here's A1, and expose through the region of the lamina terminalis, both lateral and medial to the carotid. And here we're in the lamina terminalis and removing the remainder part of the tumor. So we'll spend a lot of time trying to remove all these components separately. So what about the cavernous sinus, which is a common area for invasion? So if we do have cavernous sinus involvement with the tumor, we have to decide whether we're going to do an aggressive resection there. Now, I won't do a cavernous sinus exposure with the primary presentation of a functional tumor. We'll always radiate the patient and use medical therapy first. But if they failed radiation, or if they have double vision and diplopia already, I think that gives you some freedom to remove the tumor within the cavernous sinus. And we'll go ahead and do a standard Dolenc approach. and remove the tumor from the different compartments and triangles within the cavernous sinus. And you want to be very careful, but if you think about the way a pituitary tumor grows, it's growing from the sella laterally. So it's going to push 3, 4, and 6 laterally. And 3, 4, and 5 are going to stay near the lateral wall of the cavernous sinus. So here you've got a recurrence of a woman with a tumor in the cavernous sinus primarily. It's in the sella as well, but she's got diplopia. So I'll use this as an indication to be more aggressive. She's been radiated already. And we'll lift up the wall of the cavernous sinus and find our window. So here's the 5th nerve, superior orbital fissure that's being drilled, the 5th nerve. And now we'll find, this is within Parkinson's triangle right here between 4 and V1 that will come in, and the tumor was presenting to the surface, and we can go ahead and remove the tumor. Now, I'm not worried about the 3rd nerve, the 4th nerve, and the 5th nerve because they're lateral. What we're worried about is the 6th nerve because it's traversing with the growth of the tumor. It's being encased and engulfed by the tumor as it grows. So we'll go ahead and remove the tumor from the cavernous sinus in this case, since the patient already has diplopia. So that's a good indication in my mind for a transcranial removal. So let's just talk about prolactin tumors for a moment, because some of these tumors will require aggressive surgery, even if you think, and even if they respond initially to dopamine agonist therapy. Here's a gentleman that was 18 years old, and he had prolactinoma that was treated. He had a CSF leak, and he was from California, and he had surgery where they just put a nasal septal flap over the tumor and stopped the leak. But then he failed with his medical therapy. The tumor grew, and I would like to make the case that I think on these cases that if you do have to operate for any reason, you should try to remove the tumor, try and reduce the occurrence. And a percentage of these prolactinomas will lose their sensitivity to dopamine agonist therapy. And the mechanism of dopamine agonist resistance, including reduction of dopamine receptor DR2 receptors expression, and then post-receptor mechanisms. So we should really attempt removal. If we're operating on any patient with a prolactinoma, we should try to remove as much as we can for that reason. I'd like to talk about acromegaly for a moment. This is an unbelievable case that I was involved with and I operated on in Europe, in Eastern Europe. This is a gentleman that was untreated acromegalic and giant in his 40s. And the tumor was all up in the 3rd ventricle, as you can see here. And there was very, very little in the cell, but most of it was up in the 3rd ventricle. He had some hydrocephalus. And the point that I'd like to make here is that you have to be flexible enough for them when you operate on cases such as this. He was so large that the standard instruments wouldn't reach transnasally, and we had to use instruments from other specialties to try and get in there and remove this tumor. Now, we were able to remove it endonasally, but I was prepared to perform a craniotomy and come transventricularly since his ventricles were so big. Just a word of warning with operating on these acromegalics, either transnasally or transcranially, is that you can see enlargement of the carotids. And this often narrows the intercarotid distance in these patients and reduces your corridor when you come transnasally. And it's also an issue when you come transcranially. And we've actually injured the carotids on patients that have had these very, very narrow intercarotid distance because the original, the tumor is causing enlargement of the artery. When we study this, it's very interesting because the carotid is enlarged within the region of the cavernous sinus. And I presume it's because the carotid is being bathed in growth hormone. But I have not any way of proving that directly. And the reason I say that is because this is quite a specific enlargement that's most seen within the cavernous segment of the carotid. And we did a study where we looked at 40 acromegalics, and you can see they all have enlargement of the carotid. Some of them are profound, which reduces this distance. And when we broke down the arteries into segments, the most involved segment was the intracavernous component. And then they have increased aneurysms, and other authors have published about this. So fair warning that I think it's hard on the arteries, and they end up with aneurysmal dilatation, both fusiform and Berry aneurysms in these patients. There's no correlation with the size of the tumor. Here you have a smaller tumor with very large carotids and a big tumor with not so large corona. There was no correlation with the side and whether there was cavernous sinus invasion at all. So it's a fascinating phenomenon. I believe it's venous blood just bathing the artery with growth hormone, and we're doing some animal studies right now to see. So in acromegalic patients, you've got to be careful. The arteries are big, the corridors are narrow, and you've got to be very careful with operating on them, no matter how you come at the tumor. And lastly, I want to talk about Cushing's disease. It was a beautiful talk earlier on the medical therapy of Cushing's disease. This is our nemesis. These are the most difficult patients and confounding patients for me. You can have these tumors, they do beautifully, and the recurrence rate is high, as you know. But I'll use some of these tricks to try and increase the efficacy of therapy. So here you have recurrent tumor in the cavernous sinus, suprasellar extension. So we'll use a combination of approaches in cases such as this. So we'll come in transnasally, we'll remove the tumor from the region of the sella. We'll come in transcranially, and we'll do an extradural cavernous sinus resection. Sometimes we'll go into the cavernous sinus if they failed radiation therapy as well. But one of the tricks that we'll use is trying to protect the pituitary for radiosurgery. So this patient had radiosurgery. You can see radiation change in his temporal lobe. But what we've done over the years is we understand that there's a high incidence of pituitary or hypopituitarism from radiation, whether you use radiosurgery or field treatments. It's much less with radiosurgery. But what you can do is, it's amazing how durable and resistant the pituitary gland is to motion, in that you can remove a giant tumor such as this, and as you know, you'll have retained pituitary function in many cases if the gland in the stalk is left intact. So what we'll do is we'll actually remove the tumor within the region of the sella up to the cavernous carotid, and then we'll push the pituitary gland over, and we'll hold it over with fat graft. And I've used also other substances, absorbable stuff to hold the pituitary over, but we'll use fat in most cases, and then go ahead and treat with radiosurgery. And the idea of this is gives you some distance and some buffer zone around the radiosurgery target to try and reduce hypopituitarism. We published some years ago that this is a good technique to preserve pituitary function. We'll also remove a little bit of the lateral part of the gland to try and make sure that we get control from an endocrine standpoint. A lot of these were Cushing's patients that I've used this on, and the pituitary function can be preserved. So in conclusion, most functional tumors are removed by the transnasal route. A minority will need craniotomy, and I'll usually use a frontotemporal approach unless the tumor is growing in a specific corridor. And if it's giant and it grows through a corridor and it's going superior, sometimes we'll come in transventricularly. I've come in transcallosally. If accessible medical therapy is not an option, obviously these are big surgeries, often in large tumors. It's most commonly in growth hormone secreting tumors in my own series, and prolactinomas that lose the D2 receptors. Cavernous sinus invasion is common, especially with Cushing's disease patients. And Nelson talked about always trying to remove the medial cavernous wall, which we do as well in Cushing's patients. And all that fail radiation therapy, and consider cavernous sinus exposure in cases where they've failed radiation or if they have double vision already. And I thank you very much for this opportunity. It's an honor.
Thanks, Bill, for a very comprehensive talk on the need for transcranial approach in these patients. There are several questions, but I would like Dr. Noss to give comments. He hasn't spoken yet before he starts his, gets ready for his talk. And two questions I think the panelists have asked, which are very relevant to the functional tumors. I would ask Andre Grottenhuis and Henry Schroeder to put their questions directly to Dr. Palbush and to Dr. Nelson.
Yeah, well, I don't see Henry actually, but I don't have the whole gallery. My question to Nelson is that in that first case that you showed with an extracapsular approach, and I do that, I found it more difficult to find and to spare the remaining pituitary gland. How is that your experience? And of course, there is a higher chance of having a CSF leak, but you can deal with it. But I was always afraid of losing some function if there was still function or improving it.
No, and I don't think there is a difficulty finding it, because the tip off is usually on the MRI, where you know the gland is compressed to the one side. It takes on contrast preferentially, as you know, and then the first thing to do is to find that plane of dissection. In that case, I showed the gland was around it. Yeah. It was around it, and so once that plane of dissection is achieved, then the key is to stay in that plane. It's perfectly reasonable if the gland is covering it to make an incision in the gland, but spare it by just reflecting it to the side that you need to, and not remove it. But we haven't found any significant problem with that at all.
Okay, because I often saw that it was more adherent to this pseudocapsule of the adenoma. So the adherence was quite a bit. So if you remove it piecemeal from the inside, that was easier to spare it on that side where you see on the MRI scan that the pituitary gland is. But okay, that's it's good to see, because on the video I couldn't recognize it that easily.
Right.
Well done. And of course, I was not talking about the cases that you showed afterwards with the KNOSP grade 4 and extensive intraventricular paracellular lesion. That was just incredible. The same as Bill was showing, these enormous tumors. These are the real challenges. I mean, the giants. Yeah. That's the thing. But I also see that we have made a lot of progress in that. And Bill knows that I'm in favor of having a combined approach in the same time. Don't leave anything. So I start. I'm not so worried about having the let's say a so-called contaminated from the nose and a sterile from a frontotemporal approach at the same time. We didn't do it very often. I told you that in 20 years, only 17 of these cases, so it's just less than once a year, and never had any infection. That's not my concern. My concern is leaving a remnant that can give an apoplexy at night and poses quite other problems.
The question by Henry is regarding how you actually explore the gland in Cushing's patient.
Understand. I've shown the sections. Maybe it was not so convincing for him. So I opened the cellar as far as possible to the cavernous sinus, 10 to 12 millimeters, to 6 to 8 millimeters. Then if MRI is negative and I look for a 2-3 millimeter microadenoma, I section in the midline and then on the right, on the left side in the zenithal direction. And if I don't find anything, then 2 sections in addition in horizontal way. And then always in these cases, I found something. If not, you have to look all the way around extraglandular. The tumor can be developed from the border of the pituitary gland against towards the cavernous sinus, or even focally into the cavernous sinus. Understandable?
Thanks.
Thank you.
Dr. Nasp, any comments before we go to the next session?
The comments to the congratulations to all of the participants, and they're really great questions. I had a question to Oyesiko. Nelson, if you enter the corona sinus, do you think there was a disruption of the medial wall, or is it already invasion of the medial wall and the trabecular and so on?
Yeah, Engelbert, we've seen both paradigms, as you mentioned, the invasion of the trabeculations through a weak point in the trabeculations, and then that the tumor sort of chooses the path of least resistance through those trabeculae. That's one pattern we see. The other pattern is where it just pushes the medial wall by pressure on it. And in those, in that secondary case, you have to resect that medial wall to be able to get the tumor off of it. And so going on the other side of the medial wall is that technique that allows the tumor to come more medially away from the medial wall, because you don't have the advantage of having the trabeculation opening and for you by the tumor, creating a trajectory or an entryway, if you will. So that whole medial wall is itself pushed away. So sort of between a NOPS 2 and a 3A, if you will.
The question regards the grade B. Do you think that the medial wall in the lower part is anatomically weaker?
Yes, I think in the lower part it's weaker.
Yeah, it's also my impression.
Yes,
and
I think so.
That's what our co-chair, Feibusch, Rudy August mentioned.
I totally agree with that.
Thanks. We move on to the next session. I would request Dr. Kuldwell to moderate this session with Dr. Gentili and Muthukumar, who will introduce the first speaker. And thereafter, I would ask Dr. Kuldwell to take the questions as well. Thank you.
It's a pleasure to introduce Professor Engelbert Noss, who is well known for his grading of cavernous sinus invasion of pituitary tumors. He is now the Professor Emeritus of Neurosurgery in University of Vienna, Austria. Professor Noss, please.
Thank you for introduction. I will talk on functional adenomas in the cavernous sinus, and I think there is a lot to talk about that. This is the invasiveness shown by Jefferson in 1955 in his monograph, and at that time he mentioned that the invasion is only 5% in these giant adenomas. The closer you look surgically, radiologically, or histologically, it's shown that the histological invasion is twice as high as in the surgical series. And if the cavernous sinus is involved, even the drop of cure rates from non-invasive and invasive adenomas drops. But what's the cavernous sinus? I think everybody knows that. That's the dorsum cellae, that's the cellar optic nerve, and that's the residual of the normal gland. After removal of that, you see the medial wall directly, and the medial wall is only a very thin, unfenestrated membrane. After that, you see the cavernous sinus. If you have a surgery, you will not see anything of that. You see the inferior hypophyseal artery, by the way. clival part of the inferior hypophyseal artery. And this is the area where the posterior lobe is embedded. And this is the carotid artery, the posterior bend. This is the cavernous sinus. This is the oculomotor nerve. And if there's a weak point, the Wandenplatte, that's a very thin membrane accompanying the optic nerve. And sometimes there is a compression or invasion of the tumor to the systems here, as we saw by Will Goodyear. And this is during surgery, the area of the carotid and the inferior hypophyseal artery in this area. Focal invasion in the cavernous sinus. We can see the medial wall on the MRI nicely in many cases. You can also see a focal invasion in the medial wall. This was checked also by the navigation to be sure that's normal. This is the inferior compartment invasion, which is more tricky to remove. And this is the medial wall. So it's translucent, small membrane. And this is the medial wall again during the removal in anatomical dissection. And this is the carotid with the trabeculations over there. This should be the end of the tumor removal. The medial wall is no invasion, it's smooth, and there are veins preserved, and there's no problem with the cavernous sinus. That's focal invasion into the cavernous sinus, and you do not really see whether there is a tumor behind the trabeculations over there, and you have to go closer and try to remove that. The classification, as I mentioned, proposed for some years, the important thing is for the endocrinological surface is that with the increasing invasion rate with the grades, there is a decreasing remission rates. The endocrinological remission rate in my hand in grade B is 0, and of course in the grade 4 the same. There is a division between the low grade and the high grade cavernous sinus invasions grading, and I think there is it's a good idea to see that, divide that. And in the new classification, I just only divided the superior compartment in the grade 3 compared with the lower compartment. Why? Because the invasion rate is significantly higher in the inferior compartment, and the remission rate, this is this area, it's quite good, but in the grade, in the 3A, but it's 0 in grade B. And of course, in grade 4, the remission rates are 0. When we concentrate on the high grade invasion in the cavernous sinus, the prediction of remission, and many papers state that there is a significant difference between the low grade and the high grade invasion rates. That's the Bologna group. They also see that the remission rate decreases with the grades, and there is a distinct difference in grade A and B and grade 3. I like that slide because it shows that the compression decreases with the increasing grade. The focal invasion is in all these areas, even in the grade 1, and the diffuse invasion increases with the increased grade. These are our data of 100 patients, only grade A and grade 3 and 4. We found a statistical significance between A and B, and of course with a grade 4. In terms of functioning adenomas, we found in this group that the functioning adenomas are significantly higher invaded compared to the non-functioning adenomas. These are all grade 4. The question is, should we operate on that, and in which extent? The endocrinologist strongly argument to do surgery to debulk the tumor and to leave the areas lateral of the artery to not to damage the artery. And also the Oxford group, they mentioned to do the same procedure. What's the risks in this cohort of more than 100 cases? We had no ICA lesions, we have no vision loss, we had a cranial nerve deficit, it is abducent nerve deficit, which is permanent. We had 2% of meningitis. When we enter the cavernous sinus, there are 2 routes. This is the medial to lateral approach, or a more direct approach, which is directly to the carotid artery. This is the inferior compartment of the venous plexus. And if there is enough tumor anterior to the carotid, I dare to do that. This is one of the acromegalic patients. You can see the medial wall remnants here. This is the carotid artery, inferior compartment, and it's a grade 4. And if you enter the cavernous sinus, this is just cellar, then you see the carotid artery detected by this ultrasound detection. If I go lateral to the cavernous carotid, there are trabeculations. You go from one trabeculation to the others. There are fibrous bands, and finally, I thought to be lateral to the lateral wall of the cavernous sinus. I was just quite satisfied until I saw the post-op MRI. There is still tumor also in the superior and in the inferior compartment, which shrank a little bit 3 months later, and this was the time where we initiate gamma knife treatment. Another case, acromegalic patient with this suprasellar and this supracavernous extension. And again, this was the first time that I realized that, again, the carotid artery and lateral to the carotid, you can detect the sympathetic nerve here. It's not the abducent nerve. And finally, you could see with further resection that the supracavernous arachnoid pops into the cavernous sinus. And this is the rest of the medial, the beginning of the medial wall, which is destroyed. I have to show that this is cranial and this is caudal part of the tumor. And again, the approach directly to the carotid, also anatomically seen the trabeculations, the carotid, and in a patient like that, I thought that would be a good idea. We had navigation, we have the Doppler, and the frustration is that there was no cleavage plane between the carotid artery, which is here. This is the sellar area. This is lateral to the carotid, but there was no cleavage plane. So there is no chance to remove that. One other case, which is a case also GH secreting adenomas. This is the normal gland. I'm sorry for this bad video. This is the normal gland, and there was a tumor. There has no tumor part in the gland. So I thought this is ectopic intracavernous part of the adenoma. We can go into that, and I think the closer you look in the MRI, you more often see that that's not so. It's often seen that the tumor grows through the roof of the cavernous sinus in the area of the cistern. This is one of the case. That's the anatomy, what you have to think about. Carotid, the third nerve, the sixth nerve in the lateral wall. And then if you open there, you see the third nerve just in this area. That's the weak point of the roof of the cavernous sinus. And that's we can see also in a patient like that. We removed the tumor from the cellar already, and I thought I can enter through the roof. I hesitated to cut into the roof of the cavernous sinus because I'm afraid of the third nerve and the PCOM artery. But I could remove tissue from this weak point, that's the arachnoid. I was lucky with surgery until midnight. The patient developed third nerve palsy. I had to go in with a transcranial approach, and you see what's happened. I could not remove the whole tumor. It was swelling, infarction, and abducent bleacher. After removal here, you can estimate that there is the normal gland, there is the carotid, the optic nerve, and this is the whole of the into the cavernous sinus, and that's left side oculomotor. It's bended anteriorly by the tumor which grow behind the oculomotor nerve. That's the post-op, and she recovered after a long time, also with from the oculomotor nerve, and no recurrence so far. Another problem in the cavernous sinus surgery is that the medial wall has to be removed in several locations. You see from Otwill's publication that the medial wall is invaded and drops the curate. This is from our publication, and we saw that those adenomas, these were prolactinomas, enclosed have a significantly better outcome compared to these microadenomas, which reaches to the medial wall. These are the figures in our hands. And again, medial wall, frail and very thin. And the Pittsburgh group operated and selectively removed the medial wall of the cavernous sinus. And by doing so, they found that after removal of the medial wall, the remission rate in their cases were almost 100%, with the cost, with the morbidities of cranial nerve deficits and reoperations because of clot formation in the cavernous sinus. When we compared the numbers of Pittsburgh, there is a correlation of invasion, histological invasion in grade 1 in the classification, and increased to 94%. This is Nishioka's numbers, and you can compare that with the grading, but I want to show that even in grade 3, they could achieve a very high rate of remission in these acromegalic patients. And that's it's very important if you have a case like that, which is close to the cavernous sinus or already in the cavernous sinus, and if you are not sure that you can remove everything, put a fat implant for preparation for the gamma knife treatment. I think there will be a presentation later on the gamma knife treatment, so we could need not to discuss that. But we should, in some cases, think about treatment with temozolomide in aggressive tumors with more or less good results. Thank you for your attention.
Thank you, Engelbert. Our next speaker is Fred Gentili.
Okay. Thank you. Can everyone hear me?
Yes.
Okay, first of all, I do want to thank Chandra and indeed the entire WFNS Endocrine Committee. I think this excellent initiative that they're doing, as we saw from Franco's initial talk. These educational webinars are very, very important, particularly in this pandemic area where we're not able to go to meetings and so forth. So Chandra and your group, thank you very much. I know it's a lot of hard work putting these things together. So my talk is on recurrent non-functioning adenomas. Now, there's a lot of controversies, and it's very excellent because this symposium is going to address some of these, the diagnostic controversies, the managed atypical, the role of radiotherapy, indication of craniotomy we already saw. And as noted, the issue of recurrent is a real problem, and recurrent of management of giant pituitary adenomas. So this is the patient I operated on in 1990, so it tells you my age. In 1990, presented with a visual complaint, primary macroadenoma, doesn't look like there's extension to the cavernous sinus. I did a microsurgical transfemoral procedure in this patient. 30 years later, no evidence of recurrence, normal pituitary function. Rudolph, all of us, we'd love to have every patient like this. Wouldn't it be a good idea? Unfortunately, as we all know, that's not necessarily the usual situation. This is another patient that I operated on 3 years later, 1993, a microscopic transfemoral, gonadotroph, hormonals were normal. He was followed 4 years later, he had recurrence. I did a repeat microscopic transfemoral, again, residual disease that I followed. 2007, 10 years later, he presented with disease progression, as you can see here. I was doing endoscopic at this time, so I did an endoscopic transfemoral. Infiltrating gonadotroph, MIB 5%, residual disease in the cavernous sinus. I followed the patient. 2010, 2013, slow growth. He was asymptomatic, so I kept following him. 2014, further growth. I did a repeat endoscopic transfemoral. He improved in his vision, hormonal status normal, postoperative residual disease in the cavernous sinus. 2015, small increase. What do you do now? 2 microsurgical, 2 endoscopic. Well, we'll answer that question later. The problem, as we know, unfortunately, that recurrent pituitary adenomas are common. The incidence vary if you go in the literature, but up to 50% incidence of recurrence. And if you look at patients with cavernous sinus involvement and follow them at 10 years, up to 80% will likely have a recurrence. The other important thing is that while the peak time of recurrence is 1 to 5 years, time of recurrence you see can vary up to 18 years. I've had patients in our pituitary clinic that I followed at 18 years having a recurrence. So the key issue that has been stressed by other speakers, the importance of follow-up in pituitary patients. These are difficult management problems. Repeat surgery, is challenging with increased treatment morbidity and decreased favorable treatment outcome. And it's interesting, until recently, there's really no international consensus on the optimal management of recurrent or residual pituitary tumors. In other words, when is the role of surgery? When is the timing of surgery? What is the role of radiation or medical therapy? But we all know that in general, the management often requires a multidisciplinary approach, that surgery alone is usually not the answer for these. Now, what are the risk factors for recurrences? Well, we all know this, of course. Incomplete tumor resection at the initial surgery is very important. Tumor biology and invasiveness has been discussed, particularly infiltration of the adjacent structures such as the cavernous sinus. In some series, they look at age, sex are predictive, others are not. Of course, tumor type, we've checked that. Hormonal levels and functioning adenoma. Very, very important is experience of the surgeon. We've all understand now how important that is. And of course, as I've talked about, duration of follow-up is very important. Now, the treatment options for recurrent adenomas, of course, we all know, observation and wait and see. If a patient is entirely asymptomatic, repeat surgery followed immediately by radiation. The use of radiation alone, different types of radiation, medical therapy, chemotherapy, and combination therapy. These are all the treatment options that we have. Now, we have done about 2,000 cases now of endoscopic pituitary adenomas. And we wanted initially just to answer the question, can endoscopic techniques reduce the incidence of recurrence and improve our ability to deal with recurrent pituitary adenomas? You know, this is not proven in the literature. There's no level 1 evidence in the literature that tells us whether this is true or not. So we initially did a small study, as you know, very small, 39 patients, and we published this back in 2012, looking at the endoscopic surgery in recurrent and residual pituitary adenomas after microsurgical resection. You can see the demographics here, 19 non-functioning, 20 functioning, but you can see from the beginning, 43% of our patients already had frank cavernous sinus invasion. So this is a typical tumor. This is a 51-year-old patient with persistent Cushing after a previous microsurgical approach. And you can see here the ability to do the endoscopy was obviously better visualization, more wider exposure. Of course, experience is very critical here. And the issue here, you see the initial missed this beautiful little hardy microadenoma laterally adjacent to the medial wall of the cavernous sinus. That the endoscopic approach allowed us very nicely to take it off the medial wall of cavernous sinus. I must say, you know, there's been a lot of things about resection of the medial wall, and we can have a discussion later. I am not a fan of resection of the medial wall of cavernous sinus. I think that is really not a useful situation. Here's a carotid artery, and this is after the removal. This patient, as you see, is post-op. Normal urinary free cortisol, 7-year, he remains in remission. And you see, I talk about remission in functioning adenoma. We do not use the term cure in functioning adenoma. That is my philosophy, because they can recur. Here's another patient, persistent acromegaly following microsurgical approach. And the problem here, of course, was this type 2 or conchal type 3 release sphenoid sinus. Very difficult in these tumors here. The endoscopic approach allowed us to have a better ability to do the drilling. And here's this patient after the removal of the tumor. Again, the medial wall of the cavernous sinus on this side. We were able to get a very nice removal. And this patient, again, post-operatively, 5 years in remission. This is a 53-year-old patient with in 2017 transfemoral procedure, partial resection. Why? Look at these, sorry. Kissing carotids, almost 3 or 4 millimeters to get in, very difficult. The endoscopic approach allowed us a little bit better ability with, ability to carry out a bit of an expanded, so we could go over the carotid arteries above to try to get a nice removal, and we were able to do a debulking of this patient, but not a total removal, as you can see here. So this patient postoperatively, as you can see, residual disease. The patient, his vision improved. What do? I observed. Is this the right option here? Did I do the right thing to observe this patient? So this is our results, where in that very small series, overall 54%, but you have to understand almost half of them had frank cavernous sinus invasion. However, the non-functioning adenoma, the remission rates or gross total removal was 86%, which I thought was very reasonable. None of the patients that had cavernous sinus invasion did I feel I was able to get a gross total removal. And that's important when we talk about gross total removal, no cell left. And I don't believe you can get a gross total removal with full invasion of the cavernous sinus. We can discuss that. And the functioning adenoma, again, 75% in the Cushing's, very short follow-up though, and growth hormone 44%. And while this is very small series, we can't say anything about it. The overall results in this was somewhat better than most reported series at that time of recurrent microscopic surgery. Cavernous sinus invasion was the major predictive factor of outcome. This series from Cavallo and the Naples group of recurrent pituitary adenomas after endoscopy. You can see 59 patients, they similar to ours, gross total removal rate 62%, 74 in those with a previous microsurgical, and 59% in those with an endoscopic procedure. This is a systemic review, and you know we all have to be careful about systemic review. Often they are not comparing apple and apples, but this looked at 15 studies, 149 patients, and they noted that remission rates were in the functioning 44%, in the ACTH or in Cushing was 55%, and the non-functioning about 76%. And this is from Jim Evans' group, and they just wanted to look at the risk factor in surgical morbidity, and noted that the reoperation for recurrent disease was not necessarily associated with increased surgical morbidity as compared to initial surgery. So if you're an experienced surgeon with experienced techniques, repeat surgery does not have to be to carry more morbidity. Now, this is the series that I want to look at. This is our series that we just looked at and just published in World Neurosurgery, for those of you in the October issue of last year. And what we wanted to do was look at long-term outcomes and the management, because the issue with pituitaries, you have to follow those pituitaries for a long term in terms of recurrences. And then the endoscopic approaches for it. Here's the numbers, 269 patients. You can see the demographics here, the tumor characteristics. These are generally old, larger tumors. They're not microadenomas, so over an inch, 2.5 centimeters. And you can see again, 45% had already had cavernous sinus invasion. These are the pathology that you can see here. So what was our gross total rates? Well, 54%. You say, oh my God, you're not a very good surgeon. What do you mean only 54%? But 43%, almost 50%, had already cavernous sinus invasion, and 15% already were recurrent tumors from somewhere else. So this is the group that we're talking about. The gross total rate varied according to cavernous sinus involvement. Only about 30% in those with involvement, 72% those without involvement. These are the complication rates. You can see hypopituitarism, 11% in the first surgery, doubled almost by the second surgery. Second surgery does have some issues with hormonal. Postoperative hematoma, you can see here, CSF leak, only 2%. And I use generally the nasal septal flap for reconstruction. So recurrences and management. The overall recurrence was 63 patients, 20%. The recurrence rates at 5 years was 22%. 10 years, it doubled. So this is the issue when we see papers in the literature with a 2-year, 3-year, 4-year follow-up, whether they're pituitary tumors or whether they're meningioma, it means nothing to me. The follow-up in these tumors have to be 10 years or more to really get a true idea of recurrence. The median time to recurrence, as you can see here, was 10 years for patients without cavernous sinus involvement and 6 years for those with cavernous sinus involvement. A third of these were symptomatic patients with visual worsening, and 2/3 were asymptomatic. The recurrent rates was significantly higher in younger patients. Well, that goes without saying. You follow them longer. And among the recurrences, 82 had a previous subtotal resection, 18% had a gross total resection, and presented the recurrence at a mean time of 61 months. Among the recurrent cases, 63% had evidence of cavernous sinus involvement that you can see here you can read this in the paper. Now, what were the risk factors for recurrence? And everybody knows these. This is not new, but we found under univariate analysis that size, of course, is very important. Cavernous sinus invasion was very important. Anterior skull base extensions were important. Residual tumor after previous surgery, and were significantly associated with recurrence. Under multivariate analysis, age, tumor height, cavernous sinus involvement, and residual tumor were associated. Interesting, unlike some of the others that we saw in general, the tumor pathology was not found to be a significant factor, although silent cortical subtypes adenomas had a higher tendency for recurrence. But I think the problem here is that our number is not high enough in each group to show that significance. So how do we manage? 52% required a second surgery because of visual symptoms or to prevent visual complication in growing tumors. Here, however, as you can see, our gross molar rates was only 28%, very low. 15% underwent radiation, 9 gamma knives, 6 fractionated, 10 after the initial first recurrence, and 5 after the second recurrence. Tumor control rates after radiation was 87% with a mean follow-up of 37 months. So let's get back to that patient, my first patient that I showed you. 2 microscopic, 2 endoscopic, now progressive disease. What do you do? Well, here I do not believe that surgery is the answer for this patient. So this patient, we recommended radiation therapy. 5 years now, as you can see, has stable disease and maybe some decrease in the size of disease. Now, looking at radiosurgery pituitary tumors, as you know, a variety of modalities have been used, from gamma knife to fractionated. And if you look in the literature, you look at, this is functioning, all right, functioning, but I'm looking at non-functioning adenoma, 5-year remission, at least control is 88%. This is from Jay Lawford and his group in 2011, looking at a literature review, that there is there's a relatively good tumor control rate of 80 to 97% in most series, regardless of the radiation technique. And then in terms of the hormonal normalization, in around the 50% range. Hypopituitarism, of course, is an expected result in radiation therapy, but the overall rate of other treatment-related side effects was quite low. And this is another an international stereotactic radiosurgery opinion, background, a systemic review. This is a correction in 2019. We looked at 2,671 patients treated with either single fraction or hypofractionated. 5-year low control rate with stereotactic was 94% and 97%. 10-year tumor control was 83%. Again, hypopituitarism was the most common treated toxicity observed at 21%. This is and then in terms of medical management, unfortunately, I don't have time to go through this, but as was shown before, my goodness. More and more now, medical management is being used not only in functioning, but in non-functioning adenomas. And in our unit, our endocrinologists have used dopamine agonists for non-functioning, recurrent, and these other medications, including temozolomide, that was also discussed. So there is a role for medical therapy. So in summary, and this is really from the Congress of Neurological Surgeons and European Society, that with recurrences, they recommend that a dedicated pituitary surgeon's opinion on repeat surgery should be obtained prior to proceeding with adjuvant therapies. Patients should be managed in the setting of a multidisciplinary team. Repeat resection is recommended for symptomatic recurrences or residual tumor. Stereotactic radiosurgery or other forms is recommended for residual tumors, and they notice that in the US, it's generally more upfront, whereas in the European, it's more, they leave it for a more growing lesion, but there's really no high quality evidence. And again, serial imaging after complete or near total resection should be done. So if you think you got a good resection total, you must follow that patient's. And adjuvant radiotherapy should be considered for tumor remnants with biological features of aggression, such as high proliferation index or aggressive tumor types. So in conclusion, despite advances in surgical technique, recurrence rates after pituitary surgery remain unfortunately high, noted on long-term follow-up. An attempt should be made for a safe maximal gross total removal when feasible at the first surgery. We've seen tumor size, cavernous sinus involvement, incomplete resection are the main risk factors for recurrences and should be taken into consideration when deciding on the management of recurrent or growing residual tumor. While the success of second surgery is significantly less in terms of gross total removal, no question that reoperation has a significant role to play in achieving reduction in tumor bulk and decompressing the visual pathways in symptomatic patients. And while the timing of radiation remains a subject of debate, it has a significant role to play with a high rate of tumor control and should be considered in patients with recurrent tumors when gross total removal is unlikely to be achieved after multiple operations and in tumors showing growth and aggressive behavior. So the management of recurrent tumors, the evaluation and management of patients with recurrent pituitary tumors requires the active participation of an experienced pituitary surgeon, as well as an equally experienced multidisciplinary team of endocrinologists, radiation oncologists, medical oncologists, and pituitary neuropathology. So thank you very much for your attention.
Thank you, Fred, for that great and precise follow-up with all your patients. and I apologize to you because I thought somebody else was going to introduce you. But for those of you who don't know Fred, Fred is the lead skull-based surgeon in Canada. He's a professor of neurosurgery at the University of Toronto and really is an endoscopic pioneer in skull-based surgery. So thank you, Fred. I appreciate that.
Thank you very much, Bill.
Our next speaker is Ed Laws, who I think for all of us who have grown up with pituitary surgery needs no introduction. He's a leader and he's taught us so many things in pituitary surgery over the years. He has a specialty interest in pituitary, craniopharyngioma, and transnasal endoscopic pituitary surgery. He's a professor of neurosurgery at Harvard University. Ed, I'll turn the screen over to you.
Thank you very much, Bill. It's a great pleasure to be back in India. And I really compliment Dr. Deo Pujari and his team and his colleagues and all of the people who assembled here for this brilliant meeting. It's really been absolutely outstanding. And I'm delighted that the World Federation is doing this, and the one we're having just next week. And it's really marvelous to see this international group of stars teaching us, and also astonishing to look back through my career when I started the first transphenortal operation in 1967. It's hard to believe, and as you can see, 6,000 since then. We're going to talk about functioning pituitary tumors and some of the lessons that I've learned over these years of endeavor. As you know, prolactinomas represent about 30% of the functioning tumors, and acromegaly about 20%. And Cushing's, which is our nemesis, as you've heard, 16% in my series. And the gonadotropic tumors, about 30%, most of which are clinically non-functioning, but some are. And the very few functioning TSH tumors and the aggressive pleurohormonal tumors make up the rest of the functioning tumors that we need to discuss. And I'm just going to give you some ideas about what I've learned. Number one, the endocrinologist is critical to our success. And the endocrinologist is your friend, and you must cultivate your friend. You must understand their language. You must understand their methods. And this is a picture of one of our acromegalic giants, who is a Romanian basketball player who came to the United States. And the lady in the picture is my colleague of 15 more years, Dr. Mary Lee Vance, who is a brilliant endocrinologist. So a few things. Progressive visual loss is truly an emergency. These days, when our surgical slots are diminished because of the pandemic, we must recognize that visual loss is an emergency, and we need to be able to take care of these patients safely. And they can occur with any kind of pituitary adenoma, functioning or non-functioning. This happens to be a prolactin-secreting pituitary tumor, and look what it did to her vision. It was just remarkable, and this was all, of course, restored to normal after that tumor was removed. Initial positioning of the patient, I think, is really important, and this is one of the things I try to teach my residents and people who come to visit, because I think the ergonomics of this operation that we do with the endoscopic transphenortal approach is a critical factor in how successful we are. So I always position the patient not flat, the way the ENT people do it, but with the thorax elevated 25 to 30 degrees. And that lowers the venous pressure in the head, and you get much less venous bleeding, and you are able to tilt the table to even decrease the venous pressure further. I make the head parallel to the walls of the operating room so that the midline is in the midline of ambient space. Straying off the midline is one of the biggest problems. And we avoid that by knowing that the midline of the patient is our midline. And we stand here and we put the nasal dorsum starting out parallel to the floor. Sometimes we extend the head a little bit if we're going intracranial, or flex it if otherwise. But the positioning is really important and makes a huge difference. We discovered very early on that a urinary catheter and the ICU care are not necessary in most of our cases. Most of our cases are finished in less than 3 hours. And so having the catheter and its complications are just not necessary. And the patients wake right up after surgery and go home the next day, or can go home the next day. We keep them to watch for DI. But they don't need to go to the ICU by and large unless they have some vascular problems or other comorbidities. We do not use routine spinal drainage, and we don't use it post-operatively except in very unusual cases, as you may have heard earlier. I don't use them in elderly patients. But if we're wanting to increase intracranial pressure to push down a tumor, Ivan Chirik taught me to do jugular compression. And you heard about that earlier, and that really works, and it's very safe. Staying in the midline is really important, and the best way to do that is to identify the vomer and to preserve the structures before doing the posterior septectomy and entering the rostrum of the sphenoid. This is a step-by-step operation, sparing the anatomy. I have only once taken a turbinate process. I know some people do it regularly, and I've been able to do these operations without resecting a turbinate. Here's what I learned from Paolo Capabianca. He was the one who introduced me to the endoscope. And we need to understand the anatomy, and it's so different from what it was before, when all we had was the operating microscope and the blades of the speculum. So here we are seeing the sellar floor, the carotid protuberances on either side, which often we didn't see. Here's the clivus, here's the planum sphenoidale, and here's the optico-carotid recess. You can see the optic canals. You can open them up if you wish. And using the endoscopic approach has been a marvelous advance in what we do for our patients. I use imaging control most of the time. It helps the residents learn the anatomy and correlate where they are with the instruments, with the anatomic factors. This is a cartoon from Joe Maroon, and you can see how the carotid artery may be hiding behind the tumor, and the tumor is compressing the normal pituitary gland to the side. And here's the optic chiasm. So these anatomic features are critical for success with this operation. And we've heard earlier, particularly in acromegaly, about the carotids and the enlargement of the carotids, the calcification of the carotids, and the propensity for carotid aneurysms in patients with acromegaly. So I say to the residents, always think carotid and avoid any damage to the carotid arteries, of course. Now, the dura of the sella has 2 layers, and we have to open it in a way that actually respects that anatomy so that you can be sure that you've gone through the 2 layers to expose the thin shell of compressed normal pituitary gland. And I usually make a vertical incision and a horizontal incision, but for a Rathke cyst, I'll make an inverted T incision most of the time. And if there's any thought of a cyst, like an arachnoid cyst or a Rathke cyst, or if there's any thought of an aneurysm masquerading as an aneurysm, we use a needle. So here's the exposure from one cavernous sinus to the other. You can see that here in the photo. You see the tuberculum sellae. We see the planum sphenoidale right here, and that's exposed in every case, along with the side-to-side exposure and the removal then of the floor of the cellar fossa. Sorry. Now, if the cella is large, and you've seen plenty of large cellas and plenty of small cellas, but if the cella is large supracellars actually can be readily removed. You can take advantage of the enlargement here by having the position correct so that you can work in every plane and get around these tumors. And that has been a good feature of what we do. Now, the one thing we don't want to do is to damage the posterior pituitary or the pituitary stalk. The posterior pituitary has a unique characteristic. For me, it looks like ricotta cheese or it looks like oatmeal, and it's in the posterior pituitary, and you do not want to remove it or damage it. Worse than that is damaging the stalk, because if you damage the axons in the pituitary stalk, you will get karyorrhexis and death to the cell bodies of the cells in the supraventricular and paraventricular nuclei. And if those cells die, you get diabetes insipidus, which is a very unpleasant complication of some of our operations. So we'll go quickly through some of these functioning pituitary tumors: the prolactinomas, the acromegaly, Cushing's, gonadotropes, TSH tumors, and the plurihormonal. Starting with the prolactinomas, and we know that prolactin is under inhibitory control by dopamine from the hypothalamus. We see it most commonly in young women with infertility, amenorrhea, and galactorrhea, classical syndrome. Much less common in men who are older, and the men have hypogonadism, impotence, fatigue, and often have very large tumors with mass effect. So between the sexes, we have two different kinds of challenges with prolactinomas. The indications for surgery are hyporesponsiveness to dopamine agonists or intolerance of medical therapy. And I must say right now that it's becoming increasingly obvious that dopamine agonists can cause a series of side effects, many of which are emotional or psychological, and the patients are beginning, particularly the women, are beginning to recognize this, and we see many patients who have side effects of the medications, and that is the reason for their operation. Also, I think cystic adenomas tend not to respond well to medical therapy either, and are fair game for a transsphenoidal surgery. Patients who present with CSF rhinorrhea from invasive prolactinomas are another issue which require nasal septal flaps in many instances, and we have some who present with apoplexy and some who present because they desire fertility, which has been lost by the effects of the excess prolactin. Our recent survey of 33 women with prolactin microadenomas revealed a 94% success rate. So we can do the job to remove those small tumors like this one and eliminate some of the nasty side effects of excess prolactin. Now, do not hesitate, though, to recommend dopamine agonists if the prolactin is significantly elevated. The patients who don't respond will come back to you for surgery, and the responders will think you're a hero. So it's a win-win situation. And the medication works, but it has its problems. The outcomes in our hands was effective relief of mass effect, normalization of prolactin depending on the size of the tumor and the sex of the patient, preservation of normal function in 95%, recurrence in about 13% over 10 years, restoration of fertility in 87%, and I use this incidence factor of living in well at 10 years, and for our prolactin adenomas, it's 90%. Now, acromegaly is a totally different problem. Our indications for surgery are very secure. It is the first-line therapy for active acromegaly. If the patient has visual loss from mass effect, if the patient has excessive hypopituitarism from involvement of the normal gland, or if they present with apoplexy, they are all surgical candidates. And here's a MRI of one of my early patients, a 19-year-old boy. You can see this tumor invading, typically as they do, into the sphenoid sinus with suprasellar extension, compressing the normal gland and the chiasm. And look at the brain, I'm sorry, the skull. This, I thought he had subdurals. This is enlargement and thickening of the skull associated with excess growth hormone in a 19-year-old. Amazing. In acromegaly, remember that the bone is thicker, the blood vessels are larger, the carotids are tortuous, the distances for surgery and your instruments are greater, and anesthesia and intubation can both be problematic, and you must warn your anesthesia colleagues about these patients because they must take precautions, particularly with intubation with acromegalics. After surgery, many acromegalics will appear to have diabetes insipidus because they have a diuresis, and it's because there's excess tissue turgor, interstitial fluid retention in the patients who have acromegaly. And if they have an immediate cure and an immediate lowering of growth hormone, which occurs with proper surgery, they have a diuresis for a couple of days. So don't leap to treat them for diabetes insipidus until you give them a little time. Now, outcomes in our series for relief of mass effect and improvement in symptoms and signs in all of the patients, normalization of growth hormone secretion is more difficult. Only half of the patients with macroadenomas achieve that goal, and a little over 70% of the smaller tumors achieve that goal postoperatively. But we're good at preserving normal pituitary function using the techniques that you've seen visualized in this symposium with the operative use of the endoscope. Recurrence rates, if you have normalization of IGF-1, are 1.3% in 10 years and 8% if we do not have normalization or they have recurrent IGF-1 elevation. Living in well at 10 years is more difficult because of the comorbidities of hypertension, vascular disease, diabetes, etc. And so we have to monitor them very carefully and help deal with the comorbidities involved. Most of you, I hope, will know that this is Dr. Harvey Cushing, and this is my favorite picture of him in his 30s. And of course, Cushing's disease, we've talked about as the most aggravating and difficult problem that we have to deal with in functioning adenomas. And you've learned of all of the physical characteristics, the centripetal obesity, the moon facies, the enlarged supraclavicular fat pads, the violaceous striae, the hypertension, diabetes, hirsutism, headaches, personality disorders, all of these terrible things that come along. They're here, losing the hair on their head, getting hair on their body. But for the surgeons, please make sure you are absolutely secure. And you heard about this in the previous wonderful lectures from the Chacos. Make sure you do the proper tests and make sure they all fit for Cushing's of pituitary origin. Otherwise, you'll have patients who are not cured and remain miserable. Sometimes it's hard to see the tumors. This is a 19-year-old girl, the daughter of one of my colleagues, and she had early Cushing's, and this is her pituitary microadenoma with a slant of the sellar floor and a little bit of hypointensity here. So the imaging can be really important. Remember that petrosal sinus sampling is often helpful, but may be misleading. It does not make the diagnosis of Cushing's disease. You have to make the diagnosis first, and petrosal sampling rules out an ectopic source if it's done right, and sometimes it tells you on which side you're more likely to find the pituitary microadenoma. We did some studies when I was at Stanford using brain connectivity, using functional MRI, and had 10 patients with Cushing's disease. You see them on the right, and 10 controls on the left, and you can see the disorganization in the patients who have Cushing's disease. And with a subtraction, we noticed that most of the problems were in the hippocampus and account for many of the cognitive and psychological problems that we see in patients with Cushing's. Always remember that patients with Cushing's don't require preoperative or intraoperative steroids. If you give steroids, then you can't figure out whether you've been successful with the surgery right after surgery. So they get by because they have a high cortisol to begin with and don't need any more. In Cushing's, if the patient doesn't have an immediate fall in their cortisol and what we call a crash, the patients complain of headache and flu-like symptoms, and we warn them that this may be coming. If they don't have that, lasting remissions are unlikely. So we look for a very low, you heard this earlier, very low cortisol below 2 picograms, and that is a signature for a good result. Dr. Fallbush, who talked earlier, was the one who taught me that Cushing's disease patients have hypercoagulability, and we put them on low-dose aspirin for 2 weeks after surgery. And I've only had one DVT in a Cushing's patient since using that. Some of the coagulopathy doctors scorn that because they think it's not enough, but it has been protective for our patients, and it's a very good thing to remember. Here's a success rate in one of my first patients with, you saw her body, now you see her face, and her 6 millimeter microadenoma removed extracapsularly. And in her case, 3 months after surgery, she was a new woman. Most of the time it takes 6 months or a year for them to resolve all of their symptoms of Cushing's, but if we encourage them, they do very well. Outcomes here: relief of mass effect, very good. Normalization, depending on the size of the tumor, only 55% of the macroadenomas, 91% in the microadenomas. Preserving normal function, okay. Unfortunately, recurrence rates are very high. By 20 years, they're up around 20%, 25, and these tumors inexorably recur. And we have a few patients that have lifelong cures, but they tend to recur. And only 75% then are living and well 10 years after surgery. And they have so many comorbidities. It's a real struggle. So anytime we achieve an excellent result, we're doing a wonderful thing. And Dr. Reinecke taught me that every day that a patient with Cushing's disease suffers increased circulating cortisol is a day that injures their body. So remember that and how important it is to get that cortisol normalized. This has to do with the not with functioning tumors, but with other ones, like the macroadenoma you see here. We showed that grossly invasive tumors are never curable surgically, and 80% of patients with macroadenomas, non-functioning macroadenomas like this one, will have invasion of the dura. And we studied that in 400 some odd patients and showed that the dura was penetrated by tumor cells in 80% of tumors this size. And so we use radiation and mostly in the form of radiosurgery. And it is a very good protective for the patients. And we use it when we don't have a complete success with the postoperative studies. Now, CSF leaks, we talked about a little bit, not much. I'd never anymore use a lumbar drain. We take them right back to surgery. And instead of having a patient in the ICU with a lumbar drain being clamped and unclamped and leaking and having complications, we go right back to the OR and go right in and remove, repair the CSF leak using a fat graft or a septal flap, depending on the nature of the leak. But I take them right back, and that takes care of it. One more comment about postoperative complications, and that is the delayed hyponatremia that can occur in any patient that we operate upon for pituitary lesions using a transfemoral technique. And if you try to correct the hyponatremia too quickly, you can get central pontine myelinolysis. This is what you see here. I've had only one case of this. It was a patient, elderly patient with Cushing's, who went home to a rural hospital and was corrected in less than a day. And she developed this syndrome and died. And so it's very important to keep in mind. And we use a rigid fluid restriction program for our patients postoperatively. For the first week, we limit them to 1 liter of fluid, and that has completely eliminated postoperative hyponatremia. Also remember that hypopituitary postoperative patients may not absorb oral steroids well, just because they're in the postoperative period. And so if you're at all worried about the level of cortisol in patients who have hypopituitarism, make sure they get their cortisol parenterally by injection, and that's important. Now, this is mostly neurosurgeons we're talking about today, but we have to cherish our friendly colleagues in ENT. They're really important. They can be great colleagues. They can teach you the anatomy. They can help you with septal perforations, with sinus disease that is associated with your pituitary tumors, or with post-op epistaxis, complex anatomy, or septal flaps. So here's a perforation you can see that needed to be fixed with our colleagues from ENT, and we do enjoy them, and they help us many times. We do use stereotactic radiosurgery, which is effective and user-friendly, and as Dr. Caldwell noted, you can sometimes protect the normal gland and the stalk by using some fat grafts or gelatin sponges, and protect the patients from the biggest problem of stereotactic radiosurgery is the loss of normal pituitary function that occurs in 30 to 40% of patients. So it's something we have to anticipate, or at least try to prevent. So just to summarize, there are some commonly recurrent and invasive pituitary tumor subtypes. As you heard, these are the silent ACTH tumors, the acidophil stem cell tumors that secrete both prolactin and growth hormone, the plurihormonal tumors that are composed of different axes, and the ACTH tumors in Nelson syndrome, all of whom are very prone to invasion and recurrence. So keep that in mind. The follow-up has to be very careful. Early and late follow-up recurrences occur, and compulsive follow-up is really, really necessary. So here's our in Neuroendocrine Center at the Peter Brent Brigham Hospital, where Dr. Cushing came to work in 1912 and was doing pituitary tumors using the transfemoral approach. It's stimulating to work in this environment, and I'm so pleased at this meeting and everything we've learned from it. And thank you all, and thank the organizers, and thank the people who helped with making the presentation so smooth. It's a pleasure to be with you.
Thank you,
And
Dr. Laws.
we look for a bright future with the pandemic gone and our results improving all the time.
We thank you very much. Dr. Raj Shekhar will introduce our next speaker, Dr. Muthukumar.
Yeah, it's a pleasure for me to introduce Dr. Muthukumar. Muthukumar is presently the Secretary of the Neurological Society of India. He's a professor of neurosurgery and was the head of the Department of Neurosurgery at the Madurai Medical College in Tamil Nadu, India. Over to you, Muthukumar, to talk on management of pituitary apoplexy.
I was sitting up reading it. Oh, nice.
I didn't do it.
Is my slide visible, Rajshekhar? Hello. Am I audible?
Yes,
Yes, you are, sir.
You are. Please go ahead.
Thank you. At the outset, it's my pleasant duty to thank Dr. Deo Pujari and the WFNS committee for this opportunity to share some of my experiences with you today. So I should start by disclosing, even though I have a bias towards surgical management of pituitary apoplexy, in the following presentation, I try to make an objective and dispassionate assessment of the evidence that is available in the literature. So I'll start with two clinical examples. The first was a 43-year-old male who presented with sudden onset of severe headache and total third palsy on one side and was diagnosed to have a pituitary apoplexy. He underwent a classical endoscopic resection. And when reviewed 10 years later, just before the onset of pandemic, he was doing well, except for mild replacement of cortisol and thyroxine. The second example is a middle-aged male who presented to our cardiology department with a coronary event. He was thrombolyzed, and 24 hours later, he presented with progressive visual loss and was found to have a huge hemorrhagic pituitary mass with chiasmal compression. And once his general condition stabilized, we took him up for surgery, and postoperatively his vision improved, but he was left with endocrine deficits. Towards the end of this lecture, we'll come back to these two cases to find out whether with the current evidence that is available in the literature, whether these two cases could have been managed differently. When we talk about pituitary apoplexy in this presentation, we are referring to the classical clinical syndrome of pituitary apoplexy and not the radiological or histopathological evidence of pituitary apoplexy. It's important to remember that the clinical presentation of pituitary apoplexy is extremely important because it may vary from headache to altered sensorium. And this is important for management because the clinical status of the patient at the time of presentation is what that determines the course of management, whether the patient is going to have a conservative management or a surgical management. Equally important is to know that 1/3 of patients are likely to have some precipitating factors. And it is important because it can confound the clinical diagnosis. Not only, for example, in pregnancy, even the gestational pituitary apoplexy can be confused with preeclampsia, with which sometimes it can coexist. And some studies have shown that patients with precipitating factors are slightly worse status clinically at the time of presentation, and their ultimate clinical outcome is also suboptimal when compared to those without precipitating factors. Traditionally, we have been taught that the pituitary apoplexy is due to the rapidly growing tumor outstripping its blood supply. By and large, why it is true that there is some evidence in recent literature that there are certain intrinsic tumoral factors like the high metabolic demand of the tumor, the reduced vascularity of the tumor, and increased fragility of the tumor vessels that contribute to this pituitary apoplexy. This is especially so when this is combined with a high intracellular pressure, which is going to make the ischemia worse, constituting something like a double jeopardy. And these intrinsic tumoral factors noted here is the only way by which pituitary apoplexy can occur in a patient with a pituitary microadenoma, about which we'll see a short while later. Now, the importance of high intracellular pressure is that theoretically at least, if the high intracellular pressure could be relieved by early surgical intervention, then it is possible. It's possible to restore the normal endocrine function in the residual pituitary gland. Whether this hypothesis is correct or not, we'll see shortly. Now, there are two grading systems which are commonly available in the literature. One is the pituitary apoplexy score. The other is this grading system proposed by Gio and colleagues. I personally do not use these grading systems because there are certain limitations of these grading systems. For want of time, I will not be going into the limitations of these grading systems. It's also important to know that majority of the patients will have some form of hypopituitarism endocrine deficit at the time of presentation. And the imaging features of pituitary apoplexy are well known to all of us. So without any further ado, let's go directly to the management of pituitary apoplexy. There is absolutely no consensus in the literature about the appropriate mode of management because the available case series are often retrospective, small, and heterogeneous with dissimilar clinical presentations. Now, when we talk about conservative management, it's generally indicated where patients who present with headache alone, with minimal or no visual symptoms, or with severe associated comorbidities that preclude surgical intervention. Now, this conservative management generally consists of supportive measures, which includes glucocorticoids, management of electrolyte disturbance, and careful clinical monitoring, especially monitoring of the visual status. And surgical management is indicated when there is a patient with visual disturbances or altered sensorium or rapidly deteriorating neurological status despite conservative management. And the standard of care is usually endoscopic transperineal resection. When we go through the recent literature, it becomes evident in recent times there is a trend towards conservative management of pituitary apoplexy away from surgical management. In this context, it's worthwhile to know certain limitations in the literature, which in the studies that compare conservative and surgical management. I'll just present two examples here. This recent publication has concluded that the conservative and surgical managements give equally good results. But if we look at the data in detail, the surgical group has a much more severe visual deficit, and there's a statistically significant increase in the difference in the maximal tumor diameter in the surgical group. In another recent publication, which also came to the conclusion that conservative and surgical groups have similar improvements in visual as well as endocrine function. The adenoma volume was twice in the surgical group, and the incidence of cavernous sinus invasion was 3 times more in the surgical group. The authors themselves conceded in their study that this selection bias might have contributed to the difference in the outcome. This is something we should remember because sometimes we end up comparing two different dissimilar patient groups. Basically, we end up comparing apples and oranges. Now, coming to the outcomes, majority of the patients will have some form of anterior pituitary deficiency, most common being cortisol and thyrotrophic deficiency, the others being gonadotrophic deficiency or growth hormone deficiency, depending upon the individual case series. A small minority of patients will have posterior pituitary deficiencies. Now, does the type of management have an influence on the outcome? The majority of the evidence in the literature, including a meta-analysis by 2 and all, shows that there are no differences in the endocrine outcome between surgical and conservative arms. But to be fair, there are at least two publications which I am quoting here in the same year. One claimed that the conservative management has a better outcome. The other claims that the surgical management has a better endocrine outcome vis-a-vis the treatment option. Now, does the timing of surgery influence the endocrine outcome? As I pointed out earlier, theoretically, the early reduction of the intracellular pressure should lead to restitution of endocrine function in the residual pituitary gland, which is reiterated by some of the studies which I have quoted here. Some of these studies have shown that those patients who undergo surgery in the first week have a better surgical endocrine outcome than those who undergo surgery at a later time. Now, can the postoperative endocrine recovery be predicted? This particular study from Germany recently has shown that if the patient has a normal or high serum prolactin level at the time of presentation, then these patients will have either partial or sometimes even complete recovery of anti-pituitary function, whereas a low serum prolactin level at the time of presentation is associated with the poor postoperative recovery of endocrine function. In other words, preoperative serum prolactin level can be used as a surrogate marker for postoperative recovery of anterior pituitary function. What about visual outcomes? Majority of patients, 90 to 95%, will have some improvement in their vision, either partial or even complete. And the controversy lies only with regard to the timing of surgery and visual outcomes. Many of the early studies, including our own studies, showed that surgery done within the first week of apoplexy gives good outcomes. And our group and Dr. Mahapatra's group have shown that the patients who are either unilateral or bilateral blind, even if operated earlier, even these patients can have useful functional recovery as far as vision is concerned. But then, to be fair, we have to provide a contrarian view that there are some recent publications in the literature, some from Israel, Korea, and France, which have studied the timing of surgery, and they have found out that timing of surgery has absolutely no influence on the outcome. What matters is the severity of the initial visual deficit at the time of presentation. And in this context, it's worthwhile to point out, even those studies, if the authors of this particular study, they came to the conclusion that is timing of surgery has no particular influence on the outcome. But in the very next sentence, they claim that if the patient has a new onset major visual deficit, they will still advocate urgent surgical intervention, that too by a specialized pituitary surgeon. So most surgeons like me do have a bias towards surgical management of pituitary apoplexy. What about our extraocular palsy? Extraocular palsies have a very good outcome irrespective of the mode of management, whether it is a conservative management or surgical management. Extraocular palsies are going to improve well in more than 90% of the patient. Our study and other studies have shown the timing of surgery has absolutely no influence as far as the outcome of extraocular palsy is concerned. And what about the time course of recovery of visual function? Dr. Edglass' group has shown that the first to recover is the visual function, next to recover is the endocrine, the last to recover is the extraocular palsy. And what about the mortality? The early mortality, including Dr. Edglass' series, has shown a mortality rate of 5%, but in much more recent series, the mortality rate has come down, probably because of early and prompt diagnosis and aggressive management. Can pituitary apoplexy recur? Of course, pituitary apoplexy can recur, especially if there is residual tumor. And many studies have shown that between 5 to 10% of patients can have recurrence of pituitary apoplexy, and especially if the NOSP grading is more, or if there is residual tumor elsewhere also, the chance of recurrence of pituitary apoplexy is more. And the recurrence rate is more when patients who undergo conservative treatment. Now, intuitively, we should believe that when pituitary apoplexy occurs, there should be destruction of the adenomatous tissues. Therefore, the tumor should not recur. But then there is ample evidence in the literature. The longer you follow these patients, somewhere between 5 to 10% of patients will recur. Tumor will recur, and therefore, patients who suffer pituitary apoplexy should undergo long-term follow-up, preferably lifelong follow-up. What about the incidence of apoplexy in incidentalomas? 2 Japanese studies have shown that in apoplexy, 9% of patients with incidentalomas can have pituitary apoplexy, and the incidence is slightly higher in patients with non-functioning adenomas, which is the subgroup that is most likely to undergo close clinical follow-up. And this is a factor that should be taken into consideration while counseling a patient with a non-functioning pituitary incidentaloma. What about microadenomas? In 2010, Dr. Kuhlbell's group reported 3 patients with pituitary microadenomas who presented with pituitary apoplexy. The interesting fact is, in all the 3 patients, the presenting feature was headache, which was initially misdiagnosed in all the 3 patients. And interestingly, this particular publication from Israel, just published just 10 days ago, showed in their series nearly quarter of their patients had microadenomas, 7 of the 27, and all the 7 patients with microadenomas presented only with headache, which means pituitary apoplexy in microadenomas can not only be misdiagnosed, it is probably even underdiagnosed. So what about the difference in apoplexy between micro and macroadenomas? The patients are not only older and have more visual deficit, both at presentation as well as at follow-up. Patients with macroadenomas have greater endocrine deficiency than those with microadenomas. So coming back to our clinical vignettes, number 1, this patient was treated by me in the year 2009. But if this patient was of course treated successfully, but if this patient who presented only with headache and third nerve palsy were to present today, one of the options as per the current evidence that is available in the literature would be to treat this patient conservatively, because headache and extraclavicular palsy can be treated conservatively despite our bias towards surgery. Whereas the second example which I have shown here, this patient was also treated 10 years ago. Deliberately, I have chosen patients who are treated 10 years ago. And this particular patient presented with the hemorrhagic mass, a huge mass compressing the chiasm, progressive visual deterioration. There is absolutely no doubt in our mind this patient requires a surgical intervention at the earliest possible time. So concluding, to decide whether conservative or surgical treatment is required should be done on a case-by-case basis. I personally do not believe in scoring systems, and the indications for conservative management include headache alone with or without ophthalmoplegia. Occasionally, some authors use it even for patients with mild visual deficit. I don't use it. Surgical management is indicated for major visual deficit, altered sensorium, progressive neurological decline, and most patients will have some form of endocrine deficit in the long run after apoplexy. Both vision and ophthalmoplegia, the recovery is going to be good. It's important to remember not only the tumor can recur, but also that apoplexy can also recur after if there is a residual tumor anywhere, either in the cavernous sinus or elsewhere. Thank you for your kind attention.
Thank you, Dr. Muthukumar. We'll ask you to introduce Dr. Raj Shekhar.
It's my pleasure to introduce my colleague and friend, Dr. Raj Shekhar, who is the professor and head of neurosurgery at Christian Medical College Hospital, Vellore. His area of interest includes stereotactic neurosurgery, endoscopic pituitary surgery, and he's basically the quintessential academic neurosurgeon of this country. Dr. Raj Shekhar, please.
Can you see my slides?
Yes, Raj Shekhar, we are able to see it. Make it slideshow.
Okay. Okay. Okay, here you go. Thank you, Muthukumar, for that introduction, and thanks, Shekhar, for asking me to make this presentation. Being neurosurgeons, we may be interested in hormonal outcomes in our patients who have functioning pituitary adenomas, but our interest probably wanes in those who have non-functioning pituitary adenomas. Typically, what we do is we send these patients to our endocrinology colleagues before surgery, and after surgery, we really don't pay too much attention to the hormonal dysfunction they had either prior to surgery or after surgery, just expecting our endocrinology colleagues to take care of it. But I think it's important for us to recognize that several of these patients will require replacement therapy both before and after surgery. The other fact to remember is that following resection of non-functioning pituitary adenomas, most of them will have a good visual recovery. But very few patients who have had hormonal deficiencies prior to surgery will recover normal function. So there is very little literature on the long-term hormonal outcomes, especially after endoscopic surgery for large non-functioning pituitary adenomas. And this is a series of patients who we operated. I do the uninostril technique, all endoscopically done, of non-functioning pituitary adenomas. And I would like to present the hormonal outcomes in these patients. So I'll be reporting the hormonal axis function both preoperatively and at follow-up at 3 months after surgery and at long-term follow-up. And we also analyzed certain prognostic factors for the hormonal axis function. So this is a retrospective study which involved 172 patients, all operated on by me. The imaging was done typically at 3 months after surgery and every year thereafter. I'm quite quick to recommend radiation therapy for any significant residue, but if there is a small residue, of course, the choice is given to the patient. And the follow-up duration for this group of patients ranged from a year to over 10 years or 15 years rather, with a mean of about 5 years. Nearly 80 patients had a follow-up of more than 5 years. So these are some demographic features in these patients and the duration of symptoms. Of course, the visual symptoms is what brought them to our attention. Note that about 25% of these patients had NOS grade 3 or 4 tumors. And like I said, about 42% of these patients underwent radiation therapy after the endoscopic surgery for residual tumors. So these are the volumetric outcomes with respect to the extent of resection. The preoperative mean diameter was 3.5 centimeters. So most of these tumors were large tumors. The smallest was 2.9, the largest was 6.2. And Hardy's grade C and D bar E constituted 93% of these patients. The postoperative median volume was 0.4 cc as compared to 13 cc before surgery. We achieved a gross total or near total resection in about 70% and a subtotal resection in 17% of these patients. And here are some examples of the tumors that I'm talking about. These are early postoperative MRIs showing a gross total resection, another large tumor with a gross total resection, and a large giant invasive tumor where we got a near total resection. And these are patients who have been followed up for long term. And this is a postoperative MRI at 9 years following excision of this large tumor with no residue. And another patient with a smaller tumor, but extending onto the cavernous sinus on the left side, again showing no residue after 9 years. So like I said, we graded the hormonal axis damage as 0 to 3 based on the involvement of the thyrotropes, the corticotropes, and the gonadotropes. And these are the results. So preoperatively, those are the blue bars. About a third of the patients had normal function in all axes. Whereas after surgery, you can see that the number drops to 20%. That's at 3 months. But if you follow them up further, this number drops further to about 17%. Again, panhypopituitarism, in which all 3 axes are involved, was seen in 20% of patients before surgery. So that tells you that these patients had large tumors and for a long duration, so their pituitary function was gone. And these patients will never recover function after surgery, the patients who have panhypopituitarism. Again, at 3 months, that number goes up to about 32%. But at longer follow-up of 63 months, the number goes up to as high as about 42%. This is a comparison with literature as far as the preoperative hormonal dysfunction is concerned. And what seems to be different from other series is the fact that we noted a large number of our patients, over 50%, to have thyrotroph dysfunction. Whereas the other series reported only about 1/3 of their patients having thyrotroph dysfunction. The other 2 axes were more or less similar as compared to the other series. And so not very much difference in our findings compared to the other series. So what happened at 3 months and at long-term follow-up to each of these axes? The hypocortisolism, which was seen in about a third of the patients before surgery, increased to 60% at 3 months. The hypothyroidism, which was 56% preoperatively, increased to 70%, and the hypogonadism increased from 41% to almost 60%. Of these three, hypogonadism was the only thing that worsened between 3 months and the long-term follow-up. The other two axes, the hypocortisolism and the hypothyroidism, did worsen slightly, but that was not statistically significant. Fortunately, you can see that the diabetes insipidus, which is of course not there before surgery, was present at 3 months follow-up in 6% of patients, but that recovered in 3 patients. So on long-term follow-up, we had 4% of patients having permanent DI. So when we looked at the prognostic factors, we looked at the tumor volume, we looked at Hardy's grade, we looked at prior surgery, the extent of resection, where we hypothesized that those undergoing gross total and near total resection were more likely to suffer hormonal dysfunction than those undergoing subtotal resection. The effect of radiation therapy, tumor recurrence, and the duration of follow-up. So what we found was that on univariate analysis, patients undergoing subtotal or partial resection, in fact, had higher rates of hormonal dysfunction post-surgery than those undergoing gross total or near total resection. Similarly, radiation therapy was a significant factor in being associated with worse hormonal outcomes in a long-term follow-up. And finally, the duration of follow-up was again a significant factor. That is, patients who had longer follow-up had worse hormonal function than those who had shorter duration of follow-up. But on multivariate analysis, the extent of resection falls off, and we are only left with radiation therapy and duration of follow-up as factors that are associated with worse hormonal function. That is, those who undergo radiation therapy understandably have more dysfunction, and the longer you follow up your patients, the more likely you're going to find patients getting into hormonal dysfunction. And this again brings up the issue of the need for long-term follow-up in these benign tumors. That's also been emphasized by previous speakers. So how does how do our results compare with those published with respect to endoscopic surgery? There are these two articles that I could find with respect to reporting hormonal outcomes. Our results were slightly worse, with 40% suffering hormonal dysfunction on long-term follow-up compared to about 17 and 14%. But you will note that the tumor volume was significantly smaller. Our tumors were double the size of the tumors in the other two series. The gross total resection rates again were half of those reported by the other series, again because our size of our tumors were double and involved probably the cavernous sinus more. The duration of follow-up is similar. So I would like to conclude by saying that we must pay attention to the hormonal function in patients with large non-functioning pituitary adenomas, specifically the larger tumors, because the smaller tumors may not have the hormonal dysfunction, but about a third of patients only will have normal hormonal axis before surgery, and following surgery this number declines to about 20%. But at long-term follow-up, nearly 80% of patients will require at least one or more hormonal replacement therapy, and 40%, half of them, requiring all three replacements. The gonadotroph function is likely to decline following the initial follow-up at 3 months, and therefore this should be assessed on long-term follow-up. And finally, the administration of radiation therapy, and the longer you follow up your patients, the more likely you are to recognize hormonal dysfunction in patients with non-functioning pituitary tumors. Thank you for your attention.
Thank you, Dr. Rajshekar. That was a great talk. We'll open this up for discussion now. We've only have 5 to 10 minutes, and I've looked at the comments, and I'd like to invite Engelbert and Fred to talk about the merits of cavernous, medial cavernous wall resection, because there's a difference of opinion, and from that of Nelson Oyasiku as well. So I'd like to ask your opinion, Engelbert, on whether you try to remove the medial cavernous wall and whether you think it's meritorious.
My philosophy, surgical philosophy, is to follow in these large tumors from the cellar to the extents areas, wherever it is. But with the increasing data that we should, even in small adenomas, microadenomas, which is adjacent to the medial wall, one has to change the philosophy and also to remove the medial wall if you are able to do that. I personally, I think I do not have the ability to go into selectively to remove the medial wall. I can do that if the tumor filled already the cavernous sinus. This is the problem. It's also part of my positioning because I'm sitting like Rudolf Walbusch at the opposite side of the head, not in the vis-a-vis position, which allows to reduce the venous pressure. On the other hand, if you have the positioning as I did, you have a gentle Valsalva for suprasellar parts of the lumen. But I rarely do a removal of the medial wall itself. And what's your experience?
Well, I tried to remove it, but I'd like Rudy to maybe address that, and then also Fred, because he felt that it wasn't any value. I'd like to hear his opinion. Rudy, do you try to routinely remove the cavernous wall?
Of course, because when we have an infiltration or perforation or an infiltration of the medial cavernous wall, then some cells in active adenomas can remain there, and they indicate the failure of hormonal remission. Of course, one has to be gentle with this resection, not to distract or make any problems. And it's easier, of course, in the bottom, below, than above, where it is much firmer. I totally agree with that.
Okay, thanks. Ed, do you try to routinely, you originally published that many years ago, that Cushing's patients have invasion of the cavernous wall.
Yeah, I think it's possible to do that, but our other studies that showed the invasion of the dura in patients that have cavernous sinus involvement makes me a little sanguine about it, because I think that it's hard to get out every last tumor cell when they've invaded in proximity to the dura or the adventitia of the carotid artery. So if it's easy, the answer is yes, you can peel it away. That's okay. To go after every last remnant, I think every last leaf in the sinus, I think, is probably overkill.
Okay, thank you. I'm not sure that Fred's still with us, but let's move on to the next topic. Engelbert, can you discuss, and I'd like to hear from Ed and Rudy and Engelbert, what your indications are for operating on a cavernous sinus pituitary tumor, and when you choose to go in the cavernous sinus.
I think I mentioned that in my presentation. To debulk, it is easier for the treatment. The load of hormones, if you are talking about the functioning adenomas, the load for treatment for the endocrinologists is lower. I think that's one of the things. If you perform medial to lateral work during surgery, I think the risk for cranial nerves is much lower than if you go anterior direct to the carotid. And then there is one thing, that's the inferior lateral trunk, which supplies the cranial nerves. And either it's bleeding, you have to coagulate, and that's a risk for the cranial nerves, or direct damage on the cranial nerves in the lateral wall of the cavernous sinus.
Right.
So, and the indications, if you have a Cushing in the cavernous sinus, which surrounds the carotid, I think there's no chance, and little chance also with the acromegaly patients.
Ed, when would you choose to explore
So
the
I
cavern?
think that it's really a question of reducing the tumor burden rather than doing a complete removal, because I think it's really hard to do that, and we try. But I think there's a real merit in decreasing the tumor burden within the cavernous sinus, so that if you know from the preoperative studies that there's invasion, I try to get in there and be very gentle, of course, and to remove whatever tumor is possible, recognizing that we're probably leaving some behind in many of the cases, not all of them. And then they do better with regard to the subsequent radiation if they need it, if you have a smaller tumor burden. And I think that's been demonstrated, and it's something we can do as surgeons.
Okay. Let's ask, there was another question on the chat, two questions that asked about the use of intraoperative MRI. I'd like to ask the panel when they choose to use an intraoperative MRI.
We have a very elaborate intraoperative MRI. It's not anywhere near as nice as the one that Rudolph had, and the great work he's done with his. But I've done 22 cases. They were very carefully selected. It turns out that because these were complex tumors where we really needed the help, that in 30% of the 22 cases, we found benefit from doing them in the intraoperative MRI, finding nodules of tumor, finding areas of tumor that we missed, that we didn't see, and we recovered, and it helped. So I think for selected cases, it has real merit, but it is a difficult process because you have to make a lot of compromises to do it in the magnet and with the instruments that are necessary.
Yeah.
But
Rudy, would you
have the most experience with this?
Yeah, we have, I think, 600 or 700 cases intraoperatively over 25 years. One have to distinguish between resectable, total resectable tumors from the MRI, and those ones who, from your impression, cannot be resected totally. So in the so-called resectable ones, we overlooked, as Ed said, in silent corners or behind a descending fold of the diaphragma.
Little closer to the microphone, Rudy, maybe.
Oh, sorry. Better? Is it
Yeah.
better?
Much
So
better.
in resectable cases, to distinguish from not completely resectable cases, we found tumor remnants in about 20%, hidden in a descending fold of the diaphragmal cells. And that helped us to complete the resection in 20%. So those patients who would not have the intraoperative MRI would have remnants in 20%. And so it's helpful, but it is limited, of course, in irresectable tumors because those parts which you always think you cannot remove will remain there. And of course, it's an expensive tool. Hopefully it will be cheaper. But To make it short, it's really high field 1.5 or 3 is really superior to the low field. So the low field will not give you the answer you really want.
Yeah, I agree. I mean, we have one, but I must admit it's so impractical. I use it very sparingly for pituitaries because it takes so much longer and it consumes a lot of time on the MRI. So.
Yeah, but that is when you decide to perform the resection and you have the result, that is 20 minutes. After 20 minutes, maybe 25 minutes, you can go on with surgery. If you have such equipment as we have, a turnable table, not when you have to walk with the table maybe 10, 50 meters around the corner. That's different. Yeah. In our theater, we lose for one new examination 20, 25 minutes.
That's very good. And then finally, the last question will relate to the indications for surgery and apoplexy. And there's been some chat saying that the British recommendations are now that if you have an extraocular motor deficit, that's not an indication for surgery and apoplexy. But what, and I'd like to ask maybe Engelbert and Ed, when do you operate on an apoplexy patient? And what are your strict indications for surgery versus conservative treatment?
The answer is easy for me because I always had the indication for apoplexy, adenoma. If he has symptoms, vision deterioration or oculomotor, or very often is also the abducent nerve involved. In these cases, all of these cases have been operated in an acute phase. In the idea that the pressure on the residual tissue of the normal gland is spared. This is maybe not in every case possible. So, and the improvement of the hormone situation is not let's say convincing.
Yes. Ed, what are your indications for operating on an apoplexy patient?
Well, I am adamant about that. I think that essentially every case of apoplexy that is symptomatic should be treated surgically. And I think that we have the surgical methodology and the surgical skills and the ability to preserve normal gland that allows us to do that safely. The risk is very low. And just sitting around watching them slowly get better, if they get better at all, it does not appeal to me, but I guess that's because I'm a surgeon.
Yeah. Dr. Muthukumar, would you like to respond to that?
I do agree because I specifically chose 2 cases which I operated 10 years ago because the first case who presented with third nerve palsy and headache, he had a total third nerve palsy. At that time, I went in and operated. But as per the current guidelines, the UK guidelines which came out subsequently 2 years after I operated on this case, there is, and the recent literature, it supports that conservative management is an option. But even at that time, to that patient, I gave the option of conservative management, but the patient's brother was a physician who insisted on surgery. So we went ahead and did the surgery. But as Dr. Edlas pointed out, and I pointed out in my first slide, I am biased towards surgery. As surgeons, we are all more inclined to do surgery.
So it's an evolving issue. Fred, will give you the last word. The indications that you use for operating on apoplexy. Fred, you're muted.
What about yours, Bill?
Sorry, Bill. You know, we are surgeons, Ed, and we like to operate, but you know, there's also, we have to look at evidence-based medicine. And my issue is no question, any significant visual issues, operation right away. But someone who comes in who is no visual disturbance or very mild, 20, 30, whatever, no cranial nerve palsies, I will observe that patient. And Ed's shaking his head. I've seen patients that, and his thumb is going down too. And I've seen patients that I've done exactly the same at 3 months, beautiful third nerve palsy resolved, that I'd operated on, the same person that I watched resolved the same way. So I hope that maybe this, we're involved in the pastor study. I think many of us are involved here. We'll get some better information and on the outcomes in these. So it's still up in the air, and I think it's an individual thing, including patient involvement. As you say, you tell the patient the situation, and sometimes they will make the decision for you.
Thank you, Fred. With time constraints, we're going to have to move on, and I'll turn this over to Danny Prevedello, who will chair the next session.
Thank you, Professor Coolwell, for a wonderful discussion. Thank you to all the panelists. We move on to session 3, and I have the pleasure of introducing the chairpersons for this session. The first being Professor Daniel Prevedello, who is the Director of Minimally Invasive Cranial Surgery at the Department of Neurological Surgery, Columbus, Ohio. Then we have Dr. Sanjay Bihari from the prestigious Sanjay Gandhi Institute of Medical Sciences in Lucknow. We have Dr. Yadram Yadav, who is the Director of Super Specialty Hospital and the head of the Neurosurgery Department from the Jabalpur Medical College. And finally, Dr. R.C. Mishra, who's a consultant surgeon in Agra and a former chief of the NSI. May I request Professor Yadav to introduce our first speaker, Dr. Manas Panigrahi.
I know Dr. Panigrahi for long. He's an excellent, skillful surgeon. He worked initially in the Nizam Institute, prestigious Nizam Institute, for long period, and now he's working in KIMS, Hyderabad. His special interests are in skull-based surgery, neurovascular surgery, pituitary surgery, minimally invasive surgery, and spine surgery. And he believes in simple innovations. He has done quite significant number of them, simple, inexpensive innovations. Dr. Panigrahi, please.
Yeah, good evening. Thank you, Professor Yadav, and thank you, Professor Dev Pujari, for giving an opportunity to speak in this meeting. Can you see my slide?
Yes, yes, yes.
Yeah. I think part of the talk has already been covered. What I'm going to speak on surgery for prolactinoma. What I'll be presenting is what is the indication of surgery for prolactinoma, but because the first line of management in prolactinoma is medical management. But then there are a few indications where one has to suggest upfront surgery instead of giving the option of a conservative. Like we have controversy in apoplexy to do conservative or surgery. In prolactinoma also there are some situations where one has to opt for surgery as a first option. Now, if you look at the history of surgery for prolactinoma, surgery was the mainstay of treatment initially. But then when dopamine agonist was discovered in 1980, similar to Parkinson's disease when Syndopa came, all of us changed over to doing medical management. And when we were residents or long ago before 1980, when we had a 28-year-old female with prolactinoma, medical management was preferred as surgery was thought to be detrimental to pituitary gland. In spite of using microscopic and endoscopy, as Dr. Rajshekar presented, there has been a change in the a reduction in the there's an increase in pituitary dysfunction following surgery. And earlier, before the endoscopic and microscopic era, the chances were of pituitary hyperfunction was still higher. So people preferred medical management over surgery. But then at present, what has been the change? Either is still prefer medical or surgery. Now, this is a case which we had treated 2 years ago, and this patient came with this scan, primarily a paracellular lesion with a cellular, paracellular, and a large intracranial component. And when we did a prolactin level for this patient had a prolactin of 11,000. He had a hemianopia, and the prolactin was 39,000, not 11,000, 39,000. And we treated this patient with cabergoline, and post-treatment on cabergoline, it reduced to 10% of that value. From 39,000, it came to 3,700 in a month. And over 4 months, it came down to 890. And the visual field, patient clinically had improvement in the visual status, as you can see in the perimetry, and you can see in the scan also. So the upper one is a pre-op scan and the lower one is a post-op scan. There's a significant reduction in the size. And so this patient is still on follow-up with medical management. But though medical management is so effective, but then still there are a lot of controversy on medical versus surgical management and which is the best way to manage. To understand this, we took out the cases which had operated over the past 8 years. Of the total 450 cases of pituitary we operated, prolactinoma we had 62 cases. They're either prolactin positive post-operatively or a higher prolactin level pre-operatively. No, but most of them, whenever patient comes, our first line of treatment is medical management. But what are the issues of just treating the patient with medical management? With in a developing country, giving lifelong treatment with cabergoline also adds cost. The cost of treatment becomes many times higher than a single surgery. 10 to 20% of patients do not respond to dopamine agonists. They have resistance. And another 10 to 20% do not tolerate the drugs. They develop side effect to the drug. And what do you do when a patient comes, a lady, pregnant woman comes with a tumor, whether you do a medical management or go for surgery? And as I pointed out earlier, before the microscopic endoscopic era, we thought that fertility rate is higher in medical management. But after the endoscopic microscopic area, what does the literature say? Is it fertility rate better in medical or better in surgical? That's what I'll explain in my consecutive slides. And what is the recurrence rate? Is the recurrence rate higher in medical management or recurrence rate is higher in surgical management? I'll be referring to literature and finally conclude what will be the best way to manage. Now, this current indication, the indication of surgical management literature has again come back in the past 5 years. This paper came in 2015. Now, this was published a review in 2019 in North American clinics on the role of surgery in management of prolactinoma. Now, the first issue, as I explained, is the cost effectiveness. Is it medical management is more cost effective than surgical? As upfront or logically, we think that medical will be cheaper, but what exactly is the literature say? Now, this paper came in 2017, and they analyzed that the cost of cabergoline treatment is almost $6,000 in first year. And if one is using bromocriptine, it's $4,000 in the first year. And each consecutive year, again, it adds up $5,000 if one is using cabergoline, or $2,500 if one is using bromocriptine. And this is quite high. So if a patient who is diagnosed of a prolactinoma at 40 years of age, and if he survives for 10 years, the cost of treatment of medical management is higher than the cost of surgery, because the cost of surgery is this is from a paper from US. The cost of surgery is $40,000, whereas the cost of cabergoline becomes $70,000 over in his lifetime. So surgery is more cost effective in younger patients, but maybe it is cheaper in elderly patients. This is another similar paper on the cost effectiveness which was published in 2019, where again they published that surgery is more cost effective if in a younger patient, especially if the life expectancy is greater than 10 years. Now, what is the recurrence rate? Is it more in surgery or in medical? Now, the pituitary surgery for small prolactinoma, now if in this paper which was published in 2017, what the showed that when the drug was withdrawn after 2 to 3 years, the chances of recurrence of getting back hyperprolactinemia was higher in the medical group, like 64% compared to surgery group, which was 32%. So the recurrence rate is higher in medical management. Either one cannot withdraw after 2 or 3 years, or if prolactin is normalized, because the chances of going increase in the prolactin level is almost 60%. So they have to take almost 60% of the people have to take lifelong dopamine agonist, whereas in surgery only 30% they will have recurrence. So surgical outcome, unfortunately, is dependent on the expertise and experience of the neurosurgeon, as well as the size of the tumor, as my previous speakers also have highlighted that. Now, this is a series of papers of 50 papers on surgery for prolactinoma, and what they published is that the remission rate in prolactinoma has been 38 to 100% for microadenomas and 6 to 80% for macroadenomas, which is better than medical remission. So having known this, that it's more cost effective and the recurrence rate is less, probably surgery is a viable alternative as a first line treatment for prolactinoma patient. And this is a systemic review and meta-analysis. Now, how often does the patient respond to dopamine agonist? Means 10 to 20% of the patient do not have dopamine resistance. They do not respond. So these are the group of patients one has to offer surgery. Now, the definition of dopamine resistance has been not clear, but then what does the literature say is after giving dopamine agonist or failure to achieve reduce adequate level of prolactin so that one can achieve ovulation. Now, this is a case which treated again in 2018. This is the pre-treatment MRI, and this is post-treatment MRI following 3 months of dopamine agonist. There was no decrease in size of the tumor. Now, as we know that in cabergoline, the hormones can come down drastically in 3 weeks, but in bromocriptine, it takes 6 weeks. So the criteria of dopamine resistance is taken as 2 months. So or 3 months. So if 2 milligram of cabergoline per week is given for 3 months, or 15 milligram of bromocriptine per day is given for 3 months, and if the prolactin level does not normalize, or if the tumor size does not reduce by 50%, or they do not establish the normal hormonal function like normal menses, then this group of patients, like the one I showed the example, are taken as dopamine resistance, and they have to be offered surgery. And the other indication of surgery is cystic prolactinomas. Cystic prolactinomas, this is a case which came to us long ago in 2014. There's a large lesion and the prolactin was high, and the cystic prolactinomas and cystic tumors with apoplexy do not respond to bromocriptine. They are dopamine resistant. So these are the group of patients. Again, one has to, this is another case of a cystic tumor with apoplexy. The previous one was a cystic only tumor. So these two group of patients have to be upfront offered surgery rather than medical management. And this is also proved in literature that cystic prolactinomas with or without apoplexy have to be offered surgery as a first line of treatment. Now, what is dopamine agon intolerance? The patient might tolerate cabergoline, the prolactin level might come down, but then there's a significant number of people who do not tolerate. They develop nausea, postural hypotension, they can develop mental fogginess, and a long-term use, lifelong more than use, they can valvular heart disease also. And less common side effects are Raynaud's phenomena, constipation, depression. And the incidence of this is almost 10 to 20%. The intolerance is 8% in cabergoline and 14% in bromocriptine. So again, this group of patients need to go for surgery. And side effect, symptomatic side effect, those side effects happens in 22% in cabergoline and 43% in bromocriptine. But symptomatic side effect like intolerance is half of that. So 8 to 14% of the patients need to go for surgery as they have intolerance. So 10 to 18% have resistance and 8 to 14% have intolerance. The sixth indication for surgery is CSF leak, as Professor Caldwell was explaining in his lecture, that if a patient, this was a patient who came with MRI of this one, there was destruction of the bone, and we offered medical management. Probably that was a wrong decision, and patient came back with significant reduction in the size, but came back with CSF leak. So we had to go for surgery. We removed the residual tumor, did the CSF leak repair, and since then we are following this paper which was published from Nimmans, Bangalore, that if a patient comes with a prolactinoma, if there is destruction of the bone like the clivus or the sella, then the first line of management should be surgery rather than medical management. Like this case where the prolactin was high, but the bones, the clivus was totally destroyed. So this patient will definitely come with CSF leaks. So the first line of management should be surgery, decompression of the tumor, and repair of the defect. The seventh indication is pregnancy and fertility. Now, fertility is supposed to be better in medical, but this paper which came recently, they said the fertility after transmural surgery was better in a meta-analysis, better than medical management. Now, in that paper, they highlighted that transmural surgery improved the fertility measures in women with prolactinoma, especially in microadenomas, than medical management. As when we give, there's a lot of controversy that if a woman is planning pregnancy, whether to continue cabergoline or not, as we do not know the fetal side effect of continuing cabergoline when a woman becomes conceives on treatment with cabergoline. Now, what do you do if a pregnant lady comes with a pituitary tumor or a prolactinoma? We know that 5% of microadenomas will increase during pregnancy, increase in size in pregnancy. Whether this group of patients should we continue on dopamine agonist or do a surgery in the second trimester, which is quite safe. So this is the algorithm of a prolactinoma in a pregnancy, that if they do not respond to cabergoline, it is probably better to err on the size of surgery, especially in the second trimester, rather than wait for the third trimester when surgery becomes difficult. So initially give a try for 4 to 6 weeks of medical management, and it doesn't come down, then it's better to go for surgery in a pregnant lady, especially with a macroadenoma. Microadenoma, one can offer to medical management, but macroadenoma is the 35% of them increase in size. Surgery is a better option. And whatever I've discussed, and we have published in Neurology India in 2020. So finally, the surgical indications of prolactinoma as in microadenomas is resistance or intolerance to dopamine agonist therapy, and if the patient doesn't prefer to take lifelong therapy, then surgery should be preferred. And in macroadenomas, if they have a apoplexy, or if they have a cystic tumor, or if they have resistance, and if the tumor size does not decrease by 50% in 3 months, or there is extensive destruction of the bone, and a female who desires pregnancy, all of them should be offered surgery as a first option rather than medical management. Thank you for your attention.
Maybe call on Professor Prevedelo to give his talk.
So thanks so much for the invitation. Let me share my screen here. So thank you so much. It's a pleasure to be here. for the invitation. Thank you, Dr. Deopujari, Vikram for the organization. And, you know, a lot of what we're going to say here was already discussed before, but I'll try to go more specifically into the acromegaly management related to surgery. So I'll try to be quick here with the presentation. I would like to just emphasize, remind ourselves, it's a rare disease, you know, just about 1 person in 100,000 will have as a new incidence of acromegaly, but we do see these patients as they funnel in our clinics as a surgeon specialized in pituitary. And as Dr. Laws mentioned earlier, very important to remember that they do have comorbidities, diabetes, carpal tunnel arthritis, hypertension, sleep apnea, and if not treated, if the IGF-1 is not brought to normal, they have a higher mortality with higher morbidity. Interestingly, if you treat properly and the IGF-1 goes back to normal, these people go back to the regular mortality, morbidity of a regular population. As I said, the diagnosis is with the high IGF-1, and you have to remember the OGTT, where you give glucose and you want to see in a normal person a suppression below 0.4. This is a number that has changed over the years. It used to be 1 nanogram per deciliter, and now it's considered 0.4. The suppression has to go all the way down. If it's not suppressed, that's when you diagnose acromegaly. The one thing that is, as neurosurgeons, sometimes we forget, that is 5% of acromegaly that can actually be caused by a tumor that is not in the pituitary gland, hypothalamic lesions and other neuroendocrine tumors. Just have that in mind, particularly if you're not convinced there's a pituitary adenoma. Sometimes further studies, octreotide scans are advised. So this is a slide that Dr. Laws showed earlier today. He shared with me in the past. So I just want to point it out that in general, with the surgical treatment, which is the first line of treatment, and we're going to talk more about that. So the first line of treatment for growth hormone producing tumors, we were able to release mass effect in most of the cases, 95%, improve the symptoms in 95%. And the normalization of growth hormone secretion as a surgery only is basically in the literature is not as good, because most of these tumors invade the cavernous sinus when you put all these cases together. So that's why basically we can, as Dr. Gentili said, not cure, but put these patients in remission is half of the patients, basically 50 to 72%. And most of the time we preserve pituitary gland, 95% of surgeons, and recurrence can vary in 10 years from 1 to 8%. I always tell the patients the chance of 1 in 10 to be realistic with the patients. And patients, 70% are living well because of the comorbidity, particularly as Dr. Laws pointed out. It's because of the morbidity if these patients are not in complete remission over the years. So in general, as the first line of treatment will be surgery. And as I mentioned, about half of these patients will go in remission here. And then the next step in treatment is the use of somatostatin analogs. And then with these measurement, you can bring most patients in remission. And then we are talking about about 90% of the patients will be in remission with surgery and somatostatin analogs combination, even if there's invasion of the cavernous sinus. And the beauty is that it's unlikely for the tumors to progress if the disease is under control. Sometimes there's a need of a second agent to control and to bring the IGF-1 down to normal, and that controls another percentage of patients. And only less than 5% of these patients end up with the need for radiation, and extremely rare. I don't have any patient in my series, I will show at the end, that really need chemotherapy as part of the treatment. So when we do surgery for these acromegalics, you have to remember the lack of space. So we've been doing this endoscopically endonasal with the ENT partner as a dynamic visualization process, forehand technique, as we've been doing this for a long time. But you have to remember the narrow passages in acromegalics, the growth of the bone, as Dr. Laws mentioned, we proved in a study that the amount of space you have in the sinonasal cavity is narrower than any other pituitary approach. In terms of the approach, we initially would do rescue flaps for small tumors early in our careers and flaps for larger tumors. And over the years, I noticed that even for larger tumors, sometimes you don't have a CSF leak. So we've been doing rescue flaps, which consists in the preservation of the pedicle of the nasoseptal flap. In case you need to do a flap, then you can do at the end. And that's the way it looks like. So we go with the camera here all the way to choana, and we perform the incisions of the nasoseptal flap by creating a cut on the roof of choana, and then down to the lower part of the septum in the confluence with the palate, and then another incision superiorly that is the same as the flap, but just we stop it before getting to the olfaction area. And then this is the way it looks like. We can work actually above and below. The pedicle is still here where you have the posterior nasal artery vessel. So if you need to elevate the septum flap, you can do at the end, but most of the time you don't need it. And then you don't have that problem of where to put the flap in case there's no CSF leak, and you decrease morbidity that way because the flap has its own morbidities as well. And of course, then full exposure, like I said, remember as well that in acromegalics, there's a chance that the distance between the carotid arteries are going to be narrow. So you can have kissing carotid arteries in these cases. The exposure has to be optimized. You want to make sure you see above and below the tumor exposed, sometimes even drilling the clivus and the floor of the sphenoid to optimize the exposure. And if we need to go to a cavernous sinus, we add a transpterygoid approach in one of the sides, the side of the invasion inside the cavernous sinus. For larger tumors that go up, we often drill the tuberculum sellae as well. And here you can see even exposure, the medial aspect of the optic canal to optimize the exposure of these tumors. So once we got to the sella, I always try to find the pituitary gland very early to optimize the preservation of the pituitary gland. So here you can see, if you don't look for it, you don't find it because it has same color and everything. But you can see here, finding this plane very early, even in soft tumors, really help you to preserve and understand the anatomy. And I think that also prevents CSF leak, because if you dissect in between the dura and the plane of the pituitary gland, you disconnect the gland all the way up to the cistern, and you actually allow CSF to drain and leak in between the gland and the pituitary gland and the dura. So avoid manipulation at 12 o'clock here, and really look for the gland very early. So here's my advice in these cases. You can see here defining before you jump and take tumor out, really look for that plane. And usually it will be the easiest area to find it is the area where in the MRI where the gland is dislocated. So I always look is more to the right, more to the left, and you can find that plane. Then for the cellular tumors, the microadenomas, I try to do resection on functional tumors, including acromegaly, by performing extracapsular dissection. This is, was published by Dr. Oldfield in 2006, and we've been trying to replicate that ever since with the endoscope technique as well. So really important to define it. And what I've noticed over the years, you don't need to really do the entire dissection extracapsularly. If it ruptures a little bit, just because you actually started that plane, you can actually re-encounter that plane afterwards and make sure that the complete resection was achieved, and you make sure that you didn't enter inside the posterior pituitary gland as well. So a little rupture like this is not a big deal as long as you go back and recapture that plane. So for cellular lesions, we always try to do that type of dissection. For functional tumors, you will see that the initial MRI, it looks like exactly the size of the tumor. And then when you do a few months later, it looks like you're never there with a small scar there. This is another acromegalic. As I learned with Dr. Laws, they always look more whitish type of tumor. This is a case that I removed part of the tumor, but I had the plane defined. And so this is exactly to show that case that you go back to that plane and you reestablish that plane in order to get the tumor out of there. So you can see here that we keep dissecting away from the gland, really using that pseudocapsule, which is made by normal pituitary gland, and you can really dissect that and remove that tumor out of there. Here you can see the final dissection, and what I do then these days when I find that plane posterior to the gland, I use a 90-degree curette small that I engage in between the gland and the tumor, and I roll that out of there. So as you can see here. So then you protect the posterior gland that way. You don't force any dissection into the posterior gland, and you can then get the tumor out. So this is an example of an acromegalic, and you can see then one thing to tell patients is that the soft tissue gets a lot better, but some of the bony changes that happen in the past, they do not change with the surgery. But all the markers for health, as long as IGF-1 is under control, improves diabetes, improves hypertension, and improves the life expectation back to normal. So here's another example. The importance of really identifying that gland earlier that will help you to really identify the plane. So here's another one that we are identifying the gland, and this is almost like an episiotomy there, like carefully not to cause a leak superiorly to allow this a little larger tumor to go around. And I like these dissectors that we design here, like to go around and not to fight with the camera. So you can see it has this shape, so you can get very close with the camera without like swording the dissection. So really, I think optimize the dissection. And you can see here that when you find the gland, you can then go around and dissect these tumors out of there. And again, extracapsular is the best way to deal with these tumors when we are dealing with the acromegalic. And you can see here then the final resection. So then it's important to really inspect the cavity, make sure that you got everything out, remove, I learned Dr. Laws as well, remove these bits of tumor that you see there. And that's when we explore the medial wall of the cavernous sinus. If there is invasion there, that we are aggressive, but most of the time we don't find any invasion there, and then there's no need to remove the medial wall of the cavernous sinus, in my opinion. I'm going to talk more about that later, but here's another application that we've been using. This is the use of ICG. The ICG will enhance and fluoresce the pituitary gland, but will not fluoresce the tumor. So it's not the best type of what you want, but it helps to define the position of an adenoma, and then you can evacuate that adenoma out of there. And when you use at the end is, you don't really have that validation because the tumor is out and the tumor was not fluorescing anyways, but it helps you to see a little bits of things that sometimes you don't know if it's gland or tumor. And if it doesn't fluoresce, you should take it out, because if it could be a dead gland as well. And that's one of the indications that helps there for that. This is another one that I've done recently. McGill, my fellow, put this together. This is a 28-year-old that had acromegaly at the age of 18, and then had a recurrence. And with the recurrence now becomes another challenge. And you can see that this is a case that I was very worried about creating diabetes insipidus for this patient, because the recurrence was really in the posterior part behind the pituitary stalk. So just to show, this is a case we've done recently, narrow corridor, a lot of the scar. And this is one of the challenges with recurrent tumors, because you don't have that beautiful anatomy. And here we're dealing with the scar to get to the sella. And I always use scissors to remove that scar, and then drilling more, as Dr. Gentili mentioned, very helpful with the endoscopic visualization with a broad view to be safe and to know where the carotid arteries are. Once again, you can have narrow carotid arteries in most of these acromegalics. So here then we opened the dura, and because I didn't want to create a leak, I actually went posterior And that's another advantage of the endoscope. We could go posteriorly there. And I was very worried not to cause the eye. Am I at the posterior gland or that's tumor? And after like really investigating, we really identified that this was all tumor. And you can see again that that was the location. We used 45-degree endoscope coming from underneath, and we were able then to clean that cavity very carefully. I was really worried about diabetes insipidus here, but you know, like this is a recurrent acromegaly young patient. We want to bring a remission for the patient. So we explored that cavity, found a little more anteriorly there with the 45-degree. And again, I like to use this the 90-degree curette to go posteriorly and roll it anterior. And you can see a little more of the tumor that was adherent to the gland there. Interestingly, we entered this cavity and looks like the stalk is right here. We actually were able to preserve the posterior gland. We were lucky with this. I learned this from Don Kelly using hydrogen peroxide in this functional tumor. So I do that as well. And you can see that this patient actually did not have diabetes insipidus and had markers of growth hormone below 1. And that's what you want in these cases. In the first 72 hours after surgery, growth hormone isolated below 1 is an indicator of long-term remission. And patient was discharged with no diabetes insipidus. And interestingly, an IGF-1 normalized just 7 days after this surgery. So one thing I want to mention is that I think we do different than most places. We actually collect growth hormone during surgery. And I've been doing this for 10 years now. The baseline of growth hormone in this patient, you just saw the picture, the recurrent one, it was lower. As you massage the tumor, it goes up during surgery. At the end of the surgery, it came down, but the following day goes even lower. And that's the number you want to be below 1. And at 7 days after the surgery, it was actually undetectable. So really a nice way to see. I do think that this proves that you touch the tumor when you have an elevation during surgery. And these are some of my own numbers that we looked at recently. You know, this is about 45 patients. And interestingly, most of the tumors are microadenoma, 77%, but we did have here cavernous sinus invasion confirmed in 40% of these patients. Supracellular extension in 44%, and history of previous operation here in 13%. And the growth hormone that we actually check intraoperatively, it correlates when it's very low with remission, with high sensitivity, high specificity. And we are working on the publication about this because I think in the future we should be checking growth hormone during surgery. And I'm trying to see if this really makes sense. The thing is, though, that the post-operative is really still the best way to make sure that there's long-term remission. And my intraoperative analysis has been all over the place, but shows that if it is lower during surgery, you can actually have show a tendency of remission. So we're trying to study this a little better. And again, if you have your minimum as a very low number during surgery, shows that you actually achieve a good resection. This area under the curve here shows that it really predicts good, very well that remission. However, the postoperative one is still the best. It's still the best. That growth hormone measure the following day, if it's below 1, it will most likely predict remission. And this is my cases when I distribute them, lower intraoperative minimums correlated with remission very well, but it's not 100% as I mentioned. I just want to finish with showing sometimes tumors that invade the cavernous sinus or tumors that are more invasive. There's a 55-year-old lady, and she had a high IGF-1, and her symptoms were related to her hands and her jaw that was growing and her tongue. And this is, you see, more invasive. And you have to also to remember that it can invade the clivus. And this is what I'm going to show here. Very important to be aggressive at drilling the bone. And here you can see we're exposing the carotid artery, because this is the tumor here. And I use this other modality of ICG here, use the green color, and help us to see where the carotid artery is there to be aggressive. So I like to do that in meningioma surgery as well. it really defines the position. So we enter the tumor, create a tumor dissection, but after removing the tumor here from the medial aspect here of the right side of the cella, we then look at the tumor invading the bone, and it was invading the bone here, and I looked at it, looked to me that was invading the wall of the cavernous sinus, as you can see there as well. And so here, what we did, we really aggressively worked over there and removed some of the margins of the gland on the other side. And then I started working on this that initially I thought was dealing with the medial wall of the cavernous sinus, but then I think it was just a layer of gland that was infiltrated there. And here's the real medial wall of the cavernous sinus there. But the endoscope gives you that view to really be aggressive. If I need to go further, we could actually remove that medial wall. I only removed the medial wall if there is like an obvious tumor invading there, and this one didn't have it. Here, then I think you got to be aggressive with the bone as well. So I think this is one of the advantages of the endonasal endoscopic. I think with the microscope was a little more cumbersome to do this drilling near to the carotid here. And we drilled all the way until we saw dura there and got the dissection near the carotid artery. Again, hydrogen peroxide, and then this is just a graft that we use when we use a rescue flap. No need for a full flap. There's no leakage of fluid in these cases. This patient had a tumor invading that little wall. We said as cavernous sinus wall, but it was just a piece of gland. And the patient did very well with remission as well, with 0.4 on growth hormone and the postoperative day 1. And you can see how the end of the case, it was going down already, the markers there. She did have epistaxis that came back to the hospital. We took care of her. She's doing great. So when cavernous sinus invasion is present in acromegalics, I do follow the tumor as Dr. Nospi was talking about. And this is just a quick example of how we do. This is my last case I'm going to show here. So this is the transpterygoid approach that we do to optimize the exposure of the cavernous sinus. So I really recommend this. This is 20 years ago, Dr. Giorgio Frank and Dr. Pasquini showed to the world that this is the way to do it. And we've been doing that way, really optimizing the lateral exposure of your sinonasal. Don't limit yourself to what you have with a regular approach. You have to do this more aggressive exposure there. So here, then we keep going, and with the feather blade that we use here, open the cella first. And because this is a soft tumor, one advice I have to you is don't really go up to decompress the optic nerve too early, because you're going to have a diaphragma coming down. So I actually go to the cavernous sinus first. I remove the cella and then I go to the cavernous sinus. And here you can see after finishing the cella work, in these cases, I enter the cavernous sinus through the front. I dissect with a ball probe first, and I use the scissors. This is totally cavernous sinus in front of the carotid approach here, and the medial wall of the cavernous sinus is in the middle here. So we're going to remove that as well as we dissect this tumor. There's another blade that you can use with 90 degree, and this is a soft tumor. So I follow the tumor inside the cavernous sinus like this until I expose the carotid, and I try to go in all compartments of the cavernous sinus. As Dr. Laws mentioned, this is a functional tumor. And if you can take it, you just keep going. And of course, if the tumor is very firm, then it's a limitation of the technique, because then it's not a place you're going to use a power instrument here. And that's the way we do. So then we went up to the upper part and removed the rest there. And at the very end, I double checked behind I removed the medial wall of cavernous sinus right there. And now I'm connecting here cella and cavernous sinus. And we remove all that and then dissect it all the way to the posterior compartment. And then at the end, hemostasis, no CSF leak, but I do put like collagen matrix in front of the carotid and inside the cella. And this is another thing is, I think for large tumor, it's important to put like something in the cella to prevent the diaphragm to stretch the pituitary stalk as your resection is completed. So this is the post-op, but for acromegalics, for any functional tumor, a good, beautiful MRI doesn't mean much. So here you see that we had a high number of cavernous sinus invasion patients. With surgery, about a little more than 50%, we get into remission. because of all these patients with invasion. And interestingly, then most patients then get somatostatin analogs. They get into remission after that, and then these basically only 5 patients that end up with the need for a second agent, and only 4 out of 45 patients in our series needed radiation. So it's just the combination of surgery of somatostatin analogs really works. And I don't have a single patient that needed a chemotherapy or like a cancer related to acromegaly. I do have patients with Cushing's that needed that, or with silent ACT agents, but not with acromegalics. And I had only 1 patient in this series that had permanent diabetes insipidus. So I thank you so much, and we'll continue with the beautiful symposium. Thank you.
Thank you very much, Professor Pravedello, for this wonderful lecture. And our next speaker is Professor Deepu Banerjee. I'm honored to introduce him. He's a senior consultant in Jaslok Hospital. He's been the president of the Neurological Society of India, as well as the Skull-Based Surgery Society of India. And his areas of interest have been skull-based surgery, brain tumors, pituitary, vascular surgery, and spinal surgery. And he's one of the first neurosurgeons from India who has had a very close collaboration with his medical colleagues, and this collaboration still exists in our department where he was a professor, that is SGPGI Lucknow. And this very close collaboration which he established nearly 20 years ago is still going strong. So I have great honor in requesting Professor Deepu Banerjee to present his presentation on pituitary tumors.
Thank you, Sanjay, and Dr. Dev Pujari and team, Vikram, everybody for this occasion, and very nice discussions going on. And so I will be talking on Cushing's surgery. So most of it has been already covered. So maybe there's some repetition, but let us go. Is it seen now? Can you see it, right? Yeah.
Yes, you can see.
Yeah. So basically, we see the first thing which strikes is why Cushing called it a disease rather than an adenoma, like a basophilic adenoma he published. Because it is a disease. I mean, we just don't restrict ourselves to one radiological picture which we see. Most often it is correct, but quite often it has a progression over a disease. And this, I just found this stamp. And this is not from the Neurological Society, it is from the cardiologist, because he also was recognized for his work in experimental animals with valve formations, lesions in the valves and other thing. So as we know, Cushing's, though it is most of the ACTH secreting cells are in the center, but the tumor can happen anywhere, and it is all varieties, small, medium, large, any types. Most of them is small. Now, what are the dilemmas when you are deciding to operate or manage a disease? One is the origin, pituitary. We know most of the time it is a pituitary origin, but then certain cases we have all encountered where we don't know why it is. So is there a hypothalamic involvement in 10% of the cases? That is, CRH is stimulating from somewhere and producing adenomas even after surgical resection. Is it a heterogeneous disorder? Means we see most often are adenomas, but there are some cases where there's hypoplasia, sometimes there are neural tissue involvement, and we have seen multicentric tumors or multifocal tumors. So as already discussed earlier, is a very, very diagnostic challenge and therapeutic challenge. And if we follow them long, there is a recurrence. So that means there is something which we are still not understood well. So challenges from surgical point of view, one is of course the localization. Unless the MRI is very, very conclusive, we are lost where to operate and how to operate. Then there is anatomy, we'll come to that. Then what already has been discussed, dural invasion, cavernous sinus invasion by Ed Laws and many others, that from 40 to 80% invasion when the tumor is lateral. Pseudocapsule margin, again, it was discussed by, I think, Ed Laws and others also. So very important. And then multifocal adenoma and recurrences. So localization with the advanced MRI, still I think about 20% are not well picked up, because either the tumor is very small or it doesn't give a nice imaging quality. These are the old pictures from Sanjay Gandhi, as Sanjay mentioned, where we have good collaboration with endocrinology department, who had worked up very well. And you can see that sometimes you don't see the tumor, though there may be some suspicious areas. When you do dynamic scan, you can pick up some more, and which can give you an idea where the adenoma is. But sometimes you are lost. You don't know even after dynamic scan, is it hyperplasia or something else, or the tumor is too small to be picked up by the MRI. So these are the radiological dilemmas where one has to use experience to manage that. Of course, in these cases where we have a doubt whether it is a central origin or not, we use bilateral infravertebral sampling, and 6 of these cases were positive. During my stay in Sanjay Gandhi, we didn't have CRH, so we used vasopressin suppression. It was quite okay to at least finalize that is a central origin tumor. I had lucky to visit center in Japan of Kuwayama, who had that time, in 94, had already 200 cases of Cushing's. And he that time emphasized that sectorial search for tumors, even if either you don't see the tumor, or if you see the tumor, you still search in the other areas. And I think Dr. Falbush has been very, in all his lectures, he emphasized that you should always do a sectorial search in rest of the pituitary gland or in the tumors where you don't find in MRI. Anatomically, the challenging are mostly in the children because they have a very flat sella. Sometimes you don't see the sella. We don't know where is the tuberculum celli, where is the clivus. So there the navigation now is very useful. Sometimes these small adenomas have large venous lakes, and it can be very challenging, requires a lot of hemostatic and patience. And of course, conchal tumors and non-pneumatized sella can be managed very well with navigation and drill nowadays. So coming to this, already has been discussed, dural and cavernous invasion. So excision, I think Dr. Pravudelov, in acromegaly cases, then it's the same, that how much we can go. I think it depends on how much expertise you have, experience you have. Dr. Knopf defined very well how the cavernous wall is very important to prevent a recurrence. But then again, depends on one level of competence and experience in these kind of cases. So most often the large pituitary functioning adenomas and the one which are the lateral ones are the one which are very invasive, and they infiltrate the dura. And if we are not able to address them, there are high chances of recurrence. And this was by Oldfield article, which has been referred earlier, that he resected the tumor along with the medial wall of the cavernous sinus and confirmed on histopathologically the reticulum stain, the reticulum stain and infiltration by the ACZ secreting cells. So this definitely shows that one should try to excise the adenoma, the medial wall of the cavernous sinus and the dura. Now he also gave a classification that if the adenoma is there's a kind of a capsule, the pituitary capsule is all around it, even the tumor is lateral, then it is not infiltrating. But if it is breached that capsule of the pituitary gland, the glistening capsule, and touching the lateral wall, then it is likely that it will have infiltrated or islets of adenoma. So in that case, it should be removed. However, where there is a C-type, where it has already invaded the cavernous sinus, it may be difficult how much you can decompress to reduce the tumor load, but total removal may be difficult. So this is one patient, say 230 kg, large tumor with a subfrontal extension. So here one needs to do extended endoscopic approach. And we had to use a obesity OT table because she couldn't fit into the other tables. And we had to really stoop over to do this surgery. Just to show, I mean, this is not a very good quality MRI, video. But what I want to show is that how infiltrative the tumor is. You see, this is the cellular part which has been removed, and this is the part supracellular prefrontal, the optic chiasma. And this tumor is badly adherent. It was also adherent to the chiasma and very infiltrative to the dura anteriorly. Retrospectively, I feel that I should have attempted to remove more of the dura. I could remove the tumor completely, but I left this dura. And though she had a good remission for 2-3 years, but the cortisol level dropped and it remained at a lower level for 3 years. And then she lost from 230 to 160 kg weight, but then there was a recurrence and she received gamma knife, but still she has not remitted even after gamma knife. So pseudo capsule, I think this was also discussed by Ed Laws, surgical margin or infiltrated. There's a controversy about it because like this article by same Oldfield and the group, they say that, they have used the pseudo capsule as a marker to dissect, as a surgical margin to dissect extra capsule with the tumor, and say that it has been helpful in removing the tumor completely, but they have not mentioned about infiltration. Similarly, our Ari Chako and Geeta from Vellore, they have also published an article in 2003. They have histopathologically studied the part of the pituitary which was close to the tumor or excised with the tumor, and they found no infiltration. It was a normal pituitary gland. However, as Professor Ed Laws said, that there is a definite infiltration in the surrounding adenoma. And this article from Korea, they excised the pseudo capsule, and they found in 43% of cases there were tumor cells in the adenoma, in the capsule, pseudo capsule, what we call. And this again from Japan, 2019. They call it peel-off resection of pituitary gland for functional pituitary adenomas, pathological significance. Now, what he says that most often there is a good capsule. In large tumors, there is a good pseudo capsule and there is no infiltration. But in small tumors, or sometimes you don't find a proper continuous pseudo capsule, there's a very likelihood that the tumor has infiltrated, and they peel off a layer of adenoma, which is a pseudo capsule like this. And they have studied that, and they have found there nests of adenoma in them. And they found that this small resection of the capsule doesn't cause any hormonal dysfunction. So combining all together, it seems that pseudocapsule is intact in large adenoma, because reticulin is compressed in large tumors, and it forms a kind of a good barrier in a relatively large tumors. This compressed reticulin barrier, the pseudocapsule, is a safe margin for doing an extracapsular dissection, as we saw in many of the videos. However, in small adenomas, often the pseudocapsule is absent or incomplete, and an adenoma may seed across the pseudocapsule into the capsule or into the normal pituitary gland. And if possible, in these small tumors, one may excise a small strip of tissue to complete and avoid a recurrence in these tumors. So I think that is a valid option. But however, as emphasized by all the speakers, it is very important in these functional tumors to go extracapsular wherever is possible, so that small micro remnants are not left behind and the excision is total. Now, multifocal adenoma is not common, but one has to keep in mind that it can be there. And this was the first paper which published 2 adenomas secreting ACTH. And in one hour case which operated in Sanjay Gandhi, earlier was operated in another center for this adenoma in 2001. Though retrospectively, there are some shadows we can see here, but she was in remission for 2 years and then she had a recurrence. And when we repeated the MRI, there was a local recurrence, and we could see some shadows here just behind the carotid artery. And this was still, I was not fully into endoscopic surgery, so we are doing microsurgery. So this tumor was, and you can see that it is just behind the carotid artery. Very good for endoscopic surgery, but very, very difficult for microsurgery. So this was under dynamic scan, confirms that there is a bilateral adenoma. And this is post-op. You can see the fats in both the sides. And this is microsurgical video, old one. So this side we have removed the adenoma, and this side we are under the microscope, we are removing. You can see the adenoma popping out on the lateral wall of the pituitary gland, adherent there. So we could excise that. And then this is a blind spot right behind the carotid. Today I will be horrified to do this, but that time I tried to scrape out because I knew there were 2 things. And then finally you see how badly adherent this adenoma is to the dura of lateral wall of the cavernous sinus. So luckily in this case we could excise, and this patient is doing well, and I think she's migrated to USA, and her daughter, that's what I last know. And also in the Oldfield article, he also says that if you follow the pseudocapsule, sometimes you can find other tumors also, like in this small tumor behind the normal tumor, which was not seen in the MRI. Now, it is important to do a sector-wise search in the rest of the pituitary adenoma, even if you see the adenoma in a particular area. And just an example that this, we have seen a central Cushing's adenoma in this patient, but while doing a search on both sides, we found certain abnormal tissue on the right side. And the central tumor, of course, was this is an HE stain where shows a loss of Essender pattern and a typical of adenoma. In the lateral specimen, there is on low field, it looks normal, but if you high field, you see there is a loss of Essender pattern. And even higher field, you can see there is a adenoma here. So sometimes you can get these tumors, and this lady did well, high field you can see, and did well. Last follow-up about 7 years, she's doing well. Another tumor, pretty large Cushing's tumor with a compressed gland. And so just to emphasize that, of course, we couldn't do extracapsular, it's very, very soft tumor. So after decompressing the tumor, I could see the very good capsule, pseudocapsule of the adenoma. But as routinely, whenever I got good tissue of pituitary, I make small slits in them with a knife and just explore them with some resections. I will just go fast. So make small vertical or horizontal incisions in different areas like this. Though the MRI doesn't show anything, but as a routine, I do, if possible, small slits. And then with a probe or some dissector, we try to explore. If we find something abnormal tissue, we take it out. And as you see in this patient, you see there's a small tumor, maybe, I don't know, it's 1 millimeter or what, but I could see some abnormal tissue coming out, and we biopsied it later, and it was also positive for ACTH. So sometimes it's a good idea to explore the rest of the pituitary. This again, sometimes you don't know, this adenoma, Cushing's, this side operated, didn't remit, then given a gamma knife, didn't remit, then the total hypophysectomy, didn't remit. So we don't know is some central functioning, and she died of septicemia because of ulceration of the gut. So I will skip this. And we had a small publication from Sanjay Gandhi group with endocrinologists there. We had 12 pediatric tumors. And you see in the initial phase, there was a remission in 8 out of the 12. But subsequently, many of them recurred over 5 to 8 years. A very good follow-up by our endocrinologists in the hospital. And finally, whatever follow-up they have, 5 of them possibly are in remission, and 7 of them had a recurrence. So pediatric tumors are a little difficult. In adult, this is a little old slide, about 79 cases. We have only 48 months of follow-up, 4 years. Initial relapse was about late relapse was about 8%, and then over remission after resurgery and some of the radiation was about 75%. So long-term follow-up is very, very important. 4 years is not very, very important. We have to go to 5, 10 years. So keeping in mind, it's the disease and not often a focal tumor in the background. Of course, we need a very good endocrinological radiologist and oncological team to manage as a combined team. And very important to look for any abnormal tissue within the tumor, within the adenoma, within the pituitary gland, or around it in the surroundings, and excise any tissue and give it for biopsy. And microadenoma, small strip of normal gland, may help in giving a good remission. And if feasible, of course, not in my experience, but medial cable wall, as has been explained, may be the option in future to give a good remission. And of course, emphasizing long follow-up. Thank you.
May I request Dr. Prevedelu to please introduce our next speaker?
Yeah, it's a great pleasure for me to introduce Jim. We know each other for a long time, and been learning from all his experiences is amazing. We have a very similar practice. when I call Jim, late at night, he's running several rooms, and big scope is here, another pituitary there, and it's very similar to what we do here. So it's a great pleasure to introduce Jim. He's a professor of neurological surgery and otolaryngology at Jefferson University and director of the Cranial-Based Pituitary Center, director of the fellowship, and chief of brain tumor division. So please, Jim, share with us your presentation. Thank you.
Thanks, Dave. Thanks so much for the nice introduction. It's nice to see everybody today. Can you see my slides okay? Can you hear me okay?
Yes, we can.
Okay, thanks so much. I'd like to thank Dr. Pujari and the scientific committee for inviting me to participate today as well, and also to congratulate you on a really great symposium. I've enjoyed it. I've learned a lot today myself, and I'd like to thank you for all your efforts in putting it together. Although my title on the syllabus said about all functional tumors, I'm going to really focus on the management of recurrent Cushing's disease. And by way of that, I'd like to just make a few comments on primary Cushing's disease. Some of this will be a bit redundant, but I think sometimes repetition is not always bad. This is our university, this is our center. And just a few comments on Cushing's disease. You know, the more I do this, the more I realize how really difficult this can be. And the accurate diagnosis can be exceptionally challenging. And we've heard that today. But the early detection is critical. You know, there's such high morbidity and mortality with this disease. The 5-year cardiovascular mortality is approximately 50% or better. And so I think that this identification and early identification is really critical. And surgery, as we know, is the first line in therapy. And fortunately, most of these are microadenomas. And this is just my artist rendition of looking in the sphenoid sinus and looking at the sella and making this opening in the dura. And one of the things I think we have to be very cognizant about is very careful opening of the dura, inspecting the dura. As Ed Laws mentioned a few minutes ago in his series of some 460 some odd patients, sometimes we'll have invasion of the dura in these cases. And we need to very carefully recognize that, and also to perform a careful dissection of the gland before we start to open or invade or investigate the gland. And as we heard earlier about from Ed Law's work, that we try to take advantage of this pseudocapsule and perform an extra capsular dissection. Now, it doesn't always have a perfect capsule. Some are soft, as you've seen, and some have a well-formed capsule. But whenever we can capitalize on that, at least largely, we want to try to stay extracapsular and try to get this sort of an en bloc resection. There are times when we need to take a small margin of gland as well. We need to recognize that, because as you've just seen from Dr. Benjari, sometimes we will have invasion even beyond the pseudocapsule. So I think a small rim of gland, when it's feasible, is important. And this is just an example of that sort of pseudocapsular dissection that sometimes is done in a very sharp way and sometimes can be capitalized in a blunt dissection. But the idea to try to respect this capsule as much as possible, try to maintain it, and try to achieve a good en bloc resection. Now, the surgical approach, I didn't put a lot of videos in just in the interest of time, but one of the things that's very important is not just to be minimally invasive. That's a term that's thrown around a lot with endoscopic and this sort of discussions of endoscopic versus microscopic, et cetera. But I think the concept of being minimally destructive, it's extremely important. It's important of all of our pituitary patients, but specifically in Cushing's patients. And these patients, as we know, don't heal well. And even when they go into remission, there can be months before they're back toward a more normal function. And it's really important to be delicate with the sinonasal cavity. And we try to preserve terminates in all cases, not just Cushing's, but in all cases, unless they're involved with a pathology. Very limited posterior septectomy. I'll often utilize a unilateral, a uninary approach when it's feasible. I think that can reduce the morbidity in the nose by 50%, but you don't want to use this if it's going to limit your resection. It's very easy to quickly open up the other side and kind of work in a binaural way, but I think it's wise to be mindful of working on one side versus both sides. I think, Danny, you mentioned using a 45-degree scope, utilizing all of our scopes. I really enjoy using the 45-degree scope to look out into the cavernous sinus for resection of the medial wall or to venture into the cavernous sinus, certainly from the medial approach. We don't fix the head, and we don't use a rigid scope holder. We really like this technique of a dynamic two-surgeon operation, as you can see in the picture there. This is something I think that's not talked about enough. Approaches are very important, but so is our repair technique. These are often microadenomas, and I feel that they don't often require very extensive repair. You see all sorts of layers and packing and fat, etc. We don't use a lumbar drain universally. In Cushing's, I think it's important to not use fat, and I don't use it in any case, but particularly Cushing's, where we can avoid an additional incision, and we can reduce the potential for infection, both at the site of harvest or at the site where you put the fat. No packing, I think, leads to less crusting and less obstruction and less scarring. I mean, we want to try to achieve remission in the first operation, but certainly I think a reoperation is easier if we've respected the anatomy and been very careful to be minimally destructive and created less scarring. This is a paper we published a year or two ago, but just utilizing this sheet or two of Surgicel to do repair. In microadenomas and those without a CSF leak, this is actually very effective. It works well, it mucosalizes very rapidly, there's minimal crusting. We've studied this post-op outcomes and also our post-op videos quite carefully. Now, this is for patients this is a different paper we published a year or so later, but for patients that have a patulous diaphragm, it may herniate down from a larger tumor, or those that have a CSF leak, we'll use an inlay collagen dural substitute and then put some biological glue on top of that. And this is sort of what that would look like in surgery without, fat packing or lumbar drain, et cetera. And this can heal very well and with minimal postoperative CSF leak. We heard earlier from Dr. Falbush that exploring the pituitary gland, certainly for non-lesional cases, we need to have some methodical way to enter the gland. I'm not sure that I would do it on every case, as Dr. Benjari suggested, the potential to look through the gland even when there's a clear micro, but certainly we need this ability, and there are times when it's critical. Starting with this midline, where we know the cells are typically located in the center of the gland, the ACTH cells, and so we typically start on the midline, but we need to sometimes explore the hemispheres and also to have a horizontal incision. So we need to have some methodical way to work through the gland in a non-lesional case. And this kind of concept of identifying the microadenoma and still trying to achieve that extracapsular resection. We know with Cushing's disease that surgery is the first line in therapy. We've heard that just previously. And initial surgery can have these degree of remission rates, but recognizing there's a dichotomy between microadenoma and macroadenoma, I think in all of our hands. And it's held true with microscopic or endoscopic surgery. And this sort of mean time to recurrence can be quite extensive, as we heard earlier from Dr. Gentili, et cetera. Early post-op remission, we get into the definitions of these things, this normalized 24-hour UFC, and we utilize serum cortisol, the various levels of serum cortisol to predict remission or favor remission, et cetera. Certainly, it's really important, and I think Ed Laws pointed this out, or others as well earlier, that this concept of post-operative adrenal insufficiency is an excellent sign of remission, early on after surgery. So we have to watch for this as well, and this sort of quote-unquote crash is very important. But if you look at the Endocrine Society guidelines, there really is no clear consensus for the criteria of remission. This is right from the guidelines that it's sort of generally defined as the things we were outlining with looking at the post-op cortisol levels and the UFC, 24-hour UFC, but that's sort of a general definition. We have to also consider this concept of whether it's persistence or recurrence. With persistence and patients who don't quite reach recurrence postoperatively, we need to really consider this early repeat surgery prior to onset of scarring, also while the anatomy is fresh in the surgeon's mind. The remission rates can still be about 50% or greater when you don't reach remission from your original resection. So going back in that early period of a couple of days, a couple of weeks, or even a couple of months. Recurrence, however, remission rate in the 64%. We'll talk a little bit more about that as we go along. We know that there's a high risk of recurrence and substantial morbidity from Cushing's disease. So these patients certainly require very long-term follow-up. Recurrence is most likely in the first 5 years, but not uniformly. You'll see these rates within the first 3 years, within the first 10 years, but we've seen late recurrence reported in many years after surgery. So we need to continually follow our patients. Some risk factors, many of these things seem like sort of common sense in a way, macroadenomas and MRI negative, et cetera. But statistically, when you look across all the papers, they haven't all panned out. Certainly patients with higher hormone levels. I think surgeon experience plays a big role. We all recognize that. And then absolutely, we've heard again and again from these past lectures that cavernous sinus involvement is a very important risk factor for recurrence. We look at predictors of recurrence. There's been some studies with various tests to try to predict recurrence. And we see that Danny doing a good job looking at levels intraoperatively, but still the diagnostic accuracy of these just has not been high enough to be useful. Salivary cortisol is very sensitive. Sometimes these can be one of the earliest biochemical findings for recurrence. So remember to check the salivaries. This concept of remission, early recovery of the HV axis, some say within 6 months or so, can be indicative of recurrence of Cushing's disease. So pay attention to this as well. Sometimes our patients take 1 and 2 years to recover, and that's probably a better sign. So before we decide to delve into repeat surgery or secondary treatments, we need to have a thorough workup. Again, I'm always or often humbled in the initial diagnosis of Cushing's, as well as with how we define recurrence. Look at the high resolution MRI scan. Many times we can see evidence. We need to evaluate for evidence of maybe dural involvement or diaphragm involvement, certainly cavernous sinus. Scrutinize this on the imaging as much as possible. IPSS, we heard a little bit about earlier, is really not useful for recurrence. It's the anatomy's been affected, and it's very unpredictable as far as lateralization. So treatment options for recurrent Cushing's, our list is repeat surgery, certainly medication treatment. We're going to hear more about that. Stereotactic radiation and bilateral adrenalectomy. So the problem with repeat surgery for recurrent Cushing's, as far as the data, is that there's very few studies that have a large series of patients. The remission rates are quite broad across the various studies. And some of the problems, I think, are that there's variable experience from the surgeons or centers, the timing of surgery, again, this concept of persistent or recurrent disease. Definitions, how we define recurrence. It's very broad across various centers. Surgical techniques, we've this concept of endoscopic and microscopic, and then the sort of technique of resection. Are you trying to perform adenectomy? Are you going to go for some form of a hypophysectomy, total or subtotal hypophysectomy? And I think there's so much variability. That's the difficulty we're having. This definition of recurrence, we roughly, I think, agree upon this 24-hour UFC as well as our AM cortisol of over 5 with our metrics. Recurrence rate following repeat surgery is, again, broad. This is some data from Ed Law's paper from 2019, and I'll show some more in a few minutes. And this mean time to recurrence, we have to keep following our patients long-term as we discussed. This idea of scrutinizing your MRI, looking for residual tumor, and again, up to 50% of patients or so can have evidence of tumor on a repeat MRI. So don't neglect that just because you have operated and there's some scarring from the prior procedure. We need to have a good surgical strategy. I think a good plan is to return to the original site. Certainly if we rely on our pathology, et cetera, if you've got positive pathology, or if you've had a patient go into some degree of remission and then have recurrence, returning to the original site, I think, is a good bet, at least in part. We need to check the margins. We may have to take a wider margin of the neural pituitary gland. And then we've got to scrutinize the dura, diaphragm, and even cavernous sinus, as we've discussed. And we need to consider the concept of hemihypophysectomy. We don't need to jump right to this, but I think this does play a role. And this is just an example, a cartoon example, and just a brief video example of a hemihypophysectomy with resection of this left hemisphere of the gland in a recurrent patient. I mentioned Ed Law's paper, which is excellent, from 2019, looking at his early cohort and late cohort, just a fantastic and huge experience. The immediate post-op remission in his series was in the order of 86%. But if you look at the longer term remission, patients that were followed at least a year and looking at them out to 3 years, it kind of falls back to the 60 some odd percent that we've seen. If a patient's not a candidate for surgery for whatever reason, medication certainly can be utilized to improve patients for surgery that are quite advanced or for long-term management. We have radiation and bilateral adrenalectomy. Medication treatment, long-term, it's indicated for long-term treatment failure after surgery or radiation for patients that may not be candidates for surgery for a number of reasons. For emergency treatment, patients that are just very advanced, have severe life-threatening hypercortisolemia when they present, and pre-op, before surgery, to try to reduce perioperative morbidity. We're going to hear about this in the next speaker, but just very briefly to categorize these three types of medical treatment: those that are directed at the pituitary to diminish or decrease ACTH. There's a few agents, but pasireotide and cabergoline certainly on that list. There are 4 or more different steroidogenesis inhibitors, certainly ketoconazole and metirapone, and then glucocorticoid receptor blockade with mifepristone or Korlym can be very valuable to reduce hyperglycemia and to try to control hypertension. And these can be used in combination, as you know. Stereotactic radiation, there's a host of different devices. Gamma knife, linear accelerator with both stereotactic radiosurgery and fractionated treatments, cyberknife, proton beam, etc. A lot of the literature is drawn from gamma knife experience. There is some discussion about whether you need to treat the entire gland versus just the resection site. Some of the outcomes have shown improved remission treating the entire gland without a huge increase in endocrinopathy. And certainly paying attention to the cavernous sinus. If we're suspicious there's involvement or we know there's involvement of the cavernous sinus. Some of the risks, absolutely endocrinopathy, optic neuropathy, and the potential for cranial nerve palsies when we're giving high doses of radiation into the cavernous sinus. With stereotactic radiation, again, drawn from the gamma knife literature, Jason Sheehan and the Gamma Knife Consortium is where a lot of this data comes from, or some of the more robust data. Remission rates in the order of 70%, but the issue is a mean time to remission of up to 16 months or sometimes longer. This really begins to approximate what we can accomplish with surgery. But again, we've got this delayed time to remission. We look at doses of 20 to 25 gray. One thing to keep in mind is whether the patients are on or off ketoconazole. The mechanism is debated a bit, but when patients are on ketoconazole at the time of stereotactic radiation, their time to remission is significantly longer than when they've been taken off ketoconazole. There are recurrences after remission from radiation in the order of 15%, and then new endocrinopathy in about a third of the patients can be expected. Lastly, bilateral adrenalectomy. This is often done laparoscopically today. This is really indicated after failure of the other modalities, repeat surgery, radiation, medical therapy, etc. It's considered always curative when you can achieve a complete bilateral adrenalectomy. But there are some significant side effects. Certainly, their patients are going to have chronic adrenal insufficiency, and there are a number of them that can have adrenal crisis. And I've seen this in my patients that, for whatever reason, don't get their steroid or for some reason get injured, et cetera, and don't receive adequate steroids. This can be very dangerous. Nelson syndrome with hypertrophy in up to a quarter of the patients sometimes needs to be treated with surgery, stereotactic radiation, and even cabergoline, as you know. And mortality can be pretty high. It's not trivial. Up to 10% of patients or so can suffer stroke and MI and sepsis, et cetera, after bilateral adrenalectomy. So we don't take that lightly. But thank you very much for allowing me to present today. It's been a pleasure being part of this group and included with a really esteemed group of speakers. And I look forward to the remainder of the presentations. Thank you.
Thanks, Jim, for a very nice talk. And I'm sure you will stay for the discussion because there will be some questions, I'm sure. And it's my pleasure now to introduce Mary Coldwell. She's an endocrinologist mainly interested in pituitary and thyroid diseases, working in West Valley and Salt Lake City. So Mary is going to talk to us about newer aspects of the medical management. Mary, please.
Okay. Thank you for inviting me to speak. I will discuss the current medical therapies of Cushing's disease. I will discuss the current medical therapies of Cushing's disease. I'd like to acknowledge Dr. Rosario Pivonello for his recent overview on the current and recent clinical trials. It was published in December 2020, and on which I tried to base this talk. Current medical therapies demonstrate only partial responses. There's no single drug that has provided complete efficacy and safety, and hopefully newer drugs will help improve those parameters. Targets for therapy include the pituitary corticotrophs, the adrenal glands, and the glucocorticoid receptors. Pituitary-directed therapies include pasireotide, subcutaneous, and long-acting. The one thing to remember is the effect of hyperglycemia, which occurs in about over 90% of patients, and frank diabetes mellitus occurs in 50% of patients. It's the only pituitary-directed drug that's officially licensed in Europe and in the US. And as you know, it inhibits the abundant somatostatin receptors, type 2 and type 5, that are found on the corticotroph tumor cells. There's a phase 3 clinical trial of 12 months duration, where there was a group of non-responders in this subgroup who did not respond in the first 2 months, with no decrease in the mean urinary cortisol. Greater than 90% of those patients remained uncontrolled at 12 months. Therefore, prolongation of therapy is probably not indicated in those patients. An extension study at 60 months showed a median decrease in mean urine cortisol of 83% at 12 months and 82% at 60 months. So we see a steady state. And in fact, 73% of patients remained stably controlled after 12 months. With regards to tumor shrinkage in a phase 3 clinical trial, the higher doses were more effective, both at 6 months and 12 months on the 1,800 microgram sub-Q dose, going from 26 to 43% at 12 months. Of note is that in the LR form of pasireotide, there is greater than 20% shrinkage in tumor at 12 months, which was very similar to the sub-Q dosage with the 10 milligram dose. And by increasing to 30 milligrams, there was further shrinkage of tumor. Therefore, the recommendations are to consider long-term treatment in those who are responsive after 2 months, and preferably patients without severe or uncontrolled diabetes. Monitoring glucose profile in these patients is mandatory. A second drug called roscovitin is newer. It's currently under investigation and there's no data in humans, although it's been used as an oral anti-cancer agent for many decades, including in the treatment of gliomas and neuroblastomas. It's an inhibitor of the cyclin-dependent kinases, and we know that cyclin E is overexpressed in corticotroph cells. Therefore, roscovitin seems to block cell proliferation in these cells. What we do have are studies on cell cultures, and it's been shown that 62%, that the levels of ACTH decreased by 62%. In 5 of 6 cultures that were studied. Studies in athymic nude mice who were injected with the corticotroph tumor cells and developed tumors showed that after 3 weeks, there was a 50% reduction in tumor mass, which is quite promising, alongside a decrease in both ACTH and corticosterone. Trials in humans, first and second phase 2 clinical trials, are yet to be published with regards to the first trial, which ended in October of 2018 and looked at 7 patients with Cushing's disease. There's a second trial that's currently open and to terminate in November of 2022 that is pending. Our second target is the adrenals. Levoketoconazole seems to be more efficient than ketoconazole and has less side effects. Metirapone, we've all known about, and osilodrostat is a newer drug. Metirapone is the only officially indicated for Cushing's disease in Europe and not in the US. Ketoconazole has been used off-label for the past 30 years. And there are 3 new drugs, levoketoconazole, osilodrostat, and ATR-101, which was shown to be adrenolitic in dogs, was given a clinical trial which was closed due to lack of participation. Ketoconazole, as you know, is a 50-50 racemic mixture of both the levo and the dextro ketoconazole. It blocks multiple stereogenic enzymes along the pathways and therefore decreases production of all hormones, glucocorticoids, mineralocorticoids, and androgens produced both in the adrenal and the gonads. This drug also inhibits liver enzymes that are involved in the metabolism of chemical substances, therefore causing liver damage. In a meta-analysis on ketoconazole, the average remission rate was 71%. It was quick at decreasing urinary cortisol in the first weeks of treatments. There was an 11% treatment escape, however. And as we know, there's no effect on pituitary tumor size. Adverse effects are the limiting factors, hepatotoxicity in up to 15% of patients, gynecomastia, and adrenal insufficiency. Newer agents such as levoketoconazole and acylodrostat are more selective in blocking enzymes along the stereogenic pathway. So they block aldosterone production, they block cortisol production, but they leave open the pathway to produce testosterone, which helps men. The phase 1 study in humans has compared levoketoconazole to the dextroketoconazole, and it showed a higher affinity for the adrenal enzymes and a lower potency towards liver enzyme inhibition. It's given twice a day, and it also has a very rapid action. A phase 3 multi-center clinical trial of 6 months duration showed a 78% response rate, in which case 30% of patients normalized their urine-free cortisols, and 40% had a more than 50% decrease in mean urinary cortisol. The effect on the pituitary tumor was not evaluated. And then in this trial, the adverse events are nausea, headaches, peripheral edema, hypertension, and QT prolongation in 5% of patients. There's also an increase in liver enzyme in a small portion of patients, which was milder than with ketoconazole. And there is a second phase 3 trial, which was completed in August of 2020, and the results are still pending. Acylodrostat, again, is specific to the distal part of the pathway, inhibiting aldosterone and cortisol and leaving intact testosterone production. You have to bear in mind that once you shut down cortisol, ACTH will rise and stimulate the cortex of the adrenal, thus pushing synthesis down the androgen pathway, which is open and has no enzymatic blocks. So you can have increase in androgen production, which is not beneficial to women. Acylodrostat was officially licensed in Europe in January of 2020 and licensed in the US in March of 2020. It's a more potent inhibitor of cortisol production than ketoconazole and meteropone. It is used in different dosages with updose of titration every 2 weeks until you reach a normal urine cortisol. Maximum dose is 60 milligrams a day. Before treatment, it's important to correct hypokalemia, correct hypomagnesemia, and do a baseline EKG because there is a prolongation of the QT interval in these patients. Within 1 week, we need to monitor for hypocortisolism, which occurs very rapidly, and periodic monitoring of all these parameters. So in the phase 2 clinical trials with acylodrostat, at 4 weeks, there was already a notable decrease in urine cortisol. By 10 weeks, 89.5% response rate was noted, of which 84% of patients had normalized urine cortisol. And the good news is that 75% of patients who normalized urine cortisol did it on a dose of less than 20 milligrams a day. This medication obviously increases plasma ACTH. It did lower blood pressure in 67% of patients with Cushing's disease, and it increased plasma testosterone in 75% of women who had normal baseline levels. Adverse effects, which are noted at 10 weeks include fatigue, nausea, headaches, hypokalemia, muscle spasm, and all these may be related to decrease in cortisol levels in the patients. Frank adrenal insufficiency was noted in 33% of patients. So there is a cortisol withdrawal syndrome in addition to frank adrenal insufficiency. At 48 weeks, 11% of women had hirsutism and acne, and QT prolongation was noted in 3.6% of patients. In the phase 3 clinical trial, 66% of patients had a baseline MRI that showed a tumor, and a repeat MRI was done at 24 weeks. Now, the concerning event here is that 30% of patients out of 66 had a more than 20% increase in tumor volume. And to push that study out to 48 weeks, 37% of the 64 patients, so 24 of 64 patients, also had a greater than 20% increase in tumor volume. There's a second phase 3 study of 48 weeks duration that closed in January of 2021, and thus we are awaiting the results of that study. In summary, it's an effective medication, it's potent, it has rapid action, it has a fairly good safety profile. There's frequent adrenal insufficiency requiring titration of dosage, and we need more monitoring on tumor growth. The third target for therapy is the glucocorticoid receptor antagonist. Mifepristone is well known already, and it's been used off-label since 1985 for ectopic severe Cushing's syndrome. It's been approved by the FDA since 2012 for the treatment of Cushing's syndrome patients who have type 2 diabetes mellitus or glucose intolerance and have failed surgery or are not candidates for surgery. It has not yet been approved in Europe. So mifepristone is a non-selective glucocorticoid antagonist. It binds the glucocorticoid receptor, and therefore it increases serum cortisol because cortisol has nowhere to go now. So it accumulates in the blood, and it will, at high doses, bind the mineralocorticoid receptor, and therefore causing increase in blood pressure, increased potassium excretion, increased sodium retention with water retention, leading to hypertension, hypokalemia, and edema. There will be, due to the binding of the glucocorticoid receptor on the pituitary, an increase in ACTH in 2/3 of patients. It also binds the progestin receptor, thus has an anti-progestational effect, causing endometrial thickening and abnormal vaginal bleeding in women. Clinical management with mifepristone, it's a very long-acting medication, up to 90 hours. Therefore, it's important to discontinue the medications 2 to 4 weeks before doing pituitary or adrenal surgery, or even if you want to reassess Cushing's disease in that patient. 2 milligrams of dexamethasone overcomes the effect of 300 milligrams of mifepristone. The dosing, the average effective dose is 600 milligrams, and you can start at 300. Prior to therapy, it's important to start spironolactone and adjust serum potassium levels to high normal in order to prevent hypokalemia and peripheral edema to develop in patients during treatment. This drug is also teratogenic. Pregnancy test is required in women and to be avoided in women seeking pregnancy. And during therapy, there will be increase in ACTH and DHEA, which will be proportional to the response to treatment clinically. There is a seismic multi-center study that was done in 50 patients with Cushing's syndrome, of which 43 had Cushing's disease. It lasted 24 weeks. Clinical improvement was significant in 87% of patients. Improved glucose metabolism occurred in 60%. And in their extension study, 80% of patients had a 10% weight loss. So it is pretty dramatic with respect to clinical impact. Pituitary MRI showed no significant changes. So the adverse effects are those related to the binding of all that free cortisol to the mineralocorticoid receptor, causing hypokalemia, edema, hypertension. And obviously in women, it does cause endometrial thickening in 35%, abnormal uterine bleeding in 14%, and requiring curettage in these patients in 9% of patients. In summary, it's effective, it's rapid in action, it improves glucose metabolism, it's preferred in men for obvious reasons, and I would be careful in patients with Cushing's disease who have severe hypokalemia and severe hypotension because they could worsen. A second glucocorticoid receptor antagonist is relacorilant. Relacorilant is a novel oral glucocorticoid receptor that has selective glucocorticoid receptor activity. It has no significant affinity for the progestin receptor. It's effective in controlling hypertension and glucose metabolism impairment. It has a good safety profile. Its half-life is shorter than that of mifepristone at 11 to 19 hours, and its adverse effects are mostly GI. In a phase 2 multi-center clinical trial of 4 weeks duration, which ended in September of 2018 and involved 35 patients with Cushing's syndrome and 28 of whom had Cushing's disease, we note that the higher doses have a greater effect on control of blood pressure, glucose levels up to 50%, and a lowering in body weight up to 60% of patients. So again, it's very effective as well as if we compare it to mifepristone. And it improves depression, neurocognitive function, and quality of life. There is a phase 3 multi-center trial, which will be completed in November of 2021 and will incorporate 130 patients. Thank you for your time.
Ajay Sinha. May I request Professor Devpujari to introduce our next speaker?
Ajay is a neurosurgeon of Indian origin, but currently working in United Kingdom. He's a consultant neurosurgeon in Liverpool and has mainly interest in pituitary surgery and pediatric, and therefore he is going to talk to us on endocrine outcomes in pediatric pituitary tumors. Ajay, please.
Thank you. Thank you. Thank you to Professor Chandrasekhar for your kind words. Sorry for, let me just get my screen up. At the outset, I would like to thank the organizers and you in particular for inviting me for this very good symposium. Thoroughly enjoyed it for the whole day. And I don't think I missed a single talk today. I've been pretty much parked on my chair since morning. And also the World Congress Federation, who has been finally supported this endeavor. So I'm a neurosurgeon. I've been asked to talk on the pediatric endocrine outcome, which is slightly off my traditional area of expertise. I mean, so I had to fall back on my very competent and very cooperative team of pediatric endocrinologists, Professor Blair, Mo Didi, and the rest, who have been very, very keen to help me out. And some of these patients do get transitioned across to the adult side, and the treatment doesn't stop once the children stop becoming young adults. It carries on the adult side, as has been highlighted very well in the number of presentations, that the key to pituitary tumors is long-term follow-up. And we have a follow-up going all the way from the early 70s in some of our patients who have become fathers, children to fathers, to grandfathers and great-grandparents over this period of time. And it's nice to see if some of these patients being treated as children in the early 70s still coming for their follow-up as grown-up adults. But end result is when I look through the literature, there is very little specific literature on pediatric. Most of them are footnotes of major surgical series. And there are very few specific dedicated papers on pediatric pituitary tumors and the long-term follow-up and their course of. And what we try to do is look at we have over a period of time looked at the surgical and the overall management of these cases. But today I'll try and stick to the endocrine aspects of these cases. As you know, there are less than 3% of all pediatric brain tumors, 3 to 9% of pediatric adenomas. And we have, for some strange reasons, the functioning tumors seem to be much more prevalent in this age group compared to the non-functioning, which is the most common tumor seen in the adult population. And in the prepubertal, you tend to see more Cushing's. The youngest Cushing I've operated is 3 years and 5 months of age. And we also, in the pubertal group, we tend to see more prolactinomas. For the basis of my presentation today, I have fallen back on 2 of the papers which came out from our firm. One was the paper written by Caroline Steele, who was our senior trainee in endocrinology in 2010, who published this paper looking at pediatric adenomas in children and adolescent adults. And the first part of my talk is predominantly based on this particular paper, which was published in European Journal of Endocrinology in 2010. And some of this paper was a paper looking at the pediatrics as well as young adults up to the age of 21. And this was the largest reviews of children with pituitary tumors. And what we found in our series at that point in time was 2/3 of them were prolactinomas. And despite the fact that most prolactinomas do end up requiring the medical management, there was a small percentage also required surgery. And long-term, there was an increased risk of cardiovascular problems, obesity, hyperlipidemia, infertility, to name a few. And the need for long-term follow-up was emphasized in this paper. Going through the specifics of this paper, as you can see, there were 41 patients in this group. We had a small subset of Cushing's and only 1 growth hormone secreting, and a very tiny percentage of non-functioning adenomas. The large percentage of patients in this group was prolactinomas, which were and equally split between micro and macro, 15 and 14 in the group. And 2%, as you said, 2 out of this 41 had multiple endocrine neoplasia confirmed on genetic studies. Current age at that point of publication of the paper was 26 years. We had a median follow-up of about, range for, good follow-up on these patients. And we found that the age range from 15 to 26. And what was interesting in this paper was that all these patients had a slightly higher BMI at presentation, but the BMI continued to remain high. At the time of publication of the paper, the BMI was 2.2 in this group, which had gone up from a mean of 1.3 to 2.2. And there were as many as 16 clinically obese patients and 3 morbidly obese patients. And as you can see from the rest of from the chart here, quite a few of them required antihypertensive treatment long-term, which is a bit unusual in pediatric populations. So goes to prove that these are not very benign conditions, and pituitary adenomas are pituitary tumors, as was emphasized by Geeta Chacko in the beginning of the talks today. Cushing's disease, the usual facial features, hirsutism, striae, are well described. I don't need to go into details of that. That has been covered up in great detail during the course of our discussions today. What is very important in children is it has a significant impact on their growth and development, as well as their school performance. And that has to be factored in, because you cannot, the school years cannot be replaced. Unlike adults, their schooling suffers. And as you can see in this particular paper, they tend to be very short in height. The height tend to have short stature and high BMI. And all these children with Cushing's tend to be victims of bullying and harassment in school. So apart from the metabolic effects on their bone and on their cardiovascular system and the rest, they also have impact on their long-term mental growth and development, and hence the need for early detection and treatment. What we also found in our study was that there was a delay in bone age, and most of them had delayed puberty, but they had early development of pubic hairs. As you can see, they have elevated androgens on biochemical analysis. I just go through a couple of cases of our interest. One of the first cases I treated when I joined as a consultant was this 13-year-old chap who had come to us with rapid weight gain. And as you can see that his BMI had shot up from what was considered to be normal to 2, and he had shot in height. And he had, when we came here, he had typical features of Cushing's. His blood pressure was on the higher side for his age, and he also had fasting blood sugar much beyond what is normally expected to be in the normal range. This was his photograph 3 months prior to presentation, and in the span of less than 3 months, he can make out the typical Cushingoid features which he had developed. He underwent a biochemical analysis, and the first thing which stands out is the loss of diurnal cortisol pattern, and raised urinary cortisol, which pretty much confirmed the diagnosis. And with a positive MRI scan, we decided to go ahead and operate on this child, and who was 13 then, largest tumor. We managed to get a complete excision, and this was a post-op scan, and we were quite pleased with our immediate post-op cortisol results. So he was in remission, and as happens with all Cushing's patients, surgery goes well, and we think we got it all out, but nature has its own way of getting back, and so this fellow, within 3 years, came back with a recurrence. And you can see that perhaps in the top corner, in very close to the cavernous sinus, perhaps we missed a small little area, and that had grown up into a tumor, and he had biochemical recurrence. We did offer him surgery again, which he politely declined. He had enough from the very first surgery, so we had to send him for stereotactic radiotherapy, which he completed, and he's currently growth hormone ACTase deficient. He's completed his schooling. He still comes to my follow-up. He's still in remission. We just have to wait and watch. You never know. We don't have much experience with growth hormone secreting tumors in the pediatric group. What I mean by pediatric group is till the age of 17, 16, 17. But I have quite a few in the young adults between 17 and 21, which I have not included in my presentation today, because that will be covered up in another presentation which I'm preparing at the moment. We had one case which was a typical somatotropy adenoma, which got cured with surgery. When we have been following him for a number of years, he still not had recurrence of the tumor. He did not require any radiotherapy. But the biggest group in our series was the prolactinomas. And those of you who may not be familiar with the British celebrity culture, this young lady is Sue Perkins. She's a famous television presenter. She's one of the first to come out in an interview and reveal that she's got a prolactinoma, which may have impact on her fertility. And certainly the whole world was aware of what prolactinoma is, and there were so many queries and questions, and also a lot of positive response from patients who were suffering from this problem. So when a celebrity comes out, it makes the problem become much more widely known. So it was kudos to her that she came out in the public. And as you can see, that typically happens in girls who present with menstrual disturbances. And in our series, we had quite a few of them who did present with either lack of development of menarche or secondary amenorrhea after menstruation cycle had been established. And quite a few of them had deficient or irregular periods, and so on and so forth. But the standard theme in all this group of patients was weight gain and short stature, and that has been the theme across all pediatric pituitary tumors in our practice. As you can make out that some of these tumors were pretty large. 3 of them presented with early visual field defects as well. One of them had apoplexy, which required urgent surgery. I've not done many surgeries on them, but 3 of them required surgery. One had a craniotomy, surprise, surprise, because this was a case which presented with early visual loss, and it was thought to be a craniopharyngioma. As one of my colleagues in those days, this was prior to development of extended approaches. He decided to do a quick frontal craniotomy and remove the cystic component of the tumor, which was perfectly logical. And that's the only craniotomy ever done on a pituitary tumor in the pediatric age group. One patient, she has complete resistance to and intolerance to the medication. So despite surgery, she required radiotherapy to control her levels because the tumor was extending into the cavernous sinus, and we did not go chasing the tumor into the cavernous sinus. Quite a few of them require long-term steroid replacement and a long-term thyroxine replacement. One patient required thyroxine replacement as well, and growth hormone replacement has also been provided in some of these cases. Non-functioning was very low, and once again, apart from the fact that they tend to present with low energy levels, The biggest thing they present to us is the short height. As you can see, Professor Blair is standing next to this fella, and you can make out the height in compared to his dad. So we talk about one case just to highlight what the presentation is like. Any non-functioning adenoma. He came with temporal field loss and no processional light in one eye. So there was no questions asked. He needed urgent surgery. Just to brief look through the hormone profile, you can see that he's already got low IGF levels. So most of these patients who present to us, if you do a detailed dynamic pituitary test, they already, when they present with large pituitary tumors, already have pre-existing growth hormone deficiency, and quite a few of them have gonadotropins missing as well, levels low as well. And this was his initial surgery, and this was the scan done 3 days post-op. I think I was pretty pleased with the extent of tumor removal I could achieve in this case. And then 3 months later, 3 years later, there was a small recurrence, and I think he has also gone for radiotherapy after that. So we here in the UK, there's the general tendency is to offer radiotherapy for recurrences. Most patients would not accept repeat surgery, but of late there has been a slightly greater uptake of redo surgery for recurrent non-functioning tumors. But that has been the standard practice here. You have your best chances the first time. Try and achieve as much as you can. The endocrinologists will follow them up. If there is any recurrence, they tend to prime them more towards radiotherapy rather than offering surgery upfront. But generally, if the pituitary functions are preserved, I tend to offer them surgery, especially if the steroid axis is preserved. But the theme in this presentation, as I would like to highlight, is the body mass index doesn't shift. They still retain their obesity with or without successful treatment. Follow up on that, this is a recent publication which has come out from our firm. This has only been published in 2019, and which once again highlights the fact that obesity is a common theme in pediatric pituitary adenomas. And despite successful treatment, obesity still persists. And this is a paper looking at our own series of just pure pediatric under 16 years patients. And the conclusion of this study was, quite a few of the obesity was the constant theme. 60% of the patient had short stature as presentation, and most presented with high BMI at presentation. And the obesity remained the constant theme despite sexual treatment and despite optimal replacement of their hormonal deficiencies. And the theme of the paper is, adenomas tend to be more resistant to tumor, and they are more likely to recur long term compared to adult population. So I'm just going to summarize my talk. So we are dealing with an unusual case. Most of the tumors in pediatric group tend to be much more aggressive. They tend to have a slightly higher rate of recurrence, but the long-term outcome is still unpredictable. And as it's been the theme across the board, we need multiple experts across both adult and pediatric practices to manage them and achieve an optimal quality of life. With this, I'll end my presentation. Thanks once again. Thanks, Dr. Devpujari and the rest of the team.
Danny, we are running short of time, but I would like you to, some questions and make some comments in the next 5 to 7 minutes so that.
Yeah, excellent. I really, once again, thanks again, Dr. Devpujari, putting this together, and it's fascinating. So just to go quickly to close this session, I would like to ask Dr. Manas Panigrahi, if he could talk to us a little bit about when prolactinomas, like there's always this challenge when there's vision loss, right? So vision loss, large tumor, and you showed like amazing case that you use medication. I do the same, and you hope to see that beautiful response and vision getting better. So what is your threshold? Like when you'd say, you know what, I gotta go back and do surgery on this patient, how many days you wait? How do you work with the vision of the patient? What's your protocol in order to make a safe approach for this patient?
Yeah, thank you. If the patient has come with a sudden visual loss, like with apoplexy, then we offer surgery as a first line of treatment. But they come with a progressive visual loss of a few weeks or few months, then he has a vision where he can manage his day-to-day activities. We have preferred to give medical management.
Yeah, but how many days do you wait, like, to see if the vision is getting better? Like, when do you declare that the treatment is not working and you take these patients to surgery?
Vision 6 weeks.
Okay, that sounds really good. So let's move forward here. I'm gonna have a question to Dr. Evans and Dr. Banerjee. The same question. You both talk about Cushing. So I think for a lot of the young surgeons, one of the main difficulties is how to handle patients that didn't really go into remission right away. So my question, you both mentioned very quickly, could you talk a little bit more on how you manage and what's your protocol for that surgery that you did? You check cortisol, and I don't know how you do, that's what I want to hear. I usually measure every 6 hours, and I can tell that the patient didn't crash, didn't go to below normality. What's your criteria to take this patient back to surgery? Like Jim, you mentioned that you would consider going before forming a scar. Could you elaborate a little more on that?
Yeah, the problem, as you know, Danny, is the definition of all of this, right? It's challenging. You can check it every 6 hours. You can check it daily. I think watching for them to go into an adrenal crisis or go sort of to have that proverbial crash is very important. If that level's not coming down, I think in that first 2 to 3 days, I think you have to consider to go back. You can re-image or you can go back. It's going to depend a bit upon your suspicion from the get-go, right? If the cavernous sinus is involved, if you feel you got a good extra capsular or extra pseudocapsular resection, et cetera. So a lot's going to come down to your gut feeling as well. But if they're not going down, I think it's important to consider to go back. Now, you know what it's like, going back in a delayed way. Things get more and more scarred. It's more and more challenging to operate. Whereas if you go straight back in early on, within a few days or within the first couple of weeks, you've probably got a better chance at opening and getting back to that portion of the gland without not only accessing that area, but not causing damage. So I would tend to go back early. I mean, Dr. Benjari, do you have?
Yeah, so we normally do the study and second or third day, but we have cases, and there's some literature where there's also have been cases where there's a gradual slowing of the levels falling over weeks. So I think it's a good idea to do, and if there is a sizable residual tumor on an MRI, to go quickly. But we have experiences where it has gone, the tumor is not seen, levels were high, but over subsequent weeks it came down. So I mean, it's a plus minus kind of situation, I would say.
Yeah,
just as a comment. Go ahead, Jim.
It just lends into that concept of your suspicion, right? And if you got a complete, extracapsular dissection and en bloc removal, et cetera, and you're seeing some kind of trend like that, or they're inching their way along, then I think it's reasonable to follow them. I would agree. But if your suspicion's high, I think going back early makes more sense.
But my practice is to just send them on steroids home, get them back in a few weeks, do a midnight celebrity study after
and reevaluate. I over the years became less aggressive. It's interesting. I was more aggressive bringing back in those cases, and for several reasons that we don't have time here. Like I became less aggressive, like taking it back. I still do it, but definitely not as frequent as I used to do. So moving forward here, I just have a quick question for Dr. Caldwell, because you mentioned about this medical management, and one of the challenges we have not only for the Cushing's when it's out of control, but also when they have systemic disease. Like I have a few patients that the ACTH is staining or with Cushing's disease where they have like a carcinoma, the disease in the liver, and then you have two problems. You have a patient still with Cushing's disease and the patient now with a disseminated carcinoma. Any particular drug that you use as primary in this situation that comes to mind? Is it Temodar, or is there any other option these days?
I've never encountered such a patient with pituitary carcinoma, so I'd like to defer to Dr. Schroeder, maybe. Telemizumide is recommended.
I tell later, Mary. I talk later about the carcinoma. We run out of time, and then I can present my experience.
Oh,
Okay.
thank you. Yeah.
Yeah, those are very challenging. And just to finalize then, the last question here, Dr. Singh, could you mentioned about radiotherapy, quite more aggressive than normally we would do here in America in pediatric population. We try to really avoid radiation. Like the case you showed, I would definitely take it back to surgery. And so can you talk to us a little bit about like side effects in these children? Do you see after radiation any major issue?
I guess long-term, they're likely to have pituitary deficiency. That's well described. But the general tendency in this country has been not to go in again. I mean, we are trying to buck the trend. We are trying to push more and more towards redo surgery. And that has been the theme in the last few years. But the endocrinologists and the oncologists tend to be much more pushing towards giving early radiotherapy. And when you offer the patient the choice, for redo surgery versus radiotherapy, the general tendency in this country is for the patients to opt for radiotherapy upfront. So it's patient choice at the end of the day.
No.
Yeah,
Amazing.
interesting.
Interesting. Indeed.
Okay, so we'll finalize this session and we'll pass to the next one as we are
Thank
getting
you.
late in India.
Thank you,
Thank
Danny.
you so much.
Thanks, guys. Thank you.
Thank you, Danny, and all the speakers. We move on to the fourth session. I'd like to introduce the chairpersons. Dr. Salman Sharif, who's the head of neurosurgery at Liaquat Medical School in Karachi. Then we have Dr. Suresh Nair, who is a former chairman and professor of the Sri Chitra Tirunal Institute and a very well-known figure in Indian neurosurgical circles. We have Dr. Mahesh Chaudhary, who is a senior consultant at the Bombay Hospital and the SL Raheja Hospital with a special interest in skull-based tumors. And finally, we have Dr. Manmohan Singh, a professor at All India Institute of Medical Sciences at New Delhi. Unfortunately, Dr. Manmohan Singh could not join us right now because of some emergency, and Dr. Salman Sharif had to leave the session.
Salman had to leave for some other commitment.
Yeah, we move to the first speaker, and I would request Dr. Dev Pujari to introduce Dr. Akanksha Sharma, please.
Yeah, thanks. Dr. Akanksha Sharma has joined us. She is working in Santa Monica with Dr. Kelly's team, and she is going to talk to us about the oncological perspective of pituitary tumors. Akanksha, please.
Thank you so much. It's such an honor to be here today. I'm just trying to. Thank you so much for inviting me. I am representing our team here at Pacific Neuroscience Institute and the St. John's Cancer Institute with Dr. Kelly and Dr. Barkadarian, as well as Dr. Kesri. So I will be discussing, as we've just heard, the oncological perspective of pituitary tumors, and it's timely since someone just asked a question about TMDR, which is what I'll be covering in my discussion. I have no disclosures. My goal is going to be to review some of the basics, which we've already discussed, so gloss over it quickly, and discuss our strategy from an oncological and neuro-oncological perspective of risk stratification when we see a patient with pituitary adenoma who presents for an evaluation to us, and review the chemotherapeutic options, including novel and less frequently used options, as well, and I'll briefly touch on craniopharyngiomas. In the US, non-malignant pituitary tumors form about 18% of all non-malignant tumors, according to the most recent numbers, and they account for 10 to 15% of surgically treated primary brain tumors. In the pituitary gland in the cellular region, we have several different types of tumors, and today my talk is going to focus on pituitary adenomas, carcinomas, and craniopharyngioma. As we've heard, it's the most common cellular region tumor, and it's often an incidental finding. In oncological practice, it's important to consider the familial history, if there's a MEN syndrome, or if there's an AIP mutation, which can be familial, which will change the overall perspective and management. Apart from this, about 40% of adenomas will have a GS alpha activating mutation for which we don't yet have a target. When I see a patient who has a pituitary adenoma, there's a number of questions and flowchart that helps me figure out where we'll go next. Often these are deferrals from our neurosurgery colleagues or ENT or ophthalmology. So my first question is the size. Is this a micro or a macro adenoma? Or is it a giant adenoma? That will help me figure out if I need to refer this patient to neurosurgery if they haven't come from there. Is it an active functioning tumor or a non-functioning, non-secreting tumor? And then finally, what are the symptoms? Is there local mass effect, which is evidenced by visual deficits, intracranial pressure, or stalk effect, which can be excess prolactin and low levels of other hormones? If there's local mass effect and symptoms, then my decision becomes easier. I will then refer to neurosurgery, ENT, and recommend surgical intervention. And in this process, our ophthalmology colleagues are very necessary and helpful to be able to get visual field testing, since I've seen several patients who haven't realized the degree of deficits they're having. But if it's not causing local mass effect, then the next step is to see what kind of tumor this might be, which would involve biopsy and pathology. And of course, we've heard of the different types of tumors today already in great detail, but our endocrinology colleagues are very helpful here in medical management at this point. So when do I, as a neuro-oncologist, usually become involved is when endocrinological management has failed and the patient has had surgical management and that too has failed, or they've had repeated recurrences after surgery or after endocrine management. So at that point, both myself as an oncologist and radiation therapy will get involved for recurrent aggressive disease. We've discussed the pituitary adenoma surgery goals in great detail, but from my perspective, my goal is always to save the patient's vision and make sure that they have the best health possible. And so that is our goal with selective tumor removal. We want to eliminate the hypersecretion syndrome and reduce the mass effect. And as much as possible, restore or preserve the pituitary gland function, which can often be disturbed with radiotherapy. And so surgical for surgical treatment for adenomas may be the most effective form of treatment when the tumor is symptomatic or active. We've discussed that the new 2017 guidelines have changed the way that we look at pituitary adenomas, and this has taken away the atypical adenoma category. When I see when adenoma is referred to my clinic, I'm looking to see what the Ki-67 is, which will determine the probability for recurrence, or is this a patient who can just be observed after surgery? And of course, the subtypes of adenomas. Malignant pituitary carcinomas are extremely rare. I've had a few in my early career, just one or two, but they of course have much more rapid tumor growth. They can be very invasive, and they have growth without response to standard medical therapies, which would not include chemotherapy. In our practice here at Pacific Neuroscience, we also send pathology at an early stage for advanced genetic testing, namely KRAS or Tempus, so we can be prepared for the future with any genetic markers. Pituitary carcinomas can be very rare, as we've discussed, and they can be secretory, and they're usually a transformation of adenomas. This is an example by Dr. Zhu et al., where they show a transformation of a typical adenoma to a more aggressive form where there's a higher Ki-67 shown on the right-hand side, and then eventually a pituitary carcinoma, which is evidenced by the high degree of mitotic activity and more clustering of cells. Going on to the chemotherapy options, temozolomide has been discussed in the literature since 2003, and it started off with the single case report, such as, and this is a more recent case report, but then eventually there was more retrospective series and prospective series, but there has not yet been a randomized controlled trial. This is an example from our practice, and Dr. Barkhodarian saw this patient pre-op, and at that point, the patient had already had 2 surgeries and had recurrent disease. He had a surgery with Dr. Barkhodarian, but in 12 months started to have recurrence of disease and was started on temozolomide. Here we can follow the prolactin levels, and we can see that as different interventions, the prolactin levels remained high, including with cabergoline. And then eventually the patient was started on temozolomide at 150 milligrams per meter square and achieved remission of disease and remains disease-free at this point with low prolactin levels. So what is the data for temozolomide? There's a varied numbers in the literature so far, and it can range anywhere from a response rate of 37 to 48%. This includes response from a radiographic and a hormonal level. But if you consider cases where there's disease stability, we would add another 30%. So the response rate can be as high as 80% for atypical adenomas. But I would caution that these cases do relapse. Median duration of response has ranged from 12 to 30 months, and so patients may relapse anytime from 1 to 2 years or even 3 years out. One of the areas of controversy is how long patients should be treated with temozolomide. In the literature, the treatment duration has ranged from 9 to 12 months. And what we've noted is that temozolomide is not without toxicity. It is one of our milder chemotherapies and is used widely in glioma, but it does have fatigue, nausea, headache, weakness, and can be life impairing. In addition, it has a risk of aplastic anemia. In the pituitary population, we haven't yet seen the skin rashes that can occur in the glioma population. They're extremely rare, but they do occur, including Stevens-Johnson syndrome. That has not yet been reported in the pituitary population, but that's also possible that there just are not enough cases. Overall, the 5-year overall survival for pituitary adenomas that are recurrent is 57%, and for pituitary carcinomas is 56%, which is quite encouraging, with a PFS of 22 or 36%. Usually patients are dosed at 150 to 200 milligram per meter square with using the Stoop protocol, which is treatment 5 days out of every 28-day cycle. There are a lot of questions that are still unanswered about Temodar, including the benefit of MGMT. Should we be assessing for MGMT status as we do in gliomas? The preliminary data suggests that we don't think there is that same benefit of MGMT methylation as there is in gliomas, but it's still unclear. And then there's a MSH6 mutation that may be associated with better improvement response. We've also seen that functioning tumors seem to respond better. This is a table by Whitelaw from 2019, which discusses indications for temozolomide treatment. And this is what we follow in our practice here. If we think that there is an anticipated aggression or high Ki67, we might consider starting early, but we would usually have a few months of surveillance before we start. And if we see growth, we will start temozolomide. Usually we MRI our patients every 3 to 6 months after surgery. Now, if there's clear aggression and recurrence, then that's definitely an indication to start temozolomide, or if there's metastatic disease in other areas. And in patients who cannot tolerate other treatments or could not get surgery, for example, an elderly patient with a poor performing status, this might also be a good option. So temozolomide is the most well-known chemotherapy option right now, and the most widely used for recurrent pituitary tumors. There are some experimental treatments that are on the horizon. One of these includes peptide receptor radionuclide therapy or dotatate therapy. This is pretty new and rare, and it's extremely expensive in the United States. The idea is that you're targeting the somatostatin receptors, you're labeling with a radionuclide and allowing for radioactivity right at the target cells. This can be extremely expensive, on the order of several tens of thousands of dollars, and is not well covered by insurance. Currently, it is covered by currently covered for neuroendocrine tumors. And so case reports have been mentioned in pituitary carcinomas and pituitary adenomas. So then what should we do if we have relapse after temozolomide? Again, this is an area of controversy right now. Several practitioners will restart temozolomide therapy. Other options for relapse would include lomustine and 5-FU. Lomustine is also an alkylating agent, and that's the theory behind that. These have just been tried in case reports with moderate success. Other platinums have been tried, including including etoposide and carboplatin. Capecitabine has been tried, and Cytoxan has been tried. There is an argument for anti-VEGF therapy, mainly because of the anti-angiogenic nature of bevacizumab or Lenvima, which is a newer VEGF drug. Usually with bevacizumab, I've personally used 10 milligrams per kilogram every 2 weeks in my practice for recurrent disease that has not responded to Temodar. There are a couple case reports with mTOR inhibition, and mTOR is just a pathway in the cancer route, but there's no specific reason it should work in pituitary tumors. This has not really played out well in larger numbers. Lapatinib and gefitinib are tyrosine kinase inhibitors that have been looked at in case reports and a small series that I'll discuss next. And then, of course, there's a lot of attention on immunotherapy, including PD-1 inhibition. Tyrosine kinase inhibitors such as lapatinib and gefitinib may work if EGFR is overexpressed in pituitary adenomas. And this takes me back to the point I made earlier that in our center, we send these tumors for KRAS testing. So we have a sense of their PD-L1 expression, PD-1 expression, and EGFR expression. There are some recently completed and ongoing trials that we hope will give us more insight in the next couple of years. There's a phase 2 trial that Dr. Lin is conducting at Memorial Sloan Kettering that's looking at nivolumab and ipilimumab in aggressive pituitary tumors. Another phase 2 trial at Weill Cornell by Dr. Majay, which looks at capecitabine and temozolomide in recurrent tumors combination therapy. And then I just mentioned that there's been a phase 2 trial of lapatinib in recurrent disease that Dr. Cooper completed at Cedars-Sinai. This was a very small cohort of 9 patients. The results were just released. Only 1 out of 9 patients had a 50% reduction in prolactin. And these were all, I should mention, recurrent disease with recurrent prolactinomas. 6 out of the 9 had prolactin elevation. The median percent prolactin change was -7%, so not as impressive as one would like. And the tumor volume change was 10%. So the final paper from this study is pending. It's an option, but not a terribly exciting option. The other new therapies on the horizon are medical therapies that we just heard about, more related to the cortisol excretion in these patients. I will briefly turn over to craniopharyngiomas, which arise from the epithelium of the Rathke pouch and can also cause visual and hormonal disturbances. These are driven by clonal mutations, and if there's a BRAF 600E mutation, it's a papillary tumor, and if there's a mutation in the beta-catenin, then it's an adenomatous tumor. Patients present with visual impairment, endocrinopathies, frontal lobe dysfunction, and hypothalamic dysfunction. And these patients are also often referred to our team as neuro-oncologists because there are new options for these tumors. But the primary management is maximal safe resection, and this is also important so we can confirm the subtype. The subtype will have a lot of significance in the type of treatment we may offer. Surgery is not without risks. It can cause CSF leaks and panhypopit. And then usually if there's residual or recurrent disease, radiation is recommended at up to 55.8 gray. At that point, if there is residual disease or recurrence in a few years, there are several options. For adamantinomatous subtype, there is IL-6 that can be targeted with anakinra or tocilizumab. And then for the MEK inhibitors, for the BRAF mutated tumors, MEK inhibitors have been tried with good success, leading to a phase 2 trial that is ongoing currently with vemurafenib and cobimetinib. This is a schema from Dr. Alexandriki last year, which shows, or 2 years ago, which shows where different areas where craniopharyngiomas can be targeted. Trametinib and dabrafenib, which is a combination that's used for melanoma, can target the pathway both at BRAF and ERK1/2. And then bevacizumab remains an option because of anti-angiogenic efficacy. Gefitinib can also be a target at the EGFR receptor. And then finally, cytokines that are released by the adamantinomatous type can be targeted with anakinra, as I mentioned. So there's a lot of exciting treatments on the horizon for both tumor types, and we're very glad to be collaborating with our colleagues in ENT, neurosurgery, radiation oncology, and ophthalmology to be able to provide care for these patients. I'd like to thank the organizers. This has been great, and I've learned a lot, especially Dr. Deopajari and Dr. Shroff, Dr. Dan Kelly, and the surgeons at our group, and my team.
Thank you, Akansha, for a nice overview. It's my pleasure now to invite Alvaro. Professor Cardova is Associate Professor of Neurosurgery in Montevideo, Uruguay, and he's going to talk us about another aspect of confocal endoscopy. Alvaro, please.
Thank you, Chandra. Thank you all for the invitation and a wonderful event in this very difficult time. And I promise to be very brief, because normally it's a very interesting, for me at least, it's very interesting topic. One moment. I am trying to share my presentation now, but I think I have problems now.
Are you able to do it, Alvaro?
I am trying to show my. Yes.
Now we can see your computer screen. Yes, the slides have
Now
come.
Now it's okay?
Yes.
Perfect. Sorry for the delay. I am very interested about different things in neuroendoscopy since the last years, at least for me, because sometimes I am very noisy about different things in neuroendoscopy, and I learn a lot of things for another specialties, mainly for NT surgeons. And a few years ago, I saw an NT surgeon who employed normally this confocal endoscopy, normally laryngeal process, cancer, and so on. So I tried to learn about that, and this is the first generation of confocal endoscopy, and I tried to use in several tumors in brain, and in the last 3 years, at least in some cases, in pituitary tumors. So I am trying to show that we have no conflict of interest. This is our experience in neuroendoscopy since a long time ago when we started in 2002. Normally, it's very important that we have 120 brain tumors in general and 102 in apophyseal tumors, in pituitary tumors. Mainly, we have 403 assisted microsurgery, but it's very interesting to use because we start a long time ago when the use of cryotherapy inside the endoscope, like in this picture a long time ago. You see one example of very malignant tumors, one pineoblastoma, for example, oligodendroblastoma, and we use the radiosurgery and the radio brachytherapy inside the endoscope a long time ago. And then we thought about is it possible or not to use the confocal endoscopy in the surface of the tumor, like the NT surgeon use normally. For example, use also the navigation, but all the time we must to learn about all of the basic knowledge in neuroanatomy things. A long time ago, the Raymond Wilson Neurografia Universalis, for example, our experience in our laboratory, the experience of Joseph Klinger, for example, we must not forget this normally background of neuroendoscopic knowledge. So the concept of the use of endoscopy since a long time ago is the minimally invasive access to the skull base. It's possible to adapt this confocal endoscopy. The answer is yes. And it's very interesting to see in different approaches how it's possible to reach this tumors or lesions in the skull base from behind and from below, from the front and from behind. It's possible also use the same approaches, and we put, for example, in this case for pituitary tumors, a 0-degree road endonasal endoscope by the use of the craniotomy of the nose approach. It's the same thing using the bimanual microdissection technique of the contact. This is our optic. This is the first generation of the contact optics, was developed by Professor D'Andrea in Portugal, in Lisbon. It's at 0 degrees. It's a common optic, like as usual, it's possible to use normally in all of the endoscopies, in NT and neurosurgery, but you put in the surface of the tumor, and it's possible to see and recognize all of the cells with the stains, perhaps blue methionine, perhaps blue hematoxylin, eosin, and it's possible to see in the surface of the tumor all of the red cells running inside the vessels. But it's possible to colonize the colonization of the vessels and to differentiate with the support of an pathologist beside this of the patient and the surgeon. It's possible to check what happened with the limits of the resection of the tumors. This is one of example, a picture. This is the first generation, but it's very useful up to now. It was during the 90s developed in Portugal. Actually, we have very, very sophisticated but very expensive dispositives to use in confocal endoscopy, like the laser and so on, but actually that's not permitted in the underdevelopment countries. They are in perhaps in probe in Europe, in USA perhaps, but actually we have not. But I think this is very useful to use, and it's possible to use, for example, in this model of cortical glioma. This is one of the examples, the MRI. It's possible to adapt with brand navigation, with all of the tractography. This is part of the possibilities to use in this kind of tumor. You can recognize a lot of cells, malignant cells, that is possible to see perhaps in the middle of the picture. And it's possible to see all of the tracts of the fine matter. So it's possible to recognize in the range of microdissection, and with the brain navigation also, it's possible to recognize the limit of the tumor. This is part of the image when you stop the image with endoscopy during the operation of the brain glioma, hemispheric glioma. Also in pontine malignant glioma, it's possible to use like the posterior approach with, it's possible to adapt the tractography also. You see here the image of the posterior approach. We are very close to the skull base and to the brainstem. So it's possible to use like a common endoscopy. But the advantage is it's possible to put in the surface with stainers to stain the surface and to recognize the limits of the tumor. It's very important to take in mind that actually, unfortunately, we have a lot of different dispositives to use, much more sophisticated than the first generation. But doesn't matter if you have this kind of endoscopy, is possible to use in the same. You see a very nice pictures with this kind of optics. You see here in the posterior approach, also the same picture. This is post-op. But it's very important to see what happened in pituitary tumors. It is possible to see, look in this picture, it's possible to see, to check after the resection, what happened in the capsule normally. A lot of cells around, like in malignant glioma, for example, that's the colonization in the wall of all of the arteries, and it's possible to see. Very interesting to see the red cells running inside of the vessel, of the branches of the hypophyseal, superior and inferior. It's only the first generation of the confocal endoscopy. With the help of the pathology, the side of the surgeon is able to recognize all of the different types and perhaps to check what happened. It's really a complete or not resection with the border limit of the tumor. So it's very, very important that it's possible to have use it. This is normally the same with blue methionine and hematoxylin eosin. Look, this very nice image, the contact with one of the branches of the hypophyseal pituitary arteries. It's possible to see the colonization of the tumor. This is one of the very schematic but very useful schema showing a lot of niches and hypoxic niches and angiogenic niches near to the vessels that is possible to see in the same things like in the confocal endoscopy. This is post-op. This is perhaps to describe the technique. It's possible to use through the endonasal approach also to put and to stain the surface with stainers of the surface of the pituitary tumor. And actually, in the upper, the below part is actually the new dispositives in lasers, for example, and it's possible to put in the surface of the pituitary tumors. So it's possible to recognize the border. You see here, this is the last generation of the confocal endoscopy with laser, and it's possible to check, and like in the infrared images, also to see the vessels. But we must take in mind if you have the first generation of a confocal endoscopy is also useful because the images like here, for example, is very interesting. You see in the video the approach, endonasal approach of the stellar, the pituitary adenoma, and it's possible also to stain the surface and to check what happened with the slices normally in histology. They are in the upper part if you compare with the below part of the slide. So it's very interesting what happened to check what happened with the adenoma, where is normally the pituitary stalk, perhaps the tissue around. I think it's very useful to see these kind of images and to check. This is if you try to perhaps to use very different stainers. This is the images that you can obtain. But I think that if you have at least the images of the left slide, it's okay perhaps to take in mind or perhaps to elaborate in your mind what kind of tumor, what kind of cells are you trying to remove. This is our experience since a long time ago, 44 patients with different kind of tumors, but in pituitary tumors of 23 and 8 in skull-based chordomas, 8 in skull-based meningiomas. The advantages of this kind of multimodality approach is for me at least, is very useful. Normally, you are working not only in the microscopical range, it's micro range for the resolution of the microscope normally, the histological microscope. Perhaps the safety of the resection is perhaps high, and the use of common reactives without complications is the most important thing. It's possible also to associate the fluorescence like the 5-ALA, for example, the fluorescein and ICG, but they are very expensive dispositives up to now. The disadvantages is the learning curve in confocal contact endoscopy. You must to learn like in endoscopy in general. The coordination of the use of micro increases with the Andrea optics is very difficult for the first time, but it's possible to learn. Sometimes blurry images is also possible to obtain, but we must to correct this. And the poor enhance of cells sometimes occurs. So what happened with for example, the use of the fluorescein. If you put the fluorescein and you immediately check with the confocal optic, sometimes you lose all of the images. You must wait at least 10 minutes and no more than 10 minutes. Sometimes it's more spend time for surgeon, but not so much. Perhaps 15 minutes and no more. But it's much more useful than you must spend time for the surgery. This is a very nice work. We have a lot of papers wrote last week for trying to check what happened actually. And if you try to see the bibliography, it's possible to see a lot of different presentations worldwide. In summary points, the confocal microscopy with fluorescence, for example, sodium, sometimes it's possible to display the tissue architecture. The imaging can be used with different fluorescence, like we speaking about in the last slides. And normally we are working in the micro range of the tumor. So we can check the normal tissue around, we can check in pituitary tumors, the pituitary stalk, the vascularization also, and to see what happened with the different kind of cells. improvement in microscopy perhaps can improve in clinician diagnostic accuracy and decision making for the resection of the tube. Thank you very much for your attention.
Our next speaker is Professor Henry Schroeder. I would request Dr. Devpujari to introduce Professor Schroeder.
Well, I think Henry needs no introduction to this audience. He is a well-known skull-based surgeon and quite interested in endoscopy, as most of you already know.
Chandra, may I introduce also Henry?
Yes, please go ahead.
Perfect.
Please
Perfect. Thank you so much. I introduce also, like Chandra said, Dr. Henry Schroeder is our president of the International Federation of Neuroendoscopy, professor and chairman of the Greifswald University, a very well-known neurosurgeon, master, or a lot of people master of me a long time ago, actually master, and every time the master in neurosurgery, in neuroendoscopy. And I'm very proud to introduce you, Mr. President, and our friend of worldwide neurosurgeon and neuroendoscopy.
Thank you for this nice, kind introduction, Alvaro. Thanks for inviting me, Chandra, Moody, to this interesting seminar. Can you see my slides already?
Perfect. Increase the size. Perfect, Henry.
Yeah, it's visible now. All right.
Yeah, perfect.
So Chandra gave me the topic of pituitary carcinoma, a topic which is not so easy because these tumors are very rare. So what is a pituitary carcinoma? You cannot differentiate between an aggressive invasive pituitary adenoma and a pituitary carcinoma. The only difference is that the carcinoma has a metastasis. That is the only definition. Otherwise, from the histological standpoint and also from the clinical image, MRI imaging, it's an aggressive invasive pituitary adenoma. It occurs usually in the 5th and 6th decades of life, and it's an equal frequency in males and females. And there is a nice paper from Bill about the pituitary carcinoma. They made a review of the literature in 2004. So the incidence of these tumors is really rare. It's 0.1 or 0.2% of all pituitary tumors. And at the time of this review, they found about 140 cases reported in the English literature. And the majority of these are endocrinologically active. Most of them produce ACTH or also prolactin, 6% producing growth hormone tumors. Only 12% are null cell pituitary adenomas, which are endocrinologically silent. The latency period until metastasis occurs is very variable. It is 4.7 years in the prolactin producing tumors and around 9 years of the ACTH producing tumors. And the overall latency period has a wide range. It ranged from a few months to almost 18 years. The median is 5 years. So it's a long time. Usually at first the tumors appear as aggressive invasive adenomas, and then they have local recurrences, and only later on they present with distant metastasis. And the site of metastasis are brain, spinal cord, leptomeninges, bone, liver, lymph nodes, heart, and lung. So they may occur everywhere. The presentation of the non-functioning carcinomas is a mass effect, as we see it in the null cell adenomas usually. And if they are endocrine active tumors, they become symptomatic with hormone secretion. The MR imaging of the cellular lesion is similar to invasive macroadenomas, so there's no possibility to differentiate between a carcinoma and an invasive adenoma. Usually they are invading the cavernous sinus. And the MR imaging of the metastasis is frequently very similar to the imaging characteristics of the primary cellular lesion. And if you look at the histology, They have an increased number of mitotic figures. They have increased microvascular density, increased Ki67 and P53 staining, and an increased nuclear pleomorphism. So all signs of an aggressive growing tumor. The treatment, the primary treatment is of course resection. You can use dopamine agonists for prolactin producing tumors, somatostatin for growth hormone producing tumors. And then if there's recurrence or residual in a cavernous sinus, usually radiotherapy is added. And then chemotherapy at that time point was disappointing, but we know now with the temozolomide experience, we have also a chance to treat these tumors with chemotherapy. The prognosis is usually dismal. The mean survival is only 2 years, but also there is a wide range. There are also long-term survivors. But 66% of the patients survive less than 1 year. And the median survival differs between the patients with craniospinal metastasis, which is 2.6 years, and patients with systemic metastasis, they have a worse prognosis with just a survival of about 1 year. There was a publication of the guidelines of the European Society of Endocrinology was published in 2018, and they investigated the effect of temozolomide. And in this meta-analysis, they reported 106 patients, which were included in 11 single-arm cohort studies. And a positive treatment effect was seen in about half of the patients, which is really promising. And they advocate the use of temozolomide as a first-line chemotherapy, and they recommend the evaluation of the effect of the treatment after 6 cycles. And they also recommend, if the radiological progression is demonstrated, that the treatment should be terminated because it makes no sense. The pituitary carcinoma of non-functioning pituitary tumors is rare. There was a nice paper published in 2018 by Lenders, and they reviewed 38 patients. Unfortunately, it's a very heterogeneous group because there are null cell adenomas silent.
Das habe ich online zu die Patients gefunden. Guck mal.
Was quatscht die denn hier zwischen? And they include, yeah, this was Siri, listen to me. And they included a lot of different type of tumors. The only common thing is that they had no endocrine hypersecretion. So null cell adenomas were included, but also silent other tumors. And they found that diabetes insipidus is uncommon. And they said that the carcinomas arise from aggressive tumors, and this continues to recur over several years. Usually they come first with local recurrences, and later on they get metastasis. Very, very rare they found cases which presented with primary metastasis diseases. And there can be a long interval between the primary tumor and the metastasis, very variable. And from the clinical and pathological standpoint, there is no differentiation between benign and malignant tumors. The only difference is this metastasis. And frequently, the metastases have more abnormal histological features of malignization. And also they found when the tumor had an investigation of Ki66 as a Ki65, they found that this Ki67 was with a clear increase when several surgeries were performed in the same patient. So this number was increasing, showing that the tumor becomes more and more aggressive. And also they found that if there is a gain or shift in hormone secretion, that was a kind of malignant behavior in these tumors. And the location of the metastasis was mainly intracranial, intraspinal, but also in liver, bone, orbit, oral, lymph nodes, lungs, kidney, and pancreas. So they can occur everywhere in the body. And if you see MRI and you have seen dural metastasis, they are look very similar to meningiomas, very difficult to differentiate from the image perspective. And temozolomide is the only chemotherapy which has a favorable response. All other chemotherapies are not very successful in the treatment of pituitary carcinoma. The overall efficacy in these cases was only 37%. And the median survival is also very dismal in this group of patients of non-functioning pituitary carcinomas. My own experience is very limited. I have just one case, and I'm not a pituitary surgeon. We have, in my career, I did only about now 400 cases of pituitary surgery. And this one pituitary carcinoma is very interesting, in my opinion. I want to show this case to you. It was a 47-year-old male, and she presented with symptoms of headache, fatigue, and blurred vision. And ophthalmology showed no hemianopsia, but reduced visual acuity in the right eye. Endocrinological examination showed a partial pituitary insufficiency, and MRI shows an intra and suprasellar lesion with cavernous sinus invasion. You see the tumor, it's a similar growth like in tuberculum stellum meningioma. This is a gland. This is a chiasm pushed backwards, and you see this lesion, but you see also the cavernous sinus invasion on the right side. The gland seems to be on the left side. And of course, we advised for surgery, so an extended transcellular, transplanum, transtuberculum approach was planned. Nasoseptal flap was raised, and then at first the sellar part of the tumor was exposed. Then the dura of the frontal skull base is open. You see the arachnoid membrane here, and you see the typical soft red and grayish tumor typical to a pituitary adenoma. So the tumor is removed initially with a 0-degree optic, then we changed now to a 30-degree optic. You see here on the left side the yellowish normal pituitary gland, and then later on we had to change to a 45-degree endoscope to get the tumor out, which is sticking into the frontal lobe. So you see arachnoid plane. We could dissect around. And tumor removal was like a standard pituitary case using curettes, grasping forceps, and now you see tumors on the frontal lobe, and we have to change to a 45-degree endoscope to get really good resection of this tumor. And the MRI shows good resection. You see here the nasoseptal flap. This is a stalk, pituitary gland in the back. So we could get a gross-total resection of the intracellular and supracellular part of the tumor. And histology came back like a null cell adenoma. Ki67 was 40%, as a really high. There was an overexpression of P53, and it was considered to be a high-risk adenoma. And the pathologist asked for metastasis, but at that time there was no metastasis present. After 6 weeks, you see there is residual in the right cavernous sinus. You see the stalk here, and you see this, the gland here, and she was really doing fine. And she was then sent for fractionated stereotactic radiation. She got 29 doses of 1.8 gray. So 52.2 grays total resection. After 9 months, you see a very good response. The tumor in the cavernous sinus on the right side disappeared, and she's still without substitution, as really was doing fine. And then she came for the follow-up 1.5 years after surgery, and we looked at this the area here. There is a normal gland, stalk, no recurrence. So everything looked very good. And she was doing good, has no symptoms, ophthalmology was okay, and she did not need any substitution of her hormones. Then after 2 and 1 year after our surgery, she was diagnosed with breast cancer, and she got chemotherapy. And after 2.5 years, she presented with head and neck pain. Neurological, she was intact, and she was sent for MR imaging. And then she came with this huge lesion at the foramen magnum, a lesion which resembled foramen magnum meningioma. If you look here, the tumor has an extension to the left side, to the right side of the foramen of foramen magnum, and then on the left side as well. On the left side, the tumor went more down and was squeezing the spinal cord to the right side. So it was very surprising finding. But when we looked very carefully to the imaging, which was obtained 1.5 years after surgery, you see there was already a small lesion which was not recognized by the radiologist and also not by us, because we looked only to the primary site of the tumor, but there was already a small lesion. But you see, within 1 year, this tumor was growing immensely. Makes it very unlikely that this is an meningioma. So the question is, what approach should we choose in? There is tumor on the right side, there's tumor on the left side. If you look to this image, of course, you want to make a far lateral approach from the left, because the cord is squeezed to the right side. But then you will not get the tumor on the right, of course. So that's why we made the decision to make a midline approach, because we hope that the tumor has the same consistency like the primary adenoma. And we open here, remove C1, C2, open the arachnoid, and you see this is a typical adenoma type of tissue, very soft. It was encasing all nerves, all arteries, but was respecting the arachnoid plane. So we dissected the tumor away from the nerves and from the vessels. Unfortunately, it was very soft, so it was possible to remove the tumor at first on the right side. Foramen magnum, you see here, the arachnoid is usually very well preserved, and the tumor could be resected. The nerves of the nerve roots of the lower cranial nerves were involved, but also the nerve root of C1 and C2. But with a bimanual dissection technique, traction, counter traction, we could preserve all nerves and we could resect the tumor in a good way. Then there was the tumor which comes from the left side. The dura was coagulated, but the tumor was not very sticky to the dura, not like a meningioma.
Oh, wow.
Here's some more tumor close to the C1 nerve roots. And then you see here, this is a tumor on the other side. And this tumor was, of course, squeezing the spinal cord. And we had only small windows to dissect it. But we opened the windows, and then we were lucky because the tumor was really soft and we could get space simply with a suction and the dissector, get more space, and then tumor could be removed, and we had no changes in the SSCPs and MEPs, so we could dissect the tumor in this area. If this would be a fibrous meningioma, of course, you would not have a chance to get this out from this approach, but we are lucky with our assumption that the tumor is similar to the first tumor. Then I could not look under the cord because of the limitation of the space, and I used the 45-degree endoscope, and you see there is some residual tumor at the ventral surface of the spinal cord. And then we removed this tumor piece, and the final inspection shows no residual tumor and the preserved pia mater of this case. Histology shows again, it was a null cell adenoma. Key 67 was the same as in the first surgery, so there was not increase, what was reported in the literature, and there was still overexpression of P53. And because of the metastasis, now it is referred to as a pituitary carcinoma. And 7 days post-op, she had no symptoms, neurological intact, ophthalmology normal, endocrinology, no substitution so far. And then in the 1 month post-op, we see a good resection of the tumor, a little bit CSF, a fistula, but not no fistula outside of the skin, but just accumulation under the skin. And then after 7 weeks after the second surgery, she got again a fractionated radiation with 45 grays. And this is the image 6 months after second surgery. Looks good. No obvious tumor visible on the MRI. But she had an interesting lesion in the ventricles. It was not enhancing, it was hyper intense in T2 and T1, so it looks like giving a fat signal. And after 6 months image, only one was present, the other was gone spontaneous. So I don't know what it is, but you see here, there is a small dural enhancement. So probably this is another metastasis on the dura. So I think the story will go on for sure, and we have to follow up her very closely. So the conclusion is that pituitary carcinomas are very rare. The definition is just the metastasis, otherwise it's not differentiable from an aggressive, invasive other pituitary adenoma. And the option, what we do have is surgery, radiation, and temozolomide. And still they have a poor prognosis. Thank you for your attention.
Very nice, very nice.
Thank you. Now it's our pleasure duty, my pleasure duty to introduce Professor V.P. Singh. V.P. Singh is the President-elect of Neurological Society of India. He was a faculty at the All India Institute of Medical Sciences in New Delhi, which is the premier neurosurgical institute of India, and presently is working as chairman of neurosciences at Medanta Hospital in New Delhi. Professor V.P. Singh, stage is yours. VP, you have to share your presentation.
Yeah. Yeah, can you see it now?
No, not yet. Yeah, we can see it now.
Right. So thank you, Suresh. Thanks, Chandrasekhar, for your wonderful symposia. I'm going to be talking about radiosurgery for pituitary adenomas. As we know, there are several options, and the decision is based on whether the patient is symptomatic or not, and whether the adenoma is functioning or non-functioning. The non-functioning adenomas usually present when they are large enough to cause pressure effect on the surrounding structures, whereas the functioning adenomas are diagnosed earlier, even when they are small, because of the hormonal manifestations. The primary treatment for pituitary adenomas is surgery. For a non-functional adenoma, surgery is needed to relieve the pressure on the visual pathways and other structures so that the symptoms improve. Functional adenomas, surgery is needed to restore normal hormonal function in the shortest possible time, as the consequences of raised hormones can be very damaging. But the outcomes after surgery are not always fully gratifying. And this is a meta-analysis of a large number of tumors, 5,000 non-functioning adenomas. Only about 45% had a complete surgical removal. Pronactinomas, about 62%, acromegalics, 60%, and Cushing's was the best, and about 71% a complete surgical remission was possible. So non-functioning adenomas have a lower remission compared to functional adenomas, and Cushing's patients had the highest remission rate. Now, what are the options for the resident tumor? If it's a large residual, one should do a repeat surgery and aim for a complete excision. The use of the intraoperative MRI does help in achieving a greater percentage of complete excisions. If it's a functioning tumor and a small part is left, medical therapy can be tried. Alternatively, one can have the options of radiation therapy or radiosurgery, either upfront or used as an adjunct if the resident tumor increases. This is mainly for non-functional. If it's a functional tumor, upfront adjunct therapy would probably be required. Now, conventional radiotherapy does give a good tumor control, with recurrence-free survival to the tune of 85 to 90% at 10 years, which drops by about 5 to 10% as we go into 20 years. But the problem with radiation therapy are the side effects. Hyperpituitarism is seen in a very large percentage of cases. If we follow them long enough, it occurs in about 40 to 50% of cases. And there could be vision problems in some, cerebrovascular complications, or neurocognitive decline. So radiosurgery as an alternative is a good option. It can be given as a single fraction or multiple fraction up to 2 to 5 fractions. There are a variety of machines which can give radiosurgery, and it's extremely useful if the tumor is in the cavernous sinus. However, what we have to be careful about are the vision pathways. The aims of radiosurgery are to control the tumor, stop the growth, and reduce the size if possible. We want normalization of the hormonal hypersecretion. We want to preserve pituitary function and protect the adjacent structures. The vision pathways should be outlined and marked in their entirety, and ideally a 2 millimeter gap is desirable between the top of the tumor and the vision pathways. If this is not possible, then we can deliberately undertreat the part towards the vision pathways. And the planning has to be done in such a manner that the hot spots are away from the vision pathways. The tolerance of the vision pathways is 8 to 10 gray, and the dose that you can deliver is limited by this. The dose given for functioning tumors is 25 gray, and for non-functioning tumors is 12 gray. And this is an example of a pituitary tumor. The vision pathways are near, and you can see that the dose is planned in such a way that the hot spots are away from the vision pathways. Now, what are the outcomes for non-functioning tumors? We have a multicentric study, 512 cases by Sheehan, where a tumor control rate of over 90% is achieved. And the actuarial tumor control at 3, 5, 8, and 10 years is given like this. It keeps on decreasing with time. Importantly, new or worsened hyperpituitarism is seen in 21% of cases. And this is especially so if there's a prior radiation has been given. And new or worsened cranial nerve dysfunction was seen in 9.3%. Another meta-analysis of a large number of cases of non-functioning adenomas. Again, the tumor control rates vary from 83 to 100%. And post-treatment hyperpituitarism seen in 21% of cases. Coming to functional adenomas, let us talk about Cushing's disease and acromegaly. Now, again, I must stress the primary therapy, the primary modality of therapy is surgical excision. And radiosurgery should be considered only for resident tumors or if hormonal normalization is not achieved. In a small percentage of cases where surgery is not possible at all for medical reasons, it can be used as a primary modality also. So what are the outcomes? There are a series of good papers which have pooled data from multiple centers, and as a result of this, we have good, robust data available now. So Cushing's disease, 278 patients with a mean follow-up of 5.6 years. Initial control of hypercortisolism was seen in 80% of cases. Of these, recurrence occurred in about 18%, so a long-term durable control with radiosurgery was possible in 64% of Cushing's diseases. Importantly, the effect takes time to come, and the mean time to normalization was about 14.5 months. Even in patients who had primary therapy, the hormonal control was about 68%. Hyperpituitarism is seen in about 25% of cases, and cranial neuropathy in 3%. What about acromegalics? The same group had studied the 371 patients with acromegaly with a mean follow-up of 79 months. And the actuarial survival was 69%, which dropped down to 59%. So the control rates with acromegaly are not as good as with Cushing's. And the hypopituitarism was somewhat more was about the same in about a fourth of cases. In these cases, it is important to stop the IGF-1 lowering drugs prior to giving the radiosurgery at least 6 to 8 weeks prior, and they should not be started until about 6 to 8 weeks after the radiosurgery. Another meta-analysis of patients with acromegaly, 1,533 cases, at 5 years, the endocrine remission was 43% and endocrine control with drugs was 55%, which actually improved with time. Tumor control is not a problem, but that is not the end aim. What we are aiming for is hormonal control. Again, hypopituitarism occurred in about 1/4 of cases. Now, when should we do the radiosurgery if the primary surgery has failed? And this again, they studied in 255 patients where radiosurgery was done between various time periods after the surgery. And they found that if the radiosurgery was done within 12 months of the surgery, then the endocrine remission was better compared to more than 12 months. And the same could be seen for less than 3 months. So the recommendation is that if surgery fails in controlling the Cushing's disease, then one should go in for early radiosurgery and not wait. In acromegalics, it takes a longer time to get the remission, and compared to Cushing's. So the time taken to remission is delayed, as well as the response is not as good. There are situations where after surgery, the hormone does not normalize. But when we do imaging, we don't see any definitive adenomas. So what to do in such situations? Here we can give a whole cellular radiosurgery and cover the entire cellar. And this was a study of 128 acromegalics. Half of them were given adenoma-targeted radiosurgery. The other half, where the adenoma could not be seen, the whole cellular radiosurgery was given, and the results were fairly similar. Whole cellular radiosurgery has also been tried for Cushing's disease in similar situations, and they found that endocrine remission, time to remission, and new hormonal dysfunction was similar in both the groups. So even if you don't see the adenoma, but the hormones are high, one can give whole cellular radiosurgery. What about repeat radiosurgery? If SRS fails, then repeat radiosurgery has been tried both in Cushing's and in acromegalics. In Cushing's, durable endocrine remission is seen in about half of the patients. And in acromegalics also, the responses are a little less, but 40 to 45% of cases, repeat radiosurgery does the trick. It can be done in pediatric patients also, and this is a study of 24 patients with Cushing's disease and 12 pediatric patients with acromegaly, and the endocrine remission rates were, as expected, higher for Cushing's as compared to acromegaly. There is, as mentioned earlier, if some patients cannot be controlled, cannot undergo surgery because of medical reasons, primary radiosurgery can also be done in these cases. And the endocrine remission rates, again, are better for Cushing's as compared to acromegalics. Comparing radiosurgery with radiation therapy, we have a good German acromegaly registry. where there are 352 patients with more than 4,000 patient years of follow-up. 233 patients had fractionated radiation, whereas 119 had radiosurgery. And if you look at the endocrine remission rates long-term, they are fairly similar for both radiation and for radiosurgery. But the difference is that the time to hormone normalization is much faster in radiosurgery as compared to fractionated radiation therapy. And the chances of pituitary insufficiency for radiosurgery are about half compared to radiation therapy. So the norm nowadays is to give radiosurgery unless the tumor is big, and because of the proximity of the visual pathways, one has to fractionate. What about pituitary insufficiency post-radiation? Now, this is again a multi-center study of more than 1,000 patients comprising non-functioning adenomas, Cushing's, and acromegaly, and the rate of endocrinopathy was 24%. However, if we compare different groups, the new endocrinopathy was about 20% in non-functioning adenomas, 25% in Cushing's, and 38% with acromegalics. 60% had a single hormone deficiency, whereas 40% had multiple deficiencies. Thyrotropin was the most common, followed by gonadotropins. The actuarial rates of new endocrinopathies increases with time and goes up to 30%. And the mean time to endocrinopathy was about 39 months. And it was found on multivariate analysis that the only risk factor of new onset endocrinopathy was prescribing to a lower isodose. Coming to the last part, radiosurgery for prolactinomas. It is well known that the treatment of prolactinomas depends basically on the size and the visual symptoms. Small prolactinomas are best managed by medical therapy, whereas larger prolactinomas with vision compromise are best dealt with surgically so as to improve the vision. Radiation for prolactinomas is not a good option. It should be used only for those who cannot tolerate medical therapy or are resistant to medical therapy and who are unfit for surgery. The type of radiation is decided by the proximity of the tumor to the visual pathways. If the visual pathways do not have a gap, are not separated from the top of the tumor by an adequate gap, then the fractionation has to be done. Coming to the results, this is again a multicentric study, 289 patients with prolactinomas, and the endocrine remission rates were 28%, 41%, and 54% at 3, 5, and 8 years. So compared to the other functional adenomas, radiosurgery is not so effective in prolactinomas, and even after 8 years, the therapy, only about 50%, half the patients get a remission. Again, 25% of patients had a new endocrinopathy and 3% patients had visual worsening. As mentioned for acromegalics, the dopamine agonists need to be stopped prior to doing the radiosurgery. Otherwise, the effect is even more delayed. Proton radiosurgery is also effective, and the results with Cushing's disease, Nelson syndrome, acromegalics, and prolactinomas are very similar to that with gamma knife radiosurgery or cyberknife radiosurgery. However, the incidence of new onset hypopituitarism is much more as compared to gamma knife. So the take-home message that radiosurgery is a reasonable option for residual or recurrent functional pituitary adenomas. The best endocrine remissions are achieved in patients with Cushing's disease. Acromegalics take a longer time to achieve remission, and the remission rate is less. Prolactinoma response rates are generally poor, and new endocrinopathy occurs in about 1/4 of patients. The hormone-reducing drugs should be stopped before the SRS. And as compared to radiation therapy, radiosurgery achieves hormonal remission earlier, and the incidence of hyperpituitarism is about half. But having said all that, the primary treatment for functional adenomas and for non-functional adenomas is surgery, because that gives you immediate relief, whereas even in the best of situations, hormonal remission takes more than a year to come. Thank you for your attention.
Thank you, VP, for your comprehensive coverage of radiosurgery for pituitary tumors. We come to the last talk of the whole today's session. It is by Tejpal Gupta. He is Associate Professor of Radiation Oncology at Tata Memorial Center in Bombay. He is very much involved with Indian Society of Neuro-Oncology, and the stage is yours, Tejpal, for the last talk of the day on radiotherapy for pituitary tumors.
Thank you, sir. Thank you, sir. I'd like to thank Dr. Dev Pujari for inviting me for this wonderful symposium. As the last speaker, I'll try to finish quickly. So Dr. VP Singh laid the stage for radiation therapy in terms of radiosurgery for pituitary adenomas. And now it's my job to talk about fractionated radiotherapy. So I'll just skip some of these slides. We know that pituitary tumors comprise 10 to 20% of all brain tumors, and 1/3 of them are non-secretory, while 2/3 are secretory tumors. The classical indications for radiation therapy for pituitary adenomas include a residual tumor not amenable to further safe resection, when there is biochemical evidence of persistent disease, such as in functioning adenomas, increasingly now for aggressive biology disease, such as those with high proliferative index or atypical histologies, a recurrent or progressive disease, either radiological and or biochemical, and medically inoperable or patient refusal for surgery. The goal of any radiation therapy is to achieve a local tumor control at minimum probability of complications. And in secretory tumors, even endocrine control is also quite important. So you have to achieve normalization of the hormonal excess. This slide shows outcomes of conventional radiotherapy, which was 2D before the 1990s, and then 3D conformal radiotherapy. And if you see, the ballpark figure of progression-free survival at 10 years is approximately upwards of 90%. So for the last 20 years or 25 years, we have good data to show that radiotherapy achieves good local control and control of hypersecretion in pituitary adenomas. However, despite this, the existing dogma is that pituitary adenoma is largely a surgical disease. I'm not contesting that the first-line therapy should be surgery, but despite impressive long-term results from several retrospective single institutional analysis, radiation therapy has not been employed very routinely and consistently for pituitary adenomas. And this stems from lack of evidence from randomized data. Neurosurgeons fear to go in for a redo surgery in a previously irradiated area. There is always this fear of radiation-induced toxicity, and to some extent, lack of awareness amongst neurosurgeons and endocrinologists. In the last 15 years, there has been a boom in the technology as far as radiation therapy is concerned. SRS has been there for more than 40 years. Now, increasingly, newer technologies in the fractionated domain have also been coming, such as stereotactic conformal radiotherapy, IMRT, VMAT, IGRT, robotic RT, and of course now protons and ions as well. So this is in brief a workflow for high precision fractionated radiotherapy, applies to pituitary adenomas as well. So you use a good relocatable immobilization, which is very accurate, tight conformation of your beams to the target volumes. You do a computerized 3D planning. There is a stringent quality assurance and a very precise treatment delivery. This cartoon actually shows that when you increase the number of beams, on the extreme left, the A series is a parallel opposed field, which without any MLC or beam shaping. And then when you employ beam shaping, 3-field technique, and then IMRT technique and a VMAT technique, you see that increasing the number of beams and intensity modulation results in better high dose conformality and improved organ at risk sparing in pituitary adenomas. Which of these high precision techniques to use? Is there a magic answer? And the answer is actually no. And most of these high precision techniques, they actually have very similar dose volume indices. So conventional stereotactic conformal radiotherapy, arc based IMRT, helical tomotherapy, VMAT, and arc based IMRT all provide very simple, very similar dosimetric indices, and they are comparable with one another. So it depends on what is at your disposal, and you're free to choose any one of these techniques for irradiation of a pituitary adenoma. This is outcome data of high precision fractionated stereotactic radiotherapy, either using stereotactic conformal techniques or in recent years using IMRT. And again, you see that the ballpark figure of tumor control rate is upwards of 90-95% at 5 to 10 years. This data is, of course, much less mature than the 20-year data for conventional 2D or 3D radiotherapy. We have been treating at Tata Memorial the non-functioning pituitary adenomas with fractionated radiotherapy, and this is part of the thesis of one of our students. The manuscript is in preparation. So over the last 15 years, 92 patients of pituitary adenomas non-functioning that we treated, 83 of them had local control without any evidence of tumor progression. 9 patients had died by the time of last follow-up. 3 of these deaths were due to local tumor progression, whereas 6 deaths were due to other causes such as CSF rhinorrhea, meningitis, metabolic causes, and 1 head injury. And the overall survival at 5 years and 10 years was 98% and 87% respectively. As far as secretory tumors are concerned, with our colleagues from KEM, this was published in 2016. In a series of patients, 20 patients with Cushing's disease, we achieved biochemical remission in 15 out of these 20 patients at a median of 20 months. Similar encouraging experience with acromegalics. This was also published a few years ago. Biochemical remission was achieved in 55% of patients, 20 out of 36 patients at a median of 60 months. So much longer time to remission as opposed to the Cushing's disease. And this has been borne out in the literature as well, and Dr. Singh mentioned as well with radiosurgical literature as well. So the Cushing's disease, they have a faster time to remission, whereas the growth hormone secreting tumors have a much longer time to remission. Dr. Singh mentioned radiosurgical treatment leads to faster remission as opposed to fractionated radiotherapy, and that is also borne out in the literature. Also, there is a diminished response to radiosurgery on suppressive therapy, and as he pointed out, there is a mandate. It is now recommended to stop suppressive medication 6 to 8 weeks prior to the radiosurgery. So this data previously existed for radiosurgery. Recently, when we analyzed our data, we saw that this was even true for fractionated radiotherapy, and this is just published last year by our colleagues from KEM and endocrine department. So 6 of the 29 patients of Cushing's disease that had achieved an initial remission following radiotherapy developed recurrent disease, and all of these 6 patients had received cabergoline in the peri-radiotherapy period. So now we stop the cabergoline for at least 6 months before we give them radiotherapy for recurrent or persistent Cushing's disease. Dr. Singh mentioned about the closeness of the optic apparatus for radiosurgery, for selecting the case for radiosurgery. So fractionated radiotherapy in that sense is much more liberal. The risk of radiation-induced optic neuropathy is less than 1% with fractionated radiotherapy. And of course, the brain and the optic apparatus being a neural tissue, a fraction size becomes important. So if you use a higher dose per fraction, there is an increased risk of injury to the radiation structures. And as he showed in SRS, a Dmax of less than 8 to 10 gray generally appears safe. So you have to have a 2 to 3 millimeter distance from your target volume if you are intending to do single fraction radiosurgery. Fractionated radiotherapy also has its own share of complications, and this is collated data regarding cerebrovascular accidents following fractionated radiotherapy in pituitary adenomas. And as you can see, not very common, but a mean rate of around 6.7% following radiotherapy. What about second tumors following radiotherapy? And there is an increased risk of second tumors following radiotherapy, and it could be, but generally that is very late. The latency, the mean time period is generally of the order of 15 to 20 years. And younger patients would tend to be at a higher risk of developing a second cancer following irradiation for a pituitary adenoma. There is some debate on this second tumor following pituitary radiotherapy. So this is data that was published a few years ago. These are 236 patients that received radiotherapy and 226 patients that were not treated with radiotherapy, but almost similar number of patients, 31 and 32 patients, and 31 and 22 patients in these group developed extracranial tumors respectively. And when you look at the cumulative incidence of secondary tumors, there was no significant difference between the incidence of secondary tumors in patients who received radiotherapy versus who did not receive radiotherapy. But by and large, most people would agree that a risk of secondary cancer does exist, particularly if the patient is followed up long enough beyond 20-25 years. What about the impact of radiotherapy on on neuropsychological function in pituitary adenomas? So this was a systematic review that was published just last year. So as we can see, there is a high incidence or prevalence of neurocognitive dysfunction, more so in patients with secretory tumors, both as a function of the disease and the hypersecretion, but also as a function of radiation therapy. What about effect of pituitary radiation on mortality? So this is data published 15 years ago, includes most of the older series of 2-dimensional and 3-dimensional radiotherapy. The data from SCRT and IMRT trials is not that mature. We don't have more than 15 years follow-up when the effect on mortality would probably become manifest. But from the older data, we do see that there is an increase, statistically significant increase in all-cause mortality, which is predominantly due to second malignancies, circulatory and respiratory, as well as cerebrovascular accidents. So there is an effect of increased risk of mortality due to pituitary irradiation long term. So can one safely defer radiotherapy and offer it at progression in non-functioning adenomas treated with subtotal resection? So this is data on 126 patients treated with subtotal resection and observed initially. And nearly 40% of patients had progression within 5 years, requiring either redo surgery followed by radiation or salvage irradiation. So the 5-year progression, freedom from progression is only about 60%. So can we make pituitary RT safer? And the answer to that is possibly yes, by using the newer techniques, as well as by using something known as hippocampal sparing pituitary radiotherapy. So this is data from our own institution. We have a prospective phase 2 study of hippocampal sparing radiotherapy in pituitary adenomas, and we have been doing serial longitudinal assessment of neurocognitive function and quality of life assessments. This data was presented at the Astro a couple of years ago. The manuscript is presently in preparation. So what we saw was there was no significant worsening of neurocognitive function and no impairment in quality of life in the short term, which was at 3 years. But of course, this data needs to be mature, and if it holds true for 5 years and beyond, then hippocampal sparing pituitary radiotherapy would become the standard of care for fractionated treatments. Dr. Singh mentioned about proton radiosurgery, but you could use protons for doing fractionated treatments as well. And just by the sheer physical characteristics, you tend to spare much more normal tissues. And now increasingly they are becoming available, including the first proton therapy center in Apollo Proton Cancer Center in Chennai. Coming to the last part, this is from Miniti's group, the risk-benefit ratio of radiotherapy in pituitary tumors. So what should be the research agenda going forward in the next 5-10 years? So we need more studies to investigate the relationship between doses to the pituitary gland, the stalk, and development of hypopituitarism. As Dr. Singh mentioned, new onset endocrine deficiencies are almost 40% with fractionated radiotherapy, and of the order of 20 to 25% with stereotactic radiosurgery. The safety and efficacy of different dose fractionation schedules also needs to be explored in clinical trials. And in the last few years, hypofractionated radiosurgical treatments using 25 gray in 5 fractions, so 5 gray times 5 fractions have become increasingly common. And we propose to do a randomized control trial of that versus the 5 weeks of fractionated radiotherapy. That protocol is being developed, and possibly in the next 6 months, we will start that trial. We need to identify molecular markers that predict tumor aggressiveness and rapid recurrences such that those patients can be treated more aggressively. And we need to define the efficacy of different radiation techniques on the normalization of hormonal hypersecretion in secretory adenomas. With that, I would like to end and invite all of you to our annual meeting on evidence-based management of cancers in India. The theme is Technology and Cancer Care, Promise and Reality of the Brave New World. Thank you for a patient hearing.
Thank you, Tejpal. Can you unshare so that
Yes,
we can have some discussion? So we have reached the fag end of everything, and but for the discussion, and let me ask some questions to the speakers. And we learned a lot about pituitary today. So we learned about invasive tumors, we learned about aggressive tumors. We came to know that atypical pituitary has been removed. We have heard about pituitary carcinoma, but one thing we didn't discuss was pituitary blastoma, which is a new term which has come. And we also learned about various modes of therapy, radiotherapy and radiosurgery for pituitary tumors. My question to Akansha and also to Professor Schroeder, what about MGMT status for patients receiving temozolomide? We know that there is no promoter methylation as occurs in GBM for pituitary tumor. So has levels of MGMT any implication on response to temozolomide?
So we have only rare patients, and if we have a patient who is considered to get chemotherapy, we have already done surgery, we have already done radiation, so there's no other option. So for me, it makes no sense if MGMT is methylated or not. We would start with temozolomide because we have no other options.
Okay, so pituitary carcinoma, as you have told, it forms only 0.1% of the tumor. So, and also you told that 37% of the patients only respond to temozolomide for pituitary carcinoma. How long will you give that treatment, temozolomide? For, we know GBM we give for 6 months after concomitant chemo and radiotherapy, 6 cycles of temozolomide. Here for how many months? 6 months or 1 year or lifelong?
Suresh,
So to answer the question about duration, the literature has ranged between 9 to 12 months of treatment with a 5 days on, 21 days off cycle. In our practice, we use we go up to 12 cycles if the patient tolerates it. It will depend on the bone marrow status. There's still some controversy on the duration of treatment. There's some studies to show that the longer the treatment, the more durable response, as long as 30 months or 36 months. But there's yet to be a randomized control trial to differentiate the different doses. And in terms of the MGMT, there is currently, they have looked at the MGMT in some smaller papers to see if there's improved response, and we haven't seen any difference. So there doesn't seem to be a correlation.
Okay, but I think low levels of MGMT, they have a better response. That's what I have read. I don't have any personal experience. Is there any particular subtype of pituitary adenoma secreting tumors which responds to EGFR inhibitor, or everything will respond? Again, Akansha, you can answer.
Yeah, the EGFR
inhibitors. This type.
The data is really early.
Say, is it the prolactinoma?
Yeah, so it's been looked at in prolactinomas mainly. And the data is very early. There's only been a few case series, and the phase 2 trial that I mentioned was only 9 patients. And so there's very limited data right now to really draw, I think, larger conclusions.
And how about response to a combination of temozolomide and Xeloda for pituitary carcinoma?
Yeah, so there's a trial going on right now for recurrent disease and pituitary carcinoma at Cornell. So we should hopefully have the results in the next year, but that's combining capecitabine and temozolomide. In case reports, it's shown some response, mainly with stability of disease, not so much with regression.
I think Professor VP Singh and Tejwal, they covered everything about radio surgery and radiotherapy. I don't know what doubt. There is no questions to be asked there.
I would like to ask one question, Suresh.
Please, please.
What is the role of temozolomide in not pituitary cancer, but otherwise aggressive tumor? I mean, 2 surgeries, radiation, the tumor is still, recurring.
Yeah, so it's been used actually in all types of adenomas, not necessarily carcinoma. So in pituitary adenomas, response rate has been 50% if you look at radiographical regression, and up to 80% if you include stability of disease. So we'll use it for tumors that have failed surgery, as Dr. Schroeder mentioned, and who have had recurrent disease after surgery.
So
yeah, I completely agree with Dr. Sharma, because there is no difference between a pituitary carcinoma and an aggressive invasive adenoma. So if you have all options, temozolomide is that what we have.
Okay,
it's a gliding scale, and indeed, as Henry presented, was the moment there is metastasis, we have to consider that as being a carcinoma. And the cases I have seen were mainly, and that was odd, not only the Nelson tumors that can be very aggressive, but also prolactinomas. Sometimes they present really with very distant metastasis, spinal, even somewhere in the body. That's and if you look to histology, the pathologist cannot even say that they are malignant. But the moment you have these distant metastases, we have to treat it as a carcinoma.
Okay. So, any other questions from anybody who are still awake in
Yes,
this?
I have one question about radiotherapy, because my radiotherapists, they always say that the fractionated radiotherapy is more protective to get a good pituitary outcome regarding normal pituitary function. And gamma knives, that means high doses at one time point, will not spare the normal pituitary gland. But you or some of the speakers presented different opinions or different results that the gamma knife is better than the fractionated therapy, which is surprising to me. So what should we advocate to the patients, radiotherapy or fractionated radiotherapy?
VP, can you answer? VP Singh. VP, you're still there. VP Singh.
Right. Most of the literature says that radiosurgery actually gives hyperpituitarism in about 1/4 of cases, which is about 20 to 25%. Whereas with the fractionated radiation therapy, the incidence is much higher, 40 to 45%. Tejpan, would you agree with that?
Yeah, so I did mention the same thing, and I think Dr. Henry, the fractionated radiotherapy is much sort of liberal or much safer as far as visual pathway is concerned. The risk of radiation-induced optic neuropathy is almost zero. I mean, we put the figure as 1%. I think I have never encountered optic neuropathy with the dose that we give for in fractionated radiotherapy for pituitary tumors, 45 gray. Even for secretory, some people give 50 gray, but you will hardly ever encounter that. I think when we counsel our patients, it's important to understand the relationship of the tumor with the optic pathway. So as Dr. VP Singh also pointed out, he put a gap of 2 millimeters. Personally, I would not give anybody radiosurgery unless the gap is of 3 millimeters or more. So that if the tumor is abutting or within 3 millimeters of the optic pathway, I don't think radiosurgical treatment makes much sense, because then the risk of causing radiation-induced optic neuropathy becomes significantly high, particularly with single fraction radiosurgery. I think increasingly we are moving towards a hypofractionated radiosurgery, which is 1 week of treatment, 5 fractions of 5 gray each, which is much not as harsh on the optic apparatus, as at the same time will probably also reduce the incidence of new onset endocrinopathy. So the literature clearly shows that new onset endocrinopathy is lesser with radiosurgical treatment.
Right, good. I will talk to my radiotherapists. They should read the most current literature. All right.
Okay, so any other questions from anybody?
Any comments, Dr. Chaudhary? Your co-chairperson, I don't know if he's still around.
On one, may I ask? On one hand, this is Turel.
Yeah. Your voice is very.
On one hand, we have the effect of the side effects of radiotherapy that you are discussing. But on the other hand, we want to see what is the effect on the tumor. So are they? Sometimes we know in medicine that when you have some strong effect on the disease, you also have a similar strong effect on normal tissues. So are we discussing the bad effects of radiation therapy or the good effects of radiation therapy?
I think, KK, it was discussed by both the speakers. I think they told about the side effects of both radiosurgery and radiotherapy.
No. So are we? What about the tumor? What about the effects on the tumor? Are these beneficial effects or they are not beneficial effects?
So there is no denying that the local control is upwards of 90% in non-functioning pituitary adenoma, and the hormonal biochemical remission rates varies from 55% to 80% in secretory tumors. So of course, that is why either radiosurgery or radiotherapy is being offered to these patients. But every treatment comes with a price, and that's what we have to be aware of, and let our patients be also aware of that to make an informed choice.
Okay.
I think we have
time for red wine now. All right.
Yeah.
You already. You have this already. But it is good. It is, at least in India, it is way beyond midnight. But here in Europe, this is a good time. Henry,
it's 1 o'clock. It is close.
I have to look for it.
1 o'clock in India.
Chaudhary has any comments? Otherwise, I think Suresh, it is time for us to end the day's session.
I think we have to sign off by saying good morning to my friends in Asian continent, good night to my friends in Europe, and good afternoon to friends in American continent.
Yes.
I think we are meeting at 1:30 Indian time tomorrow for the second day of wonderful meeting.
Tomorrow.
GMT.
All right.
Very
good. Over to see you soon. Cheers.
Very good to see you. It was a great day. Thank you so much for everything. Yeah.
Thank you, Andre. Thank you. Bye.
Thank you so much for all. Bye-bye.
Bye.
See you tomorrow.
Bye. Bye-bye.
Bye for now.
Bye, Chandra.
Thanks.
Bye.
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 Beard is